Are those your jazz hands? Yes. Now I see Senator Petty. I can recognize the faces. I just can't read names. So welcome everyone. Who else? Oh, is that Hildebrand up there? Hello there. Okay. As long as I can see the faces, we're good here. Welcome everyone this morning to the KanCare Oversight Committee. And we've got a pretty good day. I think the big change that we had on our schedule was extending the lunch hour a little bit with some meetings that happened to come up for some folks. So we will start off our presentations with Matt Fletcher with InterHab. Good morning.
Good morning.
Welcome. Oh, good. We can see your face. Thank you.
Thank you, Madam Chair. Press the button.
Is there a green light on there or blue light?
Blue light.
Okay, we're good.
Okay.
I'll get a little closer to you.
All right. Thank you, Madam Chair, for the opportunity to speak with you and members of the committee this morning on behalf of InterHab's members who serve or arrange to provide services to Kansans with intellectual and developmental disabilities across our state. When I last appeared before this committee in June, I gave an update on our providers' response to COVID-19 and the challenges that they were facing in keeping Kansans with IDD healthy and safe during the pandemic. I'm happy to report that there are some relief sources that are now being made available to Medicaid providers here in Kansas. Some of those relief sources are federal in nature. Others are being steered through state departments, and I believe you'll probably hear some updates from those departments during your committee hearing today. However, it's important to note that the relief sources and the funding the way it has been set up and the strings that are attached to those relief sources are such that it's important that you know that those relief funds will not make providers whole for the losses that they have endured during the last several months of the pandemic. They are incredibly helpful and they're a lifeline in many ways, but they will not make those providers whole for the losses that they've incurred. In addition to that, our providers are still, and this is amazing to note this, but still several months into the pandemic, having difficulty accessing necessary resources such as personal protective equipment and most importantly, virus testing. And that's something I wanted to bring to your attention today in particular, because I do believe that as we're heading into the fall and winter months, we are going to see an increased challenge for human service providers out there in our communities. And in many communities, especially rural communities, finding these virus testing resources remains a very difficult task, even as we stand here almost in October. So, I think as we get into the fall and winter, we're going to have a lot of cases of flu. We'll probably see COVID continue to be an issue here in our state. And the ability for providers to test their staff and to test persons that they provide support to and to get those tests back in a timely manner, it's absolutely critical to continuing to keep folks healthy and safe as we move into the fall and winter months and into 2021. I'll just wrap up my testimony this morning by pointing out some general funding needs that continue to plague the IDD system. And in some ways, we were dealt a pretty significant setback regarding those in July with the governor's allotments. The work that the Kansas Legislature did during the spring of 2020 is very much appreciated by IDD providers. A 5% reimbursement rate increase was included in the budget that was signed by Governor Kelly at the end of March of this year. And providers really needed those funds, so much so that they had already incorporated those funds into their budgets and in many cases had notified staff of wage increases that they were to receive come July. Well, just a few days before the beginning of the new fiscal years, those funds were swept as part of the allotment response. We certainly understand the governor's very difficult decisions that must be made on behalf of the state. But we would urge that during the 2021 session that we have some substantive discussion about restoring those funds, as they were really a critical lifeline to the IDD system. With that, I'll stop and answer any questions if you have them.
Okay, I think what we'll do, Matt, is we'll wait till we get through everybody and then we'll come back on our questions committee. So, make sure that you have those documented what you want to ask. Thank you very much. Next, we have Nick Woods with Interhab. I love how you guys tag team. That works good. Welcome to the committee.
Members of the committee, can you hear me?
Did he leave it on for you? Is there a blue light?
There's a blue light.
All right.
So in my role as Associate Director at Interhab, I do a lot of work with our Complex Needs Task Force. We're always looking at issues and costs and systems problems and gaps and barriers regarding people's medical health needs, behavioral health needs, and age-related conditions. A lot of people with IDD are living longer these days, and that's a wonderful thing. There's also unprecedented numbers of people living in the community versus institutions, as there were, just 10, 20 years ago. And that's terrific. But they have a lot of issues and health conditions that have to be addressed now in the community that maybe back in the old days used to be taken care of in our state hospitals. But we've sort of broken it down by trying to address needs or system improvements related to behavioral as crisis response, and being able to provide in the moment, on the scene crisis response to prevent people from having to enter more restrictive settings. We're also very interested, and a lot of our members already do this sort of informally, where they have their own health clinics, essentially, where they're coordinating a lot of community-based medical care. They have their own nurses. They do a lot of interaction with doctors directly. A lot of people with IDD get their health services through their provider, not necessarily the doctor's office. And that takes a lot of coordination and a lot of expense. Just to give you an idea, the figures that are used internationally for IDD are that the people with IDD are between 1% to 3% of the population. So in Kansas, just 1% would be 29,000 people. And of course, on our DD waiver, we only serve about 9,100, and there's about 4,000 on the waiting list. So that gives you an idea that there's a lot more people out there with IDD. They're just maybe not at the most risk. So, and of that 29,000 or so, 85% have a mild form of disability, intellectual disability. And then only about 5 to 10% have the more severe to profound level of disability. We do break it down that way because we understand that just like the general population, maybe 5 to 10% of the population in IDD drive up to 50% of the costs for their medical and behavioral health care. So we're looking at that. We're going to be talking with you during the session a lot more about these system improvements that I think would just make our system a lot more efficient. It would take care of a lot of problems that I know our state agencies and our MCOs and providers everywhere constantly struggle with. So look forward to having those conversations.
Thank you very much. Next, we have Holly Noble, Legislative Committee Chair of the Kansas Adult Care Executives Association. Welcome to committee.
Thank you. Happy Monday morning, right?
Yes.
Thank you very much for the opportunity to share the many concerns our Kansas nursing homes are facing. Our long-term care system is currently in a state of turmoil. The following firsthand issues have all detrimental effects on our elders. First, mandatory testing has left us with staff resigning or taking leaves as absences. Close to 50% of our members who responded to our survey have reported a loss of their staff due to their refusing to testing. Also, testing costs between $5,000 to $20,000 for just one round of staff testing. For homes in red zones, testing twice a week, you can only imagine what their bottom line will be at the end of this year. Affordability of the ongoing cost of testing is also not realistic. It will only lead to further financial strain on an already fragile system. We have homes in Kansas that have yet to receive a machine for in-house testing, making them reliant on outside vendors to come to their facility or having to send their test out. These facilities are spending more per test for testing for those who have in-house machines. Even homes having machines are having a difficulty of getting the materials that they need for their machines. These homes are also becoming reliant on outside labs for testing of staff, vendors, and even volunteers, all creating additional costs to our already overburdened system. Then there is a shortage of critical PPE and sanitation supplies for enforcing homes to get creative in finding our supplies. When nursing homes are forced into allotments, it is a recipe for disaster. Not only is it hard to get the needed PPE, but it's also difficult to get the needed quality. We need to help to obtain appropriate PPE, ensuring we can keep our elders safe. Sustainability is also a next huge concern that we have. Some homes are on the verge of a no return. Many of our members are saying they have a 6 to a 12 month of financial sustainability, and that could impact our state in the form of receiverships. This is largely due to knowing that all funds will cease and not roll over or even be addressed for additional assistance in 2021, which has left many homes questioning how long they'll be able to keep their doors open. The sustainability of adult care homes to operate under the financial, regulatory, and medical safety practices required to keep our residents safe is currently unknown. Now is the time to step up, and we need to have a plan for a secure future for our elders. The challenges of COVID-19 have created a very stressful environment for our members, our staff, and our residents. Finally, funding. The 1% overall increase in fiscal year that was budgeted for 2021 was rolled back. Homes are already facing greater loss per day of care than last year. And with the talk of cuts next year, we are looking at compounding all these problems should cuts of long-term care actually be made. We thank you for everything you guys have done, and also want to thank you for your time. And we understand that you may not have answers that we are so desperately needing right now, but we do sincerely hope and strongly encourage that you search for some answers soon in order to help us find solutions to these concerns. Thank you.
Thank you very much. Appreciate it. Next, we have Tanya Dorf-Bruner, Executive Director of Oral Health Kansas.
Hi, Madam Chair. I'm on Zoom. Can you hear me?
I'll get you switched back here in just a minute, I think. I don't know who's doing that. Huh? If you want to go ahead, Tanya, we can hear you. We're just not seeing you, so.
Okay. All right. Yeah, I can't figure out. Oh, wait. Nope, the video, for some reason it's not going, but I'll just go ahead. I do thank you, Madam Chair, for the chance to visit with you today, and thank the committee for the chance to participate by Zoom. So again, my name is Tanya Dorf-Bruner. I'm the Executive Director at Oral Health Kansas. We're the statewide advocacy organization, kind of the consumer advocacy organization for oral health. We want to do a few updates for you today on a few issues we've been discussing over the last few months, and just tell you where things are and elevate a couple of issues for you. First of all, was the dental reimbursement rate that did pass during the 2020 legislative session. We were really pleased that this committee was a big supporter of that $3 million rate increase. We know that was one of the critical update for the state, and is going to go a long way towards making sure the dental provider network is more ready to meet the needs of people enrolled in Medicaid. Sorry. So we did submit some public comments to the agency back in August. They said that a state plan amendment was needed in order to, it says, hang on. Sorry, I got to pop up there. Sorry. An agency said a state plan amendment was required to implement the rate increase. When we negotiated with the previous Medicaid director, and we worked with the Kansas Dental Association to figure out the best way to implement the rate increase in order to target the codes that would have the best chance of expanding the Medicaid dental provider network. So then the agency issued a state plan amendment. We provided some public comments about that. The state plan amendment did appear to leave off several codes that had been targeted for the rate increase. And one of the most important codes that we'd really like to call your attention to today is D9420. It's hospital calls. We receive a lot of calls from families, especially families of people with disabilities, expressing frustration that they can't find a dentist that has hospital privileges. Frequently, a hospital is the only place that people with disabilities are able to get sedation dentistry and get what they need taken care of. So this code D9420 increases a dentist's ability to provide sedation dentistry in the hospital setting. We did a survey actually of states across the country to figure out what the rates other Medicaid programs pay for that code is. And Kansas's current rate is about the lowest in the country. So we were really pleased that we thought that rate would be able to be increased. You've got in your testimony there a full list of the codes that were missing from the state plan amendment and that we think do need an increase this year. Again, these are rates that we worked with the Kansas Dental Association and the previous Medicaid director on. So we did submit comments. We did contact the Division of Healthcare Policy, Healthcare Finance to raise our concerns. And today we just really wanted to elevate the importance of including these codes to the committee's attention. The next thing I want to discuss briefly is some dental research studies. And you may recall that Oral Health Kansas has referred to a couple of dental studies in the works at previous KanCare Oversight Committee meetings. We're excited to announce that by next month, we'll be able to release a report in conjunction with the Kansas Health Institute that is studying the number of Kansans who have dental insurance and the number who have unmet dental needs. The report should be finalized, by the end of October. We'll be able to debut it at our conference on October 30th. It's going to include some future policy and some research implications to improve oral health in Kansas, and we're excited to be able to share that with you as soon as it's available. We also are continuing to work with the American Dental Association's Hospital Health Policy Institute on a study that would estimate the costs and the offsets of introducing a comprehensive adult dental benefit in Kansas. So that report should be finalized by the end of 2020. And again, we look forward to discussing that with you in future meetings. The final issue we wanted to bring up today is teledentistry. So as you all know, when the pandemic hit, the CDC recommended dental offices close for all but emergency procedures. By the week of April 6th, about 95% of dental offices were closed, but 82% were able to provide emergency services. The biggest issue at that point was consumers knowing what was a dental emergency. So we put out some guidance for consumers to understand what emergency was, and people found that to be helpful. By May 4th, dental offices were opening again, but they were opening slowly. So all this led to the KDHE authorizing 2 KanCare dental codes to be able to be provided via teledentistry through June 30th. And that really helped Medicaid dental providers and patients get through that initial phase of the pandemic. So the purpose of teledentistry is to triage needs. You obviously can't provide any dental services by Zoom or by the phone. That's not possible. But dentists can assess urgency of needs. They can prioritize patient needs. They can even soothe patient worries. And that's really kind of a big deal because aerosols are produced in dental procedures and the coronavirus. Yes.
Okay. Your time's actually up, hun.
Oh, I didn't know we had time. I'm sorry.
3 minutes.
I didn't hear that. I'm sorry.
Well, I did not say it. So those on Zoom probably are not familiar with it. And
Got it.
Dave's been trying to hold up the sign and get my attention. So we're good.
Oh, got it. Well, I'll just say the one last sentence I would say is teledentistry, long story short, you can read the testimony. It's not authorized right now. And we would really ask that the committee consider including a recommendation that the Dental Practice Act be authorized or be amended to authorize teledentistry next year. So I appreciate your time and I'll stand by for questions. Thanks.
Thank you, Tanya. Next we have, is it Sean Balky or Balk? Balky, all right. President and CEO of Craig Home Care. Welcome to committee.
Morning, Madam
I
Chair.
don't know why I have trouble every time with your name. I just,
Okay. Ball and key, just try to,
Balky, okay.
there you go. So, good morning to everybody. Thank you for the opportunity. 3 minutes isn't a lot of time, so I'm going to get right to the point. Most of you are very familiar with me, familiar with the issue that I'm going to talk to you about, so I don't have to give you a lot of background. I'm tag teaming this a little bit with my colleague, Matt Johnston with Maxim Healthcare Services today. But I wanted to set the stage really more than anything of where we're at with this issue. We're here to continue our request for an increase to the specialized medical care rate in Kansas. It is grossly underfunded. It does not allow for the adequate provision of services to the most medically fragile and complex children that need this medical care in the state of Kansas. And we think we have a good solution for how we can address this. We had really good progress last year, really over the last 2 years. To be frank, we have been very collaborative with both KDADS, KDHE, this committee, the governor's office. We've engaged everybody that we felt like was really necessary to get this thing moving. We had some good success last year. We didn't get where we needed to get to. We got some movement. We got from where the rate was to what was recommended of $37 an hour for the service. Wasn't going to get us to the 47 that we felt like is adequate, and what really everyone agreed to was an appropriate rate, but it was progress. Well, Obviously, no one anticipated COVID. No one anticipated what was going to happen with the budget. So we didn't get that money either. So now we're at a situation where, like many other providers or all other providers in this industry, we're challenged. We have additional cost increases that range from personal protective equipment that is so much more expensive. There's so much more of that now can you imagine all these immunocompromised children, right, that are needing these services? I mean, it's not just even someone who's maybe high risk. They can't even take a vaccine, right? There's so many aspects of the level of care that require so much more PPE in our world. In addition to that, we have to increase wages. We had to pay a tremendous amount of overtime because we have so many nurses that are trying to cover these hours and trying to do so when we have a shortage out there. Service interruptions, like many other providers, we have a lot of quarantines. We have a lot of situations where we cannot provide the services that are authorized. The expectations standards have been raised. Now, this is what we've seen asked of us from acute care hospitals for discharges, and what we're going to be expected to do going forward has upped the game, and it's not going to go away when COVID goes away. This is going to be the new standard that we're going to be expected to comply with. And very similar to Matt's Fletcher's point earlier, the CARES funding that's is supposedly out there to help providers is going to be, from what we can see, the attestation form for providers. I don't know if this has been brought up before. There's some restrictive elements to that make it pretty much impossible for providers to access those funds. My colleague and I will probably be able to access maybe 5-10% of what is allocated to us as a provider because of the way the attestation form reads and the restrictive nature of what's included in there. So that's not going to be any help either. So we need help with this service. We think we have a solution that Matt's going to go into great detail in 3 minutes to cover with you of what we feel like we have now, because we have more data. We have a lot more access to what the costs truly are out there. And we think we can make a really solid case that this increase will end up saving the system money now, this year, if we could get something implemented. Thank you.
Thank you very much. Appreciate it. Next, we have Matt Johnston with Maximum Healthcare Services. Welcome to committee.
Thank you very much, Chairwoman. Committee members, I appreciate you.
I flipped my glasses off and I broke 2 pairs because of that, so.
Well, no, I appreciate you letting me speak, and thank you very much, Sean. I got tasked with the technical portion of this, which is great, so I'll try not to bore you to death. Last committee meeting when we testified, this committee tasked the provider network, KDHE and KDADS, to really start answering some of the questions you guys have posed over the past 2 years. That was our goal. I really wanted to thank KDHE, KDADS. There were so many people who helped, but specifically Sarah Fertig, Chris Schwartz, Derek Hayes, Janice DeBoer, Michelle Hayden, Amy Penrod, Brad Ridley, and several others who helped us gather all of this information so we can really start answering some of the questions that you had. I'm here today to present those findings. One of the questions was, what is specialized medical care actually cost throughout the entire state? We used 2019 as the data set because who knows what 2020 is going to bring. So 2019 is what we used for all of our data sets. The program costs with both IDD and TA waiver participants, $45.5 million in 2019. Another question that was posed was, how many hours is a participant actually receiving? The KDHE estimates that Adam Profit had used 168 hours a week, which is 24/7 on a long-term basis. That's just not the case. We were able to find that the average recipient is about 53 hours per week. So we were able to determine, a better cost per participant with knowing that it's only 53 hours instead of 168 hours. We also were looking at the hospitalization costs. That's really where we can find a way to make this increase revenue neutral, or not only revenue neutral, but possibly cost savings for the state. This was staggering. The specialized medical care recipients from 2019 comprised of over 95,000 hospitalization days with a cost of over $1.5 billion. Knowing that the program costs $45.5 million to keep them in their homes, and knowing the staggering cost of hospitalizations, the cost savings is for sure there. Another question that was posed by this committee is, private insurance. All hospitalization days aren't necessarily going to be cost savings because there could be another provider than Medicaid, another insurance than Medicaid. We did find out about 42% of specialized medical care recipients do have a third-party liability or a primary insurance that might cover costs that would not cover costs. Doing some math, and I won't bore you with it, we reduced out what the possibility of the third-party liability or the primary insurance would cover. Even reducing out those costs, it would be a reduction of 2.5% of hospitalization days, which would be under 1,400 hospitalization days to not only cover the state general funds, but also cover all funds it would cost for the increase to $47 an hour. If we were to just look at the $9 million estimate of state general funds of what it would cost, that's a reduction of 566 days in the hospital. I know that there's patients who are stuck in the hospital for 3, 6, 9 months, even a year sometimes. 566 hospitalization days to make this revenue neutral. We don't have exact figures. We can't say which ones would be able to be reduced, but it is very, very low number that in our mind. We also have created a way that we can track this data year over year. What we worked on is a sustainable model that we could use these numbers as a baseline to continue to look forward. This increase would be there to recruit, train, and retain our nurses to work in the home setting instead of in other like healthcare facilities that are able to pay way more than we are right now. And I got my stop sign, so I apologize if I bored you with numbers.
No, we never get bored with numbers. We like numbers. So thank you very much. Appreciate it. Next, we have Leslie Anderson, Executive Director of the Kansas Association of Area Agencies on Aging and Disabilities. Welcome to committee.
Very much. Good morning, everyone. It's good to see you again and good to see that you're all healthy. I'm here representing the network of the 11 area agencies on aging throughout Kansas. And you have my written testimony, so I'm not going to read it. It would be redundant, and you guys have a lot of things to do. So I do want to talk about the high touch level of assistance that the AAAs have been able to carry through during the public health crisis through innovation and the use of telecommunications. And thankfully to KDADS, that has been a reality to help further the mission of the AAAs and allow people to access services faster and consistently. So through telecommunication, the AAAs have been able to continue the work of the ADRC and the other programs that they have, doing assessments and information and referral assistance and options counseling and the administrative case management services. So if you remember in 2018, the legislature appropriated funds to create the administrative case management services. And unlike targeted case management, this serves to explicitly provide assistance to individuals who are eligible for the BIFEPD waivers and the PACE program. So they help with filling out the applications and getting documentation to make sure everything is together to submit that accurate application, and then help with the follow-up necessary until they are completely eligible for services. So the very first month, which was May, the ACM served 113 people. Last month, it was 376. So we can see the need is escalating. Don't know if it's through the public health crisis or it's general need. But in this time of uncertainty, it's very important that this service is available to people. Since 2012, the ADRC has had a statewide call center, and that is through the Central Plains Area Agency on Aging in Wichita. And there was about 436 roughly contacts during the last 6 months, and that's 11,885. So you can see that that is a continued need to help people understand and to access services and information on Medicare, Medicaid, transportation, nursing home assessments, and of course now COVID-19. The last program I wanted to touch on is the new program, and that is through a collaborative partnership between KDADS, the ADRC, Assistive Technology for Kansans, and the Centers for Independent Living, where we intend to transition 35 individuals from institutions back into the community with high-touch services, starting with an assessment for the social determinants of health, and do some critical case management through that process to ensure their health, safety, and welfare. And we do appreciate KDAD's acknowledgement that transition is necessary in the state. Lastly, to mitigate the adverse effects of COVID-19 and to respond to the continued and growing need, we have made some recommendations, and in a nutshell, we're just asking the committee to evaluate the infrastructure, support initiatives and pilot programs, and ensure the Aging Network has consistent involvement in all of these initiatives. There's always an aging perspective to decision-making, and we ask that that be considered. Thank you so much, and I will stand at the appropriate time for questions.
Thank you very much. Appreciate it. Next, I have Kyle Kessler, Executive Director of the Association of Community Mental Health Centers of Kansas. Welcome to committee, Kyle.
Thank you, Madam Chairwoman, members of the committee. I'm Kyle Kessler, Executive Director at the Association of Community Mental Health Centers. We appreciate the opportunity to appear before you today to visit briefly about the effects of the pandemic on the mental health of people in our state and country, and provide some possible solutions to help make sure that our system is at capacity when more people emerge who need help addressing their anxiety, depression, and trauma that has been triggered. A report from the CDC that was released about a month ago identified higher levels of adverse mental health conditions, substance abuse, and suicidal ideation compared to the same time period of April through June in 2019. Nearly 41% of respondents reported at least one adverse mental health or behavioral health condition, including symptoms of anxiety disorder or depressive disorder. 31% had symptoms of trauma relating to the pandemic, and over 26% started or increasing use of alcohol or drugs. For context, the prevalence of symptoms of anxiety disorder was approximately 3 times more than the same period in 2019, and depressive disorder was about 4 times higher. Several items have emerged that would assist CMHCs and other providers with doing their work. Some are as follows: approval by Medicaid to allow therapy to be billed without patient being present. This is Medicaid code 90846. And I don't believe we've talked with this committee about this before, but it would allow for billing therapy without the patient being present. Several states like Texas and Iowa allow this, and it is extremely valuable in treating youth or others who may have Medicaid while their parents, foster parents, or other caregivers do not. This allows for development and communication of treatment strategies, among other things, without discussing the patients in front of them, which many clinicians believe could result in triggering the patient, thus being counterproductive or even harmful. This would be considered, we believe, cost neutral. Second, continuation by Medicaid to allow telemedicine parity for treatment by telephone and televideo. This has certainly been a game changer for our system. It allowed us to pivot very quickly, especially in urban parts of the state, because rural and frontier areas were previously using televideo a lot. So we hope that our state will allow whatever CMS continues to allow us to do in terms of flexibility relating to billing for televideo and telehealth. Third, increased Medicaid rate reimbursement. With stagnant Medicaid rates and increased expectations, we have seen increased turnover in many of the professions we employ. The 2020 legislature had increased rates by 2% before the governor froze the increase as part of the allotments. I want to express our appreciation to each of you. I know all the members of this committee were supportive of that. Lastly, expansion of Medicaid. More than half of those who present for treatment at CMHCs have no insurance, and we have seen an increase in the number of new patients who present directly to crisis services. So with that, Madam Chair, I would conclude my comments and stand for questions at the appropriate time.
All right, thank you very much, Kyle. Next, I have Sean Gatewood, Co-Administrator for KanCare Advocates Network. Welcome to committee, Sean.
Chair, members of the committee. I came before you last time this committee met and talked about the need for coronavirus and COVID reporting in institutional settings, congregate living settings, because of just how important it is, particularly if you're trying to place a loved one in one of those settings. And I'm happy to report now the state is reporting that information. We're very, very excited about that. We would say that, we would love to see that down to, instead of 5 people, down to 1, just because we know that, any virus present in a congregate living setting is an issue. But we're very, very happy to have what we have. So just wanted to sort of report that pleasant news. Now, looking forward, again, we're never going to eliminate the need for institutional care by any stretch of the imagination. Intensive nursing care is needed. But for those that, could transition back out, or those that could be not put in an institution to begin with, I think that would be a very good thing given our circumstances in the world right now. So I think we ought to be looking at various ways of transitioning people out of the home. We used to have a Money Follows the Person program. It would be nice to bring something like that back. I know we've been working with our managed care organization friends, and they have programs going on inside of them that are working on transitioning people into a more or to a less restrictive setting, I should say. And so if the state starts looking at that as well, I think it would be a very positive thing given the state of the world today. So thank you, Madam Chair. Happy to have good news to report.
Thank you very much, Sean. Appreciate it. Next, we have Mike Burgess, Director of Policy and Outreach, Disability Rights Center of Kansas. Welcome to committee, Mike.
Thank you, Madam Chair. And ironically, I'm going to cover on the same 2 topics that I did last meeting, which happened to be the same 2 that he touched on. But I'm going to try and delve into the weeds just a little more than Sean did. And those 2 are COVID-19 data and Money Follows the Person. So again, I want to thank the Department of Health and Environment for listening to the disability community and others and providing that much needed transparency to help. I mean, we've now joined, there's 35 states that were already doing that. Kansas is now the 36th that is reporting that COVID-19 cluster data. And just want to make that, that we're joining the majority of states in doing that. In doing that, because there's so many other states, there's some great examples out there of states that have done that. They're balancing that need to respect privacy, healthcare privacy, administrative overhead, but with that need to provide actionable data for Kansans. And so on the second page, or attached to my testimony, is one from the state of Mississippi, actually. And they define an outbreak, and I apologize that it's so small. The online, if you look at the online, you can make it bigger. But they define an outbreak as 1 or more cases among long-term care facility residents, or 2 or more cases among staff within a 14-day period. And those 2 things are both significant and very helpful for the folks. And so if you look through, it's sorted by county. They break down a lot of different types of facilities. It's not just nursing homes, but they have what they call personal care homes. There's ICF IDDs, and a number of other types of settings that are included in this more detailed report. And those are the state licensed facilities that we're looking at. And you have, again, the cumulative number of cases among staff, you have cumulative among residents, and then also they report deaths, which is also relevant. I think if you wanted to make this better, you combine what Kansas is doing now, where they're showing you the number of active cases as well. And I think if you add that column of data to this report, you have something that is immensely helpful for families. And what often happens is when somebody's getting ready to transition from a hospital into one of these settings, the family or the individual may have 24 hours to pick which facility they're going to go into. And that's just that's a tough time when there's a lot of things they're trying to figure out, let alone to try and call on each of those facilities to figure out if there's any active cases at that facility. And so, this is one. So imagine if that was your mom. Well, I'll make this personal for me. It wasn't my mom, thankfully, but we had a family member who had a healthcare incident, and they ended up having to transition into a facility. Literally the next day, there was a newspaper article about this huge outbreak that happened at you can imagine what that did for us. I mean, that was very, very stressful for an already stressful time. So I'm almost out of time, so I'm going to transition really quick into MFP. And I talked about, we're already doing and paying for some of this work. Talked about the missed opportunities that could happen. Well, CMS just did an announcement. 33 states are getting up to $5 million to do this work. And that's on top of the program. They did a supplemental appropriation for this. And, the good news buried in that release is it's not too late. They're going to have rolling opportunities for states to apply for and receive. And you can see in my testimony the types of things that you can use that money for, which again are things that we want to be doing. I mean, that we all want to be doing. So with that, Madam Chair, I'd be happy to stand for questions at the appropriate time. And thank you very much.
Thank you, Mike. And next, I believe we go back to the Zoom with Beth Patton, private citizen. Beth, are you there? Do we know if she's even on? She's not on? Okay, should she let us know that she wants to be available, we'll squeeze her in at any time, Dave, so I appreciate that. Pardon? Yes, there is written testimony before you committee, so you can go over that. Then we have written testimony only from Lou Ann Keeby with the System Advocate Manager of South Kansas Independent Living Resource Center. Rachel Monger, Vice President Government Affairs, Leading Age Kansas. Amy Heighton, Executive Director, Topeka Independent Living Resource Center and Grassroots Advocate for Independent Living. And I believe it looks like written testimony for Audrey Dunkel, Kansas Hospital Association. Have I missed anyone that was wanting to testify this morning? All right, committee, we will now open it up to questions of the conferees. Anyone have questions?
Representative Landwehr.
Thank you, Madam Chair. My question is for Holly Noble. It's a multiple part question, if that's okay, Madam Chair.
No, that's fine, because I've got a few, so
Okay.
do whatever you need to do.
Okay, so I've had a few facilities contact me about the testing and the costs and the requirements. Could you just real briefly tell us, this is all a federal mandate, what the requirement is and how long they are going to pay for it?
Okay, well, it's kind of, it'll probably take more than just a minute to
Yeah,
explain.
if you
just so
could
I
really
will
summarize.
sure try. Okay, so yes, it is federally mandated. We have to go by zones, whether it be red, yellow, or green. Those that are considered red have to test twice a week. Those that are yellow, weekly, green is a monthly. And I'll just use my nursing home. So I'm rural Kansas, town of 600, population of almost 5,000. We had an outbreak in our meat plant, which was not in my town, but for some reason, those 40 made us be a red zone. So we are looking at testing twice a week. We couldn't even find services. So we are busy frantically trying to not be out of regulation and trying to get vendors and get denial letters and proof. Our nursing home also doesn't have a machine. We are not skilled in any nursing home that takes Medicaid only. And for rural Kansas, there is quite a bit because we rely on our critical access hospitals to actually be the Medicaid provider. That is their bread and butter. A lot of our Medicaid homes have no machine, and it's not even slotted yet to have a machine. My last communication with CMS was September 30th. There's going to be a new list out of even those homes. Now there is, you hear in the news about this Abbott testing. It's going to be $5. That's great, but a lot of our homes don't have those. I personally have tried contacting them. So is my infection control nurse, and so have 2 critical access labs that are by us with no response from them. And you're talking 2 weeks, no response. The problem is there's not a lot of good communication coming from above that says when you're getting them. From what I'm hearing from people are just, oh, I have a shipment. It's here. It's great. And those that have nothing. I have still had heard no communication. I have nothing. The home down the street got a letter say, hey, we're getting some Abbotts, but that's all they know. It hasn't came yet. But it is financially strainful, and we're supposed to have them back, within 2 to 3 days. I did testing on Tuesday. Sunday was my last of the 4 results came in. And the fact that we're having to pay all this money when it could be used at a better time, when it truly is an issue in our area where I had 0 active cases, would be much better. In addition to vendors, I had to have a vendor come down from Hutchinson, or even our sprinkler system, who has no contact with residents. no contact. He can be ground up, walking around, but yet I had to get him tested. So we're bringing people in just to be tested, but they could be positive and we could still have an issue. But it is an issue of trying to get the testing and being available and being effective. If we lose all of our money at the end of the year, what's going to happen? New Year's party, January 4th, we start having all these outbreaks, and we really are coming up with $20,000 for testing out of our own pockets.
$20,000.
Oh yeah, you're talking per test. Is some of our homes, the larger homes, are having to pay $20,000 for one round. It did, because you're talking your vendors, your volunteers, your staff, and if you have a staff of, let's say 500 at some of these larger homes, it's quite costly.
We've also been having a lot of discussions in this committee and other committees that I'm on as regarding workforce. And so I'm wondering who does all these tests? Are you having to hire somebody new to do that?
I'm actually having to take a nurse off the floor to do it and has to monitor it. Talk about staffing, especially in rural Kansas, it is very difficult to keep your staff. And a lot of our staff roll dual hats. The nurse at our school is also my education nurse. She has refused to do testing because she is fearful because of the false positives that it's going to make their school have to close down. Her husband's a teacher, her kids play in sports. I have high schoolers and I depend on my second shift. I literally depend on my high school being open to help service my 2 to 10 shift. That they're in their senior year and they're scared to death of being tested and not being able to play their volleyball. And so it really is being critical, the testing is. And it's also not pleasant to have. We had COVID in my nursing home back in April. The testing was not pleasant. The second round, not only did they go up one nostril, they went up both nostrils now because of new requirements. So it's not pleasant.
Okay, one more. Along that same line, then, how do you manage the temp agencies, or if you use them?
I do use them.
So my questions on that are, I'm assuming they're tested. Do they test at every facility they work at, and are they paying for it, or are you paying for it?
Well, I can tell you my experience. When it comes to agency, we try to keep them as their own. So we do like a lockdown of for 40 hours a week, for a month at a time. And we do those testing. We have some that would work with us, said, hey, we'll provide the testing. And we have many of them say, nope, we don't have to. Talking to some of them, they have actually told me that what they're being told is it depends on the facility they go into. So they're only going to test per that facility. So if they live in Sedgwick County, who is a red, but my county is a green, they only have to test once a month is what I have been told by them personally. But everyone I have talked to has had a different answer to me. And then we use 4 agencies in our building, but we are making their staff test per our policy in our county.
And then are you paying for it, or do they?
We are paying for it. But we also, I don't know if every facility does it how I do it. Like I said, I do contract with them and we try to keep them, and we are a peak home and we feel very special about how our residents and families know our staff. And so if we like that person, we kind of keep them on. So they're kind of like our staff. It's what the hardest question is going to be for staffing is it's a weekend, you have the flu going around. I need to call out 3 shifts. My problem in rural Kansas is that person can't come on my building. I can't service them because I don't have a way of getting them tested on the weekend. All of our labs are closed. That's the concern we have right now when it comes to getting help in our buildings is after hours in the evening and on weekends when there is no lab available and you can't have them step foot in your building without being tested.
Wow. Okay. Thank you, Madam Chair.
Committee, and I've got Representative Carpenter and Representative Murnan for questions. Is I'd like to pause for just a moment because we do have Beth Patton back on the Zoom line, so you may get called back up, Holly. Beth, are you there now? Beth Patton?
I'm kind of frozen.
Frozen?
Are you able to hear me?
Yes, I can hear you. Go ahead, Beth. Can you hear us, Beth?
I can't hear you guys. I was thinking on my state website, state top, see if that works better.
Beth, you're really breaking up on us out there. Would it help staff if she went back out and tried to come back in? Beth, if you'll try to disconnect and then come back in, and then we'll bring you back into the committee when we can hear you better. Is that okay? I think we've totally lost her. They're absolutely loving this technology. Can you imagine the legislative session? Okay, next on, I think, Holly, I'd like to have you come back up if you would. Going along the same lines of where Representative Concanon was at with this, if you could design what really needs to be done to protect your system, what would you do and what wouldn't you do?
I don't disagree that testing is important, but I do think right now there's too many variables that have not been taken into effect the way it's wrote. Every county knows their area, how much traffic everyone has. I know in my home, we are even talking about trying to protect our residents. Is the way it's wrote, we can ask families to test. So we are asking families to bring proof that they're being tested, brought in. I do think that's going to cross some issues. One being, is my understanding that insurances don't pay for the testing. So I think there's so many variables, it's going to be hard to say this is what needs to happen, because it's such a multi-phase issue of getting everyone to collaborate and come up with a good plan. We work really well with our county and with our disaster plan manager. And I really do think if you give us some time to get some other people, get Case, Leading Age, and other people together, we'd be happy to come up with something to present to you guys as to what an ideal scenario would look like.
Okay. Well, and the reason I ask that is, I have found it interesting, all of these requirements that are being put on a lot of, businesses out there, whether it's in the healthcare industry that you're in and others, when in our own hospitals, an employee tests positive, they don't test the rest of the employees. They don't quarantine the rest of the employees. They wait until another employee has a symptom and then they address that employee. So I'm just finding it really hard to understand why we are putting so much more pressure on entities such as yours and others in the healthcare field, because I would think our hospitals know a lot of what they're doing out there.
And so do I feel like our industry does too. And we're all here to provide the safety of our elders. And no one, I would think, would intentionally put our elders in harm. So, but I do feel like you give us some time and we'd be happy to bring up something. But the testing definitely is a huge issue. And I do feel like rural Kansas has not been adequately thought of getting access to some of these testings is really hard, along with staffing, and it has just bombarded us with multiple issues. I do have concerns about staffing, and when you have issues with staffing, it takes months and months to rebound. And the fact that your staff saying, hey, I'd much rather not get tested and just take a leave of absence, or I can go to McDonald's and, down the road and make $15 an hour or not have to worry about having this testing. It's what a lot of them are doing, and that's just not a system that's going to help us.
I think it would be good for all of our healthcare folks. So this isn't just for Holly out there that may be running up against this, because I know, within the hospitals, a lot of their, because they have subcontractors coming in and out of their facilities every single day. Well, the hospitals don't, but a lot of those employers are requiring, because the hospitals require it, but the hospitals aren't having to pay for all of that.
When I've talked to our vendors, actually 3 of them have all said this was news to me, and I actually sent them the bill. I highlighted in the bill because they all said, I don't have to be tested. I said, no, you do have to be tested. A lot of them are unaware in long-term care that they have to be tested. And I literally have had to email them. And then it's I don't know what I'm going to do. So if you want them in your building, you have to figure it out. And I have regulations for fire marshal says they have to have this test before this date. It forces our hand and says, well, I guess we're having to do it.
I think it might be good for us if you could distinguish for us the CMS requirements and then the state requirements.
CMS is the ones mandating the testing and the requirements of the zones. Now, the one thing I will say that has been a great help to us is the fact that the state has get us now and running that they are now allowing us to use KDHE numbers for percentages, because that took us from a red zone down to a green. And that helped us tremendously because that went from twice a week to monthly. And that is wonderful because that helped me get a lot of my staff saying, hey, okay, if I only got to do it monthly. Now, granted, they aren't aware it could change at the instant, but that's something that I will address when it comes down to it, if it ever does. But that the state allowing us to do that has been wonderful. And we do greatly appreciate that. And it took our numbers. I wish I had them. I don't. But I think top of my head, I want to say about 14 counties, I believe, that went from red to green. And that's a huge savings to a lot of our nursing homes. And that was great.
Right. Well, and I don't know how you guys are doing what you're doing to not only have this additional expense on top of you, but then also having the cut that the governor placed on you. And you weren't anywhere where you needed to be prior to that cut.
No, and I do know there are a lot of homes that are looking at receivership. I hate to say that. They got 6-12 months. I know a home in my county, they were struggling. And part of it is we have a lot of unknowns. I myself have got a PPP loan. I have no clue how much is going to be loan forgiven, how much I have to pay back. And so that a lot of our homes have that. That is in the back of our head. If I got to pay back $222,000, I have staff that's begging me for hazard pay. I got staff begging me for increases. Our home alone said, hey, in December that we weren't going to do any evals and raises in 2020. We're going to look at our financials in December. And thank goodness we did, or I'd be in a heck of a mess right now. So it is hard. And even, with surveyors coming in, they're not doing any testing and we have to allow them in our building. So that is something a lot of homes have said, hey, we have to allow these people in our building with PPE, but how come we have to make our vendors get tested and our surveyors are going into the rooms, talking to our residents with, they're not doing hands-on care, but they're still talking. So we still have chances of errors and we have no clue. I hate to say it, but I do feel like it's going to be everywhere eventually. I mean, you can't not have it come in. It's just how can we mitigate it to where we have less exposure?
Right. So has there been any relief whatsoever, and I apologize because I'm trying to remember whose testimony and what. Has there been any relief whatsoever from the COVID dollars that the state has received from the federal government to your folks?
Sparks funds.
Yeah.
So yes, and we have that. And we've been actually going through and seeing what can we use, what can't we use. Part of the problem is, like others have said, stipulations as to is this going to be covered? Is it not? It's kind of vague on some areas. And so I'm waiting for our accountant to see, is it even qualified? My biggest concern is I may not need it till January 1st. And if it doesn't roll over, that's my biggest concern is I have $108,000. That's great. But right now I don't have I'm not red. I don't have an issue in my nursing home. I'm only testing monthly. But what happens if there's a party and next thing I know, I have an outbreak and then I'm out of my pocket and I could have used those funds, but I don't have those funds available to me now. That's the big thing. I think if, I'm not saying all of it's because a lot of our homes have needed that money. They have used that money and some, but there are some homes that haven't hit the issue of having it in their home yet or having an outbreak. But in 2021, if it does, it would be nice if we can find a system that would roll over or help us to get some of those funds to roll over so we know we're not having to spend the money. Because you could spend the money, you could think of ways of spending it, but truthfully, we need to keep it and not spend it in ways that you could use it, but it's not the most valuable use of it. It'd be nice if we could have it available to use as needed, rolling over in January.
But you could use some of that funding for some of your PPE needs and et
If you
cetera.
can get the PPE.
If you can get the PPE.
Well, I'm an allotment for gloves. My concern, honestly, is flu. How can I allot gloves if someone has, I can't reuse them. We're thinking outside our box here, do we go buy the kind that you use when you do dishes? It's crazy, the allotments, and it's not just us, it's everywhere. I know there's a shortage, but it is an issue.
All right.
Haven't even hit flu yet.
Okay, and Holly, I know there's some other questions for you, and we'll come back to you in just a moment, because we do have Beth Patton, I believe, back on line with us. Is that correct, Beth?
Yes.
Can you speak up a little bit?
Yes.
Okay, go ahead, Beth. Welcome to committee.
Hi, thank you for the opportunity to speak. My name is Beth Patton, and I live in Independence, Kansas, which is in the southeast part. I'm here as a private citizen for two reasons. I know that you've got my testimony, and I'm not going to go over that. It's pretty much on point and depicts issues that recently occurred surrounding a 13-year-old child here in this community that kind of shows some flaws, pretty severe flaws in our community mental health center services in this catchment area, and I'm sure everywhere around the state. But those issues are not what I want to discuss, but they do kind of point out some things that I do want to make. First and foremost, I want to give a huge thank you from the bottom of my heart to three of the entities that you guys know and work with, and I work with actually two, DCF staff, Medicaid, and UHC. They rose up and beyond for this child. They did not know where this child, the state that the child was in, until the child was there, and they pulled her out, basically saving what was to happen with her. And for that, I applaud, and the parent thanks that those people. That is what it is for, but at a much earlier time. That leads me to the second point. There is, this is not the only grandparent that I have seen. I actually am a grandparent as well of custody of grandchildren in a private case. What scares me is that there are so many grandparents that do not go through DCF to get their grandchildren. And there are no services. There's nothing to help guide them. There's nothing, and it gets to a point where DCF doesn't know because they're not involved. And so the grandparents don't know what to do. There are no services that get in place. They don't know how to navigate the system. They have to use their own money, their Social Security, their funds, their savings. It all gets counted, so they make too much money for anything. And what happens is these children don't get what they need. They're trying to help these kids. I just wish that possibly this committee could look at a focus group. I would even be willing to be on it. I just don't want to spearhead one. I am a mental health professional, but I can't undertake that. I just see so many, even in other states. But if something doesn't happen, the grandparents are going to lose everything, and they're going to be relying on the system in their old age, and the kids aren't going to have the help they need, and it's all going to be for nothing. I just wish there was more. Mental health centers need some safeguards in this area I know the rules. Most people don't know the rules. And the only reason this person got the help is because I knew where to push them and point the person in the right direction. And that's sad, very, very sad. And for that, I am very, being in the field, it makes me sad that I was in the field, to be honest. So I'm still in the field, just in disabilities. So I thank you for your time.
All right, well, we appreciate you being here and going through the difficulty we have sometimes with our technology. We appreciate that a lot.
That's fine.
I think what my recommendation would be, and we just happen to have the correct staff member here in committee today, is that we, Dave, that we refer this to the mental health committee that is actually looking at how mental health services should be provided in Kansas, how they are, and where we need to go in the future, because you've made some very valid points in that.
Okay, thank
So
you.
we'll advance that. And you might want to monitor when those committees, because we are Zooming that online, there'll come a point where we will allow the public to have some testimony in it. Right now, we've been dealing with the legislators and some non-public members that were assigned to that committee. So I think that would be an appropriate one for us to address it, but we appreciate you bringing it to us.
Thank
While
you.
we've got Beth on here, are there questions for Beth, Representative Barker? Not for Beth? All right, seeing none, Beth, again, thank you very much. We
Thank you.
appreciate you being here today.
Thanks.
Okay, well, I'm going to put you on a list, Representative Barker. All right, next we have Representative Murnan has a question.
Good morning, everyone. My question is for Matt from Maxim.
And for some reason, Representative, it's not you, it's everybody that has spoken. We're getting some kind of a feedback, so we may be asking you to repeat yourself on occasion.
Okay, I'm testing now. Is that okay? Okay.
Yeah, we're just getting some background noise. It's not on your side. It's something that's happening with the technology right now. So
Okay, great.
just be prepared
Matt,
for it.
okay, thanks. Matt, I want to make sure I heard you correctly. And just FYI, math is good. We need more of it in the legislature, so thanks for that. On page 3 of your testimony, in your bolded area regarding your recommendation for the increase. So based on, did I hear you correctly? Based on all the math you did, including the process of excluding third-party or commercial payments, you got to the 47 per hour, correct?
That's with a reduction of 2.5%.
To achieve a reduction of 2.5, it would go to 47 an hour would achieve that reduction. Did I hear that right?
The rate to $47 an hour would be, to make it revenue neutral, it would need 2.5% of the hospitalization days reduced to be able to make it revenue neutral. That would cover the $22 million for all funds. And for the state funds, it's estimated 9 million. That would be 566 days. That would need to be reduced to cover the state general fund.
Great, thanks for that. And thanks to everybody for going through that math problem. That's exactly what we needed from last time, and I appreciate you guys doing that. I know that wasn't easy. So thanks for the explanation on that. And then my second thing, Madam Chair, is regarding Holly's comments. If I understand correctly, the money that she's referring to, that it would be nice to move it into the spring months or January month, the month of January, that is a federal requirement that those funds be spent by the end of December. Am I understanding correctly?
Yes, it is. And I think it's something we're seeing all different government and business entities are struggling with that, because they may not need the money by the end of the year, but they know they're going to need it in spring. So
Right. But that's nothing we can do, correct?
No, ma'am.
Okay, thank you. That's all.
All right, thank you. Next, I have Representative Carpenter.
Thank you, Madam Chair. My question is also for Matt. Matt, in here, and I may have not read it, but it does not address how many clients, how many patients we're talking about here.
528.
Okay, so we're talking 500. Well, that just kind of helps me a little.
A big piece of the math problems that we were.
Well, yeah, and it wasn't, I didn't read it in there. It may have been in there, but I didn't see it. But as you know, I've been a proponent of this for quite some time. We had money in the budget this last year also. So, but I did need that number there to finish my math. So, okay.
If you wanted to dig deeper into the math problems, I'd be more than happy to do it. I just didn't want to bore everybody. So.
Well, you know, I think we just have to put our ducks in a row to make sure that we can prove our case. So, okay, thank you.
I think what we're going to try to do is, if there's any more questions for Matt, otherwise we're going to have him jumping up and down like a jack in box, and a few of our other people as well, not just you. Is there, because I also had Representative Hildebrand and Barker. Did you have questions for Matt? What about you, Senator Hildebrand?
No, not for Matt.
Okay.
My question is for Holly.
Okay, we'll bring her back up here in just a moment. I should have thought of this earlier. Matt, while we've got you there, is what has been the actual impact of the $22 million cut that the governor did to your current budget?
Well, it was in the budget to raise to $37 an hour, which definitely we would have been appreciative, but it is a far cry from where we needed to be at. The impact is the same as it was for over the past few years. Our reimbursement rate hasn't moved. The utilization percentage continues to decrease. It becomes harder and harder every single year to recruit, train, and retain our staff. The problem continues to compound. So without some impact on this population, it will continue to get worse. We're already at a crisis level of 65 to 70% of authorized services. Create more and more hospitalization days, which 95,000 hospitalization days at $1.5 billion, even a fraction of a reduction easily covers the 22 million.
And so we're, instead of paying for the $22 million in being able to provide the proper services, we're still paying that money, but now we're paying in hospital days, which is a lot more expensive. So we could give you that hospital day money. That would be awesome, wouldn't it? All right. Is there anyone else that has questions for Matt? Oh, I know. I do have a request, is because I did not see in your testimony some of the numbers that you were giving us. I did not see in there. If you could provide that to us, or if I overlooked it, it wouldn't surprise me when I'm trying to skim through there.
I'll go ahead and send you a summary of all the math and then the long math.
Oh, that would be great for us, I think so. Thank you very much. Okay, next we have Senator Hildebrand.
Thank you, Madam Chair. And this, my question is for Holly Noble. So. Holly, I appreciate your testimony. We're hearing an awful lot from our senior citizen homes and long-term care facilities that PPE and testing is a big problem. When HB 2016 was passed, there was a stipulation in Section 19 that ADHD would provide testing, sanitizing equipment, and PPE. Can you give us an update on where they are at in fulfilling that requirement under HB 2016, please?
I'm not aware of any health sanitation equipment. I'd be kind of curious as to what they consider sanitation equipment would be. As for the machines, I know my home itself has not got one yet. Look at myself, sorry. But our home ourselves hasn't got a machine yet. I don't know when we're going to get it. And I know I'm not the only home yet. I think I saw there were still 8 or 9 homes that had responded, that had not received machines. I know some homes have said they've got their second rounds, and there's some homes who haven't even got their first round yet, which is what's very disappointing. I don't know what there is for tracking of who's receiving, who's not receiving. That is something I think would be nice to know, especially for you guys, since you guys are the ones that I'm sure people are going to come to saying, hey, where is everything? As for the PPE, what we have gotten was not, I would say, adequate. It was not industrial grade. It was very thin. Our gowns were thin. They were like paper. We couldn't even use what we did get. And for the N95s, I don't know how familiar you guys are with N95s, but I know our allotment was all KN95s. I don't know if you guys are familiar with what a KN95 is. We can't even use those because they're not considered N95s. They're actually manufactured from China, and we're told, hey, you're not supposed to use those in nursing homes. So what I got, I couldn't even use. So.
All right. Thank you, Madam Chair. That brings up a good pivot
Senator
point.
Hildebrand.
Can we possibly have KDHE in the Adjutant General's office give us a detailed list of where this equipment's going? Because this was a 90-day time limit for them, and that would have expired in September 7th. We're now in October, almost October. Can we request for this committee to get an update from the Adjutant General's office and KDHE, a detailed list of this PPE, what nursing homes have received them, what nursing homes have not, and what their time frame is to fall into accordance with HB 2016, please?
Last week, I got an email from CMS that basically told me to stop contacting them and emailing them, and they'd put a new list out September 30th, if that's helpful. I was trying to be that squeaky wheel myself, trying to figure out where my stuff was. But September 30th is my understanding. There will be a new list out of just the machines.
So Senator, our staff has made note of that, and we will request, I can't talk this morning, will request the information for you and the committee. Thank you. Any
Thank you.
further questions, Senator?
No, thank you.
All right, seeing none. Next, I have Representative Barker.
Thank you, Madam Chair. And Holly, you can just come back. My question is probably on the same line as the senators. I was sitting on a interim committee on emergency management last week, which I found very enlightening.
I like that too. So
what percentage of the allotment is your need? For example, are you getting 50% from your allotment of what your needs are?
problem is with our needs all depends on my caseload, what diseases I have in my building at the time. For example, right now on gloves, I'm okay because I don't have any flu, but I guarantee if I have something that goes through my building, I'll be running through my allotments. And it's surprisingly enough, you think, gloves are a problem, it's the size too. We can't even guarantee what size we're going to get. And so we may have people that need smalls and extra larges just to make do. And the big problem also with that too is you got people that are allergic to latex and stuff. So we're very limited on what I can have in residents. I can't even have latex in my building because I have residents that have the allergy. So I'm limited as well on that.
Another follow-up. One of the stories we heard last week where they were ordering the gowns and they were nothing but plastic bags, trash bags with the heads and the arms cut out. And they did get those from China.
That's the shipments that we got. I mean, I'd hate.
You were part of that. Okay.
Yeah.
And which they couldn't use.
Yeah, we can't.
Do you go directly to online and purchase them, or are you waiting for emergency management to acquire those and then give the allotment?
We go through our vendors. But I will tell you, we try getting on with new vendors, and we've had vendors say, I'm sorry, we're not taking any new people because they're on allotments themselves. So not only are we on allotments, so are the people that are purchasing them. So they're not even taking new orders so unless you're ordering gloves from them before, you can't get put on to order gloves. Now, our nursing home was able to go through through emergency management to get some supplies. Chris has been very good at that, and that's been changed over now. We through the state, you guys set up this program to go through, and if you had your had a PPE and you couldn't get it to get a request, but we had to show proof that we exhausted all of the other options, and we did. Our home got 1,500 N95s, so we're very thankful for that, and we got 2,500 gowns. So, and actually, I was told that they actually were not paper, so we are very appreciative of that.
My understanding is they have quantities over at emergency management. It's just getting them out to the people who need them. So you have to exhaust all other means before they
show proof. And we go through so we collect all of our emails, everything we have, and we show all of our proof. And they were at one time, we were requested weekly to turn on our PPE count too. And we have actually went through and have now down, they're only asking for monthly PPE count. I will tell you though, that when it comes to PPE count, this is how scary it is. And I'm just going to use my nursing home. So this is how scary it was. When this all started, we hardly had enough PPE to get by. And we were told, if you open up a box, they don't want you counting the box. So we went through and we opened up boxes. I put them downstairs, and I have a COVID supply room. I know I've got 2 weeks supply right there. And those boxes are open. One's been used. And I don't count that in my PPE, because there are a lot of us that are scared if something does truly happen, can they come back and take our PPE? A lot of us are scared if they're tracking it, what's to say they won't say, hey, you don't need it as much as this person. And it's a scary thing to be in when PPE is what could save a life.
Thank you, Madam Chair. Thank you, Holly.
Is there anyone else that has questions for anyone?
Senator Petty.
Senator Petty, go ahead.
Yes, I have a question for Tanya.
Hi, Senator.
Hi, Tanya. Hey, you and thanks for being here on Zoom. You had mentioned about the codes, and I was wondering if you could elaborate on how many you said there. Maybe I missed that number. You mentioned the D9420 code, but you mentioned there were some other codes that were not on our plan. Could you expand on that?
Sure. So last year and I finally got the camera to work, so happy about that. Last year when there was a rate increase, there were about 37 codes that were increased. This year, the second rate increase targeted those and a few additional ones. The code, the issue we're bringing up here is that the list of codes that ended up being proposed in the final state plan amendment was different than the list that was negotiated back in May. So we're trying to figure out kind of where the disconnect is. I can get you kind of a detailed list of what that difference is. We were just highlighting 9420 as an example of a new one that was added this year that would have a really significant impact if it could get an increase. So I don't know if I've answered the question, but I can certainly provide you a lot more detail about that.
Thank you. That's helpful. So yeah, and I think it would be helpful for us to know what that code list is. So the confusion here is about what was negotiated, but actually what was in the final set of codes.
Right.
Is that correct?
Yes.
And then the second question I had for you had to do with, you mentioned about amending in which I think sounds like a very reasonable approach, amending what to provide, include telemedicine and in the 2021 session.
So it'd be amending the Dental Practice Act, which lists what the parameters of the scope of practice for dental professionals is. And so it would be amending that just to say that that certain codes can be provided via teledentistry, which could be via video or by telephone. And I can get I don't have the number, the citation in front of me, but it's in the 65s, but I can get the citation together.
And right now, because of the pandemic, have you been allowed to do dental telemedicine?
So it was allowed for about 2 months through KanCare, from the start of the pandemic until about June 30th. So I guess it's a little longer than 2 months. Since then, it hasn't been allowed, and primarily because it turns out there's just a lot of confusion about what the Dental Practice Act does allow, and then what House Bill 2016 during the special session intended. The language around healthcare provider and around telemedicine was fairly vague, but the interpretation from the state so far is that it's not as vague. It's not so vague that it does include dental. So, yeah.
Thank you. Thanks, Tanya, and thanks, Madam Chair.
Thank you.
You're welcome. And Tanya, kind of tagging along with that, because I also had the same question on the telehealth. And I think that, one of the things that we've learned as we've gone through this pandemic and talking to different health, professions, that we've got to come back in this next session and definitely define what does telehealth mean? What do those codes look like? Et cetera. So I think any of the professions out there that are dealing with this need to be prepared to come into the 21 session with, ideas and recommendations. Because I know that we've kind of learned through the mental health side of things that telehealth isn't necessarily a real positive for some of our really young, our 5-year-olds, our 6 and 7 and 8-year-olds, because of the interaction that's kind of needed by the professional to work with them. So we would appreciate hearing from you then for the next legislative session on that.
Absolutely. Thank you, Madam Chair.
Thank you. Committee, are there further questions? Did I miss any, Dave, that's on Zoom? Okay. Now, we have our presentation by our KanCare Ombudsman, Carrie Bacon. Welcome to committee, Carrie.
Thank you.
Is the blue light on?
Yes, it is.
Okay.
So I'll pull it closer. Thank you for allowing me to be here and share with you a little bit about what's going on with the Ombudsman's office. If you look at the front page, it shares a little bit about what's going on with our office. We Our satellite offices are still closed for the most part. My assistant and I are handling most of the calls. We have a Wichita team member that is working remotely, and what we've worked out is she's doing training. She's been training 4 different volunteers, a Vista volunteer, an intern that will take over 2 slots for our volunteer. And then we have 2 new volunteers that are for Olathe. And once we open that office back up, they will be able to start there. One thing that I would like to bring to your attention, if you take a look at page 14 under our Medicaid issues, this piece of our report talks about the kinds of calls that we get or emails that we get. And you'll notice that I've highlighted Medicaid eligibility issues and Medicaid information or status updates. And those are dramatically down, anywhere from 67 to 77% down. When I first did this report, somebody came back to me and said, well, what's happening at the clearinghouse? I was like, I don't know, I should probably check that out. So I did, and they are actually down 57% or 55%. It's in this report. Yeah, 55%. So people are just not calling in. I think one of the reasons that may be happening, I don't think it's all of it, is that right now the state is not dropping people from Medicaid. It's a COVID thing. And so even if they've lost their waiver services, typically many people, not all, would lose their Medicaid services. If paperwork isn't turned in on renewals like it should be, people would lose their services. None of that's happening right now because there's a requirement that people keep their Medicaid as long as we're in a state of emergency. So I think that's a little piece of it, but I'm not sure that that's all of it. And then the other thing I wanted to let you know about is that we are partnering with an organization, well, a group called IRIS, and it's, I can never remember what it stands for, but basically IRIS is set up with yeah, it
okay,
is.
Go ahead.
It's under the highlights on page 4. All right. Integrated referral and intake system. KU is the one that's kind of organizing it, and you have 14 to 16 community hubs, and then they're responsible for getting partners within that community. And I would say that it's kind of like helping to provide wraparound services for people. Someone comes in with an issue to their organization and they recognize that they need help in other areas, and this provides an easier way to make sure that they get the help that they need. And we were invited to participate in this, and we've already been receiving referrals and able to assist people with, it's pretty much been eligibility issues. So we're pretty excited about it. And in the third quarter here, the last month or so, we've been participating in their monthly meetings or quarterly meetings and introducing who we are and how we can assist. So it'll be a really good outreach tool, another way for us to receive referrals. I think that covers most of what I wanted to share with you. There's a lot more information in there, but I'll let you take time to read that.
Committee, are there questions? Yes, we're a quiet bunch. You did a great job. And I appreciate you just kind of hitting through the highlights on this here when there's not a lot of changes. So thank you very much for being here today. Next, we have Jay Emler, Deputy Attorney General, Chief Information Security Officer from the Attorney General's Office. Welcome to committee.
Thank you, Madam Chair, members of the committee. Hearing aid back in.
It comes a time for all of us at some point, Senator. So.
As the chair said, my name is Jay Emler. I am Deputy Attorney General, Chief Information Security Officer And because we no longer have an Inspector General, I've taken over the administrative function of the Inspector General's office as well. The Inspector General, of course, Sarah Fertig, now works for the Kansas Department of Health and Environment, and I think you're going to be hearing from her a little later. Since the last meeting of this committee, and Madam Chair, I'm going to just really hit highlights here and not
That's
get
great.
into, you all have my testimony, you can all read. So since your last meeting, the office has had 242 complaints. Those have been reviewed, and if there was some question about those and clarification was needed, they were passed on to the Medicaid clearinghouse. The office communicates on a monthly basis with the MCOs, KDHE's, Program Integrity, KDADs, and of course the Medicaid Fraud Division of the Attorney General's office. In addition, there are other agencies that we meet with on a monthly basis. Personal care services are an area that has a great deal of potential fraud. And of course, the Office of the Inspector General for Health and Human Services has indicated this is a high-risk area. One of the reasons for that, well, two reasons. One reason is that the personal care attendants have no set qualifications, and the second is that CMS does not require states to enroll PCAs. So you have the possibility, a greater possibility for some fraud. The office ran claims data from January 1 of 19 through June 30th of 20 to see if it could identify problems with payments being made while beneficiaries were actually inpatients at hospitals. And the office found $49,294.67 in 30 different cases. All of those cases, well, one of those had over $8,000 where the PCA was billing, but the beneficiary was actually in the hospital. All of those cases were turned over to the Medicaid Fraud Division to have further investigation. There is a chart in the testimony of which MCOs paid how much money. Some follow-up on the APRIS notification. The long and short of that is that we did an in-depth, and there are like 10 steps that are in the testimony. I'm not going to walk you through all 10 steps there, but there are 10 steps that they went through to determine whether or not people were being paid. And of course, this is just a sampling. It's not everybody, but it would appear that out of the 24 people that we identified, all of those, most of those were handled appropriately. There was one where the notification did not come in for like 26 days, and we were not able to determine why that came in so late. But as a rule, what we found out is that the notifications were coming in from APRIS at about 1 day after the person is booked into the jail. And then the average time that it took the clearinghouse employee to input that information was approximately 2 business days. So it's moving along quite well. And as you just heard, people are not being taken off of Medicaid because it's a federal requirement under the Families First Coronavirus Response Act. So while we've identified that there may be some folks that shouldn't be receiving under normal circumstances, they have not been removed because of that requirement. The other 2 areas that you probably would like to have a little more information on are the TA waiver participants and the COVID-19 monitoring. Unfortunately, from our small staff's perspective, we've had a lot of quarantining and distance working, and those 2 areas are not ready to be presented. We hope to have that report ready by December. And quite frankly, I hope we have an IG in place by that time who can report it more accurately than I. We do have, when I say we, the Attorney General's office has advertised nationally for IG. So we're actively seeking a new Inspector General. With that, I would be happy to stand for questions or find out what you would like to know, and I'll get back to you with the right answers.
All right, appreciate that, Jay. Are there questions? See, you did such a great explanation. We just don't even have questions, or you just totally confused us. I'm not sure which, but no, I just think, things have just really been improving every time we hear a report from the Inspector General. And I think it's been, kind of great. We're starting to see things, I think, smooth out somewhat. So
Appreciate that. In my review of the reports from earlier years, it does look like things are improving tremendously. So thank you. And I'm happy to, if you have questions, just let me know and I'll dig up the answers for you.
all right, thank you very much.
Thank you.
Appreciate it. Next, we have responses from our state agencies. So first up, we have Sarah Furtag with the Kansas Department of KDHE. Welcome to committee.
Madam Chair. Hey, good morning, committee. I will go ahead and start on the specific issues resolution log, which there are only 2 items on that. Does everybody have that in front of them? Both of these items are KDHE issues. So item number 1 concerns the work program. Mr. Brad Lennenkamp had reported some issues with the out-of-state payroll agent that had been hired to handle the finances for the work program participants. He indicated that he would prefer to see an in-house or an in-state company handle that. KDHE's response is that the MCOs actually contract out for that provider. And what we're hearing from the MCOs is that the out-of-state providers they've selected offer more of an online banking experience for the work participants. So you can log on at any time of day and find out what your balances are. And previously they weren't able to have that, but that is a provider that's contracted by the MCOs. And Madam Chair, do you prefer that I pause for questions after each one, or should I just?
No, just go ahead and on to your next one.
Okay, thank
I'm
you.
sorry.
That's okay. Number 2 on the same page concerns Traceba. There is an individual at the last Bethel committee that indicated that she would like to see Traceba on the preferred drug list, the PDL. Our response to that is Traceba actually is on the PDL, but somewhat confusingly, it is a non-preferred drug on the preferred drug list. So there's a class of drugs that are on the PDL. Traceba is one of them. However, it is a lot more expensive than the preferred drug for the same condition on the PDL. So you do have the ability to request a prior authorization to get on Traceba. There's a process that you follow. So that is possible if somebody really needs it, but it is on the PDL, just a non-preferred drug on the preferred drug list.
Well, and that's kind of something that occurs even with Medicare and private insurance, is that they have their preferences, but it doesn't mean you're denied it. You just have to justify, did you try this, and this before you went to that? Would that be right?
That's exactly right.
Okay. Committee, are there questions on those 2? Okay, seeing none.
All right, I'll move on to the general issues resolution log. So the first item for KDHE is on page 6 of this log, item number 9. Everybody found it? Status of CMS approved supported employment pilot for 500 persons on the HCBS waiting lists. With the chair's approval, I would almost defer this conversation. Later on this afternoon, as part of our update, we're going to provide more information on this pilot. So Madam Chair, if you would be okay with that, we can defer discussion of item number 9 until our presentation this afternoon. We have a lot more information to provide.
That's fine.
Is that okay? All right, so the next one for us is right below that, item number 10. Need for community service coordination to assist KanCare beneficiaries. In June 2020, we reported that this is on hold. That is still the case in September. That is still on hold. We need to do some coordination with KDADS on that.
Questions, committee? Representing Concanon.
Thank you, Madam Chair. So when you say you need to do some coordination, is it because of COVID that it's on hold, or is there a lack of communication?
I would say there's a lack of communication. I will say that COVID has thrown a huge wrench in pretty much everything the state agencies are doing. So that has contributed to it. But Janice and I just spoke about this recently. And so our agencies are going to coordinate on this. And hopefully in December, we can provide some more information to you all.
Thank you. Thank you, Madam Chair.
So you don't have a projected time when you'll be revisiting that?
I can't give you, we don't have a target time frame for that, but we are going to continue to discuss in the coming months.
All right, thank you.
The next item, it's not marked in green, but item number 18 on page 11, that has to do with the protected income level. And just as an FYI, we will be providing information about that this afternoon. So we did include a response there, even though it's not in green, which is that the proposed regulation changes have gone through the approval process and the public hearing will be set for early December. But I'll have more information on that this afternoon.
And I'm sorry, I got lost. So what number was that?
Sorry, number 18 on page 11.
Page 11, yes, okay. Questions, committee?
I'm not trying to keep you in suspense for this afternoon's presentation, but we do have a lot more information this afternoon. Okay, so the next one for KDHE is not until page 19, item number 32. And this one was marked in green, but it also indicated it's closed. This was the comment that was received back in February stating that the KanCare clearinghouse is inaccessible to individuals with disabilities. KDHE reached out to the individual who that the remark is attributed to and discussed this, and she did confirm that the clearinghouse is accessible. So we provided a response because it was marked in green, although it's also marked closed. So Madam Chair, if you're okay, we would support closing that item or putting it in yellow.
That's number 32 on page 19.
Mm-hmm. At least with regards to KDHE's part in it.
I think maybe, Dave, we'd want to put that on our continue to monitor list. So it's closed, but it just brings it to our attention each time for us to keep an eye on. It's all it does. Representative Concanon has a question.
Thank you, Madam Chair. So we're just talking about that first point there where the clearinghouse is inaccessible to individuals with disabilities. So the other two areas are still unresolved?
I wouldn't say that. That's more in KDAD's realm. They might have a response for that.
Okay. Thank you.
You know, as KDADS and KDHE get tied together on.
Yeah, so we don't want to close that whole section, do we?
No, we're just the one item.
Okay.
And Dave was probably smart enough to figure out that's what I meant when I didn't say that.
Madam Chair. Madam Chair, it's Monica.
Staff, I am in trouble. Okay, further questions? I do see one on the Zoom. I'm just looking around the room. I believe that Representative Bernan has a question.
Yes, just wanted to clarify. Is the KanCare clearinghouse open to the public?
By appointment, yes.
By appointment. But it's not accessible? Is that I'm sorry if you said it, I missed it.
The comment that was received in February indicated that the KanCare clearinghouse is inaccessible to individuals with disabilities. It is accessible to individuals with disabilities.
Okay, thank you. I dismissed that.
Yeah.
All right, further questions? All right, seeing none.
All right, so the next KDHE item is on page 25, item number 46. And this was a comment from Mark Schulte of CASE, indicating that due to HB 2016 being signed into law exempting nursing homes from legal protections, liability insurance rates have increased. And there's also a concern about predatory lawsuits. And our response to that is that the provisions of HB 2016 are in law, and any revisions to them would have to be done through legislative action. KDHE can't really do anything about those.
Okay, I guess we just need to insert in there, Dave, the comments so that we understand what the agency's response is to that. No, it makes, I mean, what she says is correct. It's just so that we have something in the comments so that we know that we. No, it's open. Representing Ballard.
Thank you. Thank you, Madam Chair. I do have a question about if we're looking at 45, you said frontline workers need protection with adequate supplies to be prepared. Has there been a shortage of supplies, or is this ongoing because we don't know how long COVID will be part of our lives?
Well, I believe KDADS is going to go into more detail on that particular item. The comment was from June 22nd, so I don't know the extent to which that still might be an issue, but I believe Janice DeBoer is going to speak on that item. 45.
That answers my question. Thank you, Madam Chair.
Okay, proceed.
Well, I think 46 is the last one for KDHE, Madam Chair. But I'd happy to stand for any questions that the committee might have.
All right, committee, further questions? And you'll still be available if one pops up as we proceed forward on other things. All right, thank you. Next, I have Janice DeBoer, Deputy Secretary of KDADS.
Morning, Madam Chair and members of the committee. Glad to be here today. I'll start with our log sheet also. Page 1, number 1, we're just continuing to monitor. Number 2 and 3 on page 2, we are continuing to monitor. Actually, if you'll go with me to page 4. Madam Chair, in September 15th and 16th, you had asked us specifically, honestly, why it was taking us so long to get the TCM folks together. And we did get together September 15th and 16th. I'm on number 5, page 4. That's our first green box. So our update is we are pleased to report today that on September 15th, we did have a meeting with a TCM work group. It was a virtual platform. It's my understanding, I wasn't in attendance, but it's my understanding the meeting was well received. We kind of started at square one as far as values and conflict of interest and where do we want to go with targeted case management with our community-based consumers. So it's my understanding it was a productive meeting and we will continue to have conversations with this group. I have asked Commissioner Amy Penrod and her team to not limit the conversation to just targeted case management, that eventually we need to fold in the conversation about administrative case management. Madam Chair, you'll remember, as will Representative Ballard, that you two were very instrumental in supporting the request for administrative case management a couple of years ago. You heard from Leslie Anderson today that that particular program, if you will, has launched. So there is reason to believe that administrative case management is helping our FE, PD, and BI populations. So what I've asked Amy to do as she pulls this work group together to talk about targeted case management, also have conversations about administrative case management so that we have a big picture strategy, if you will. And if you don't mind, I'm going to go ahead and tag on to what Sarah was referring to as far as community service coordination. We can't have a conversation about community service coordination potential without first having conversations about administrative case management, targeted case management. So it's just a big picture strategy on what works best in our state for these 7 waivers when it comes to coordination, whether that's in the form of administrative, targeted, or something else that's called community service coordination. So just a heads up, we've got that initiative launched and we'll keep moving with it. If you'll go with me to page 5. Oh, Sarah covered that on the pilot. Okay, page 6. Again, this had to do with item number 11. This was a concern that targeted case management wasn't conflict-free from the MCOs. Again, we pulled the TCM work group together. I'll be honest with you, now that I stand here in front of you, I'm not sure if we included MCO representatives in that work group. So I will make a note to myself and ask Amy if we did. If we have not yet included MCO representatives, we should. So let me get with Amy on that. I'm not sure if we did or not. Continuing to scroll through these pages. I believe our next item, we go all the way to page 22. This is Matt Fletcher's issue on page 41. He talks about nearly 100 days after COVID-19, there's still no relief for retainer payments. We agree with him on that. We still have not successfully yet managed to get retainer payments processed to community-based providers. You'll recall at the last meeting, we talked pretty extensively about retainer payments. Retainer payments are the opportunity for states through Appendix K for 1915C waivers. There's a limited number of services that can be approved for disasters. I don't think Appendix K ever expected for a disaster to last for months and months and months and months. But the reality is we did apply for retainer payments. Madam Chair, we talked extensively about this last time. The MCOs are working with us very closely. We think we're close to getting retainer payments out the door. The MCOs will help us do that, and they are helping us do that. So at this point in time, as you can see in our response, I'm here to say today that the payment process is close. We haven't yet gotten any checks yet, but we will. Hopefully by the end of this week, we will have what we are calling revenue comparisons, where we are asking these particular providers to tell us their revenues compared to what the retainer payments might yield, and then the MCOs will help reconcile those. In addition, we did ask for CARES money through the Spark Committee. Members of the committee, I suspect you are aware, we asked for $12 million for our community-based providers. We are working separate from the retainer payments. We are working with the MCOs. They did step up and agree to help us on the community payment processing. We simply at KDADS didn't have a direct payment mechanism to get this 12 million out to our providers. We needed the help of the MCOs, and they did volunteer to help us. So we think we're close. You heard today from a couple of conferees that there is an attestation form attached to that $12 million, and there is. So if you go to our website, you'll see there's a tab that says COVID-19. For community providers is 12 million. We have a table that informs them of how much as a provider they will be, the distribution by provider that they could receive if they so choose. Then they have to attest to the fact that they do indeed want to accept these federal dollars. You heard from Craig that he was only going to accept a percentage of that amount, which is fine. We are not requiring an all or nothing. If you only want to accept a certain percentage, that's fine. The burden of these dollars is on the provider to determine whether or not they've incurred the costs, whether or not they want to accept the federal dollars. But if they do, then the MCOs will process those checks for us. If they don't, then we'll turn those dollars back over to the Spark Committee. They have until October 15th for this particular distribution methodology. They have until October 15th to decide whether or not they can spend those dollars. The federal restrictions are very clear. You have until March 1 until December 30th. Those dollars have to be spent specifically for COVID-related expenses or business interruption from March 1 to December 30th. That is not our flexibility to have at this point in time. So we do hope that some of these providers do accept that $12 million, but it's their decision to make. You want me to keep going or stop for questions?
We'll take questions. Representative Carpenter has a question.
Thank you, Madam Chair. And on this 41 here, the retainer payments, does that involve the financing of that? Does that involve a risk corridor?
It's probably better to ask Chris Swartz or Sarah that particular question, as far as, because that's an MCO question, very specific. So yes, there has been conversation about a risk corridor, but I would defer to Sarah or Chris.
Okay, thank you. Thank you, Madam Chair.
Representative Ballard.
Thank you, Madam Chair. I want to follow up on that. It's up to the MCOs to decide if they want to accept it. Why would they, the question is, why would they not want to accept the federal dollars?
It's up to the provider. If they want to accept the dollars, the federal dollars. And I think you heard this morning that at least one provider was saying they may accept a percentage, but they don't necessarily believe that they have incurred the cost or experienced the business interruption to accept the dollars during that particular time frame. And there's no opportunity for extension at this point. So the providers, in other words, Representative Ballard, we share with the providers in our table how much the distribution could be to them. And then they can choose to accept that amount or not accept any at all. Some may not, Representative Ballard. These dollars have to be spent very specifically on COVID-related expenses or business interruption. So if you're not comfortable that you've incurred those costs or you're going to incur those costs, then don't accept the dollars. I mean, you simply don't want to. The U.S. Treasury has been very clear that these dollars are COVID-related.
Okay, so I was just trying to decide, is it because they have not incurred the expenses, or is there a stipulation, or is the paperwork so demanding that they don't want to be able to do that because you have to, itemize every little minute detail or whatever? Or is the main reason is we just haven't incurred that, so we're not asking for it. So I'm just trying to decide, have you put too much of a burden in order to get the money, to justify having the money more so than necessary?
From our vantage point, no, we have not overburdened the provider community in making the decision as to whether or not they want to accept these federal dollars. What we have said is we're going to ask you to attest to the fact that you understand how these dollars can be spent. There was some confusion in our attestation form that, and we did hear from Sean, there was some confusion from some folks in our attestation form as to whether or not business interruption could be included. And we did ask for clarification on that and talk to several of the providers who called specifically to that, because Representative, what happened is the feds were very clear, and you all know this, that the CARES dollars cannot be used for revenue replacement by governments. That includes counties. So county affiliated CMHCs, for example, you don't want to accept those CARES dollars for revenue replacement. End of story. But can business interruption, can that be considered a COVID expense, and can actual PPE and testing? Yes. So for us, Representative Ballard, we did nothing, in our opinion, outside of the U.S. Treasury Department's and Spark's guidance in our attestation form. That's not to say our attestation form didn't trigger some questions, because it did. We believe we've clarified those questions, but it sounds like this morning, like maybe we haven't. So we'll talk to the providers who call us. We don't think we've overburdened providers any more than the Treasury Department just in general has burdened providers with these CARES dollars.
Okay, I asked that question, Madam Chair. May I continue? I asked that question because I have heard from a few that it is somewhat burdensome in order to do it, that it's not totally clear what, I mean, they know what it has to be related, but related could be several other areas. So that's what I want. There seems, the best way to say it, there seems to be some confusion. And that's why I'm really asking about it. But you've answered my question pretty much on that. But I really would like to go back to retainer payments, because, okay, again, explain retainer payments for whom? And then we're talking about the 12 million for CARES. Now, the average person would say, boy, there's a lot of money floating around here. You know, so please cover the retainer again, please.
And actually attached to this particular log sheet, we anticipated you might ask about retainer payments again. So we did provide a handout on retainer payments that's attached to your log sheet. I've got to tell you, Representative Ballard, we have been in the thick of this since March. There are times we get confused. So we just wrote it down, what retainer payments are intended to do and what they're for. There is nothing, in my humble opinion, there is nothing clear cut about these retainer payments. I just don't think they could be more confusing, but we went down this path. Sorry, Chris. We started down this path and we'll continue to go down this path, but the retainer payments have been incredibly confusing, in my humble opinion. The MCOs are helping us keep this straight. Chris and Sarah are helping us keep these straight. Amy's keeping this straight for us. But the retainer payments, in my humble opinion, are tricky just because they weren't intended for a pandemic that just keeps going and going and going. They were intended for tornadoes and floods where you could come in and help for 2 weeks and then you wrap it up. But this just keeps going and going and going, this pandemic. So it's just taking us a while to walk through and work through retainer payments with the MCOs and what this means. There is nothing uncomplicated about it. Now, that said, Representative Ballard, then you add the PPP money and you add the Spark CARES money and you add the county monies coming from Spark. And if you don't mind, I'm going to circle back to your question a moment ago. I think part of the hesitancy on the part of the providers is they're having to keep straight and keep track of all these federal dollars and now these state dollars and all the CARES dollars that are coming in, including these retainer payments. So what we are hearing from providers is, you know, we'll accept the retainer payments. We expect most of them will accept the retainer payments, but some of those providers have also received PPP payments, which aren't retainer or CARES, they're PPP. And in addition, the county is offering some dollars through the Spark program. So it's just really, in my opinion, a burden on the providers to figure out, for all of our expenses that we've incurred with COVID and for our business interruption, what are our revenue streams and how do they sync up? They have to reconcile. And if they don't, then they might want to hesitate in accepting, for example, our CARES money. So yes, I would agree with you. Whoever said there's a lot of money floating around, there actually is, Representative Ballard. And we say to providers every day, you know, take this seriously. I mean, there's every reason to believe there could be audits down the road. You probably all expect that. We expect that. So make sure you have your ducks in a row when you accept this money. And I'm not trying to be overly dramatic with this, but I will share with you, we are concerned for our providers. We're doing our best to say, make sure you're comfortable accepting this money and make sure you've got your ducks in a row because there probably will be audits. The same conversation we're having with our nursing facilities, which I'll get to here in just a minute. But for our community-based providers, we are hopeful that they accept the money if they're comfortable doing so. Representative Ballard, I'm not sure that answered your question.
Yeah, yes, it does, Madam Chair. Yes, it does. Because it was very confusing to me because I was looking at it, and I have to thank Madam Chair for putting us in the right direction and showing us which one of these to follow with the retainer, because I really was never sure about it. But because there is so much money, whether it's the PPE money, whether it's the retainer money, whether it's CARES, I've had people say to me, there's an awful lot of money out there, and people are saying that, they're not able to make it. But on the other hand, if they're worried about an audit, and maybe they will say that's not allowed and you have it, then you have to pay it back. What do you do? And it's a whole combination. So you did explain it to me, but the most thing you said to me is that it is confusing. And I think we need to untangle some of this so that people will feel comfortable with what it is they really have to do. And I don't know if there's guidelines I saw in retainer here of what it is you have to do so that, the way I understand it for law, if it's not on paper, it doesn't happen, because you can't justify it and there's no proof. So you have to have proof. So I would say if there's any way you can make it less confusing, and even that's difficult for you because I'm sure the rules will change. By the time you get one thing done, they've given you another set of guidelines. I understand that. So that was my whole point in asking, because I believe it's confusing, and I read this and I try to understand it, and then sometimes it is really not clear. And when someone asks me and I can't give them an answer for it, then I feel that we just need to straighten it out. But thank you, you did help. Thank you, Madam Chair.
Well, I think to kind of elaborate onto that, Representative Ballard, I believe that's kind of what we heard from Holly earlier today, was the complexity of this issue and the concern that the businesses have out there of the potential of a clawback on these funds, because we do know the audits will come in. They have to come in, and it's been reiterated, I think, on the federal level that these funds will be audited. And I don't believe that, some people understand just how complex it is. It's not just a matter of us handing money back. And for those of us that were around umpteen years ago, Representative Ballard, you're welcome. When the ARA money came in to help the states out on funding, that money could supplant SGF. This is not allowed to supplant SGF at all. And that's one of the things that the federal government's kind of monitoring. Representative Carpenter.
Thank you, Madam Chair. And I echo the conversation. It's, as the providers, it's so confusing if the agency is confused about what they can spend it for, and then the providers are confused because the agency is not clear. It makes it very difficult, I think, out there to try to spend that money in a way that is legitimate. So to the agency, I would try to make it as clear as you possibly can to these providers what they can and can't spend that money for, period. But, and while we're on that, because you heard the earlier testimony, I don't know if the rest of the committee is as alarmed as I am about this PPE situation, but I got to tell you, why don't you guys get in a room and figure out if we have it or not and how we can get it. I just constantly, we heard of that legislative budget last week about PPE. It just boggles my mind as why this far into this pandemic, or whatever you want to call it, that we're having struggles getting PPE. And I'll have the same question for KDHE when they get here. Where is this stuff? When is it going to be delivered? I'm tired of the talk. Let's just get it done. So anyway, thank you.
Well, I think some of that, Representative, is the question is, are states getting it and then it's not getting dispersed down to folks? Or is it a shortage that's nationwide in order to get it? And I think there's limitations they're being put on it, on what countries the supplies can come from, because some of the problems that they've run into. So the PPE issue has become complex when in our minds as business owners and dealing with inventory, et cetera, we don't see why it should be, but it is an issue. But you're right, we need to have an exact accounting and some accountability so that we know what we're dealing with, so that we know where to put pressure at. Representative Carpenter.
Exactly. And that's what I'm saying. I just want to know what is out there and what isn't, and what's possible and what isn't, so that I have answers when folks are questioning me about this, or I hear these questions. Do we or don't we? I mean, it's that simple. Do we have a warehouse full of gloves and PPE stuff that's not being distributed? What is the real picture right now today? And that's where I go from this.
And I think that's an excellent point. Is there other questions? Continue.
Okay, page 23. Now we'll talk about nursing homes. And this couldn't be more complicated either, just as a caveat, if you don't mind. So on page 23, number 42, let me just begin by saying that the first bullet you'll see in our summary of the funding and the testing and the PPE supplies, when we talk about federal financial resources that have been sent to nursing facilities, we are talking skilled nursing facilities. So Holly noted this morning that her facility is a Medicaid only. So there, let me backtrack just a moment already. So we have skilled nursing facilities, and you all know what those are. Those are Medicaid, Medicare certified skilled. Most of our facilities in our state are Medicaid, Medicare skilled. Some facilities choose not to be Medicare skilled, such as Holly's, because of what she noted in her testimony, that they're not Medicare certified because they've got the hospitals who are Medicare certified in their rural community. It makes perfect sense. Then we've got licensed only facilities that are assisted living, residential healthcare, home plus. Those are the three categories, if you will. So when I say that the federal financial resources, in other words, HHS has sent 331 facilities, 69 million, they have. So in Kansas, 331 facilities received 69 million from the feds initially. And then an additional, or the same, I should say, 324 facilities later received 33.4 million. So those are Medicare, Medicaid skills. That's not Holly's facility. Those are the skilled. So that just gives you a sense of how much money the feds are providing with these mandates, if you will, for testing, for example. On top of that, we, through the Spark and CARES committees and the State Finance Council, approved 38.4 million to come from us. So if you add that up, that's a chunk of change. So that's how much Medicare, Medicaid skilled has received the federal, and then our 38.4 million included Medicaid only, which includes Holly's facility. So when she was talking about the 100,000, that's from the 38.4. So again, Representative Ballard, confusing on all this money that's out there. The 38.4, just to let you know, as of Thursday at 8:33 in the morning, 66% of those dollars have been 66% has been distributed. So 235 facilities out of 357 said, yes, we will accept our distribution of the 38.4, and so far we've distributed 25.7 million. Again, if facilities don't want to accept these dollars because they haven't incurred the expense, or they feel like their dollars from the feds have covered it, or maybe they participated in PPP also, that's their decision to make. I will share with you, we have had facilities decline. Some facilities are saying, no way, we will not have incurred enough expense to justify receiving any more dollars at this point. We can't incur enough costs between now and December, and that was even with the testing mandate. The testing mandate came from the feds came with money. So I know we had at least one provider say to us, not directly, but indirectly, we're not going to accept the CARES. We can't spend that much money, even with the testing. Now, that's not what every provider in this room you're going to hear from, but we've had some. We had one nursing facility actually ask us if they could just send us invoices and we would pay for invoices. And we said, good heavens, no. But the point was, I thought it was a good point. Their point was they're so nervous about all this money coming to them and having to justify it. They actually asked, could we just send you invoices and you pay us out of this 38.4 for the invoice? And we of course had to say, no, we can't administratively handle that. So just to give you a sense, most of the nursing facilities thus far, 66% have signed the attestation form and said, yes, we'll take the money. Some are not. Again, there's been nothing simple about this. So on top of the 38.4, we asked for 10 million to help us. Oh, sorry, Madam Chair.
That's all right. I just want to touch on, what was the number you said on the 38.4 million? Because like on the 69, you showed us 331 facilities. You said the number of facilities, but
357, Madam Chair, and 235 of those have accepted. 357 facilities. And actually, if you go out to our website on the COVID tag, you'll see the tab, you'll see our list. There's a table, all the facilities names listed, how much they can receive if they so choose.
You said 275?
235.
35, thank you.
235 out of 357 have accepted the 38.4. On top of that, we asked for $10 million in response to House Bill 2016 for PPE, essentially. But here's what we did. Because CMS has sent so much money for PPE and supplies through the 69 million and the 33.4 million, what we said to the Spark Committee and to the State Finance Council is we'd like to use that 10 million to build a pathway to PPE and help assisted living and residential healthcare and Home Plus providers, the state license only, because they've received nothing from anyone at the federal level at all. There was conversation at the federal level, from what we understand from Linda Mowbray and Deborah Zaire, that the feds were talking about trying to find a way to get some money to assisted living, but I don't know if that's going to materialize. What we did with this 10 million and said, let us help the licensed only facilities, because your House Bill 2016 included all adult care homes, not just nursing facilities. So those assisted living and residential healthcare haven't received any support. So the bulk of this 10 million is going to be to actually pay for PPE for assisted living providers and other providers. And Scott Bruner can talk to you about that later today. And then obviously nursing facilities can use part of this 38.4 to gain access to PPE through that pathway that we've created, but then they would have to pay for the PPE themselves.
Janice, when you talk about the state license, so you have your assisted living, and then does that also include retirement communities?
Well, it will if they're licensed for assisted living, residential healthcare, Home Plus. So yes. Are you talking about CCRCs, Madam Chair? Retirement communities as in CCRCs, where you might have freestanding living.
Yeah, they have their own apartments, but they'll utilize the dining facilities and, those types of things, but they don't provide skilled care.
Yes. So yes.
So that would be under the license, the communities. Okay.
So I'm going to give you an example. Take Aldersgate, for example. So if Aldersgate, they have a skilled nursing facility, so they'll be getting part of the 69 million and the 33.4 and part of our 38.4, but then because they also are licensed as assisted living, then we will distribute dollars to them for their assisted living, and that they could use that for their staff who also, if someone's in a freestanding apartment, then their staff would also have access to PPE. So yes, it just felt like we were, well, it's not really how it felt. It's actually what you ask us to do. House Bill 2016, you ask us to cover adult care homes. So this was our way to do it, was the request of 10 million. Scott will be here this afternoon. He's actually sitting at the EOC this morning and has been for a couple of weeks, just taking calls. I'll be honest with you, this testing has been so confusing to actually answer questions. Scott and Lacey Hunter have been our staff sitting out there. I'll be honest with you, I wouldn't even be able to sit out there and answer questions. The testing is just, well, anyway. So Scott will be here this afternoon to answer questions specifically about the PPE contract. He does expect to have a contract executed no later than October 1. We're a few days outside the 90, but we've been working on it. Trust me, we've been working on it for months. So he will have a contract executed that with a vendor that will gain the pathway to PPE.
So does that mean then all of these organizations then that the 69 million, et cetera, et cetera, et cetera, would then have access to this vendor contract supply chain, is what you're saying? All of these that we just talked about in these three above lines.
You are correct. If they choose to, now, if they choose to use that particular vendor, that'll be up to facilities. Here's what we did for assisted living, residential health care, and the state licensed only. What we're saying is we will provide you with $225 for 2.5 months based on your number of beds. And we will provide that number to this particular vendor. And then if an assisted living provider wants to take us up on that offer to order from that vendor, we will cover it in this 10 million. We won't do the same thing for nursing facilities per se. They will contact the vendor directly and make their own payment directly. That's been our approach, Representative Landwehr.
But they'll still have access to the vendors to stay, okay.
Exactly. So we have cleared a path that they will have access to. And then the supply chain through the local emergency management, I'll let Scott talk to you about that this afternoon, if you don't mind, with KDM and sitting at the table and sitting in the room at the table and hashing this out. That has been happening, but I'll let Scott give you an update if you don't mind, because the last thing I want to do is confuse it anymore. So I'll go down to the rapid testing machines. You've already heard a lot about the testing machines. We meet with the nursing facility trade associations on Teams, Microsoft Teams, every single Tuesday. We've done that now for about 3 months. This became so obvious that the communication needs to be so constant. We meet every single Tuesday with Deborah Zare, Linda Mowbray, and Bill, and a couple of their other staff. What we might do as a result of hearing today's testimony, we might just suggest to those trade associations to include a couple of their members, because what we heard from Holly today, what I heard in the other room, was more detailed than sometimes we hear on those Tuesday calls. So it might behoove us all if we just had some of their members on those calls also, so we make sure we have a better understanding of what's actually happening every single day in nursing facilities. So that will be my suggestion to Deborah and Linda and Bill. And then one last thing, and I think, Representative, I think I need to hustle. I think I'm taking too long here, is we also requested 10 million in additional funding for testing from the CARES Spark Committee. And that 10 million wasn't directly approved by the State Finance Council or the Spark Committee. The Spark Committee said, and the State Finance Council both said, let's take this 10 million and fold it into the 33 million reserve and fold it into the 50 million, and let's have a statewide initiative. Let's have some statewide response to all the testing. So at this point in time, we are not expecting to get the 10 million directly for us to try to oversee testing, but instead it'll all be folded into a collaborative initiative on testing. Okay, I'll move on and I'll hustle. Representative Landwehr, I think I'm taking too long.
Well, we'll take whatever time that we've got to do to get through these answers here. Did you have something, Representative Ballard?
Thank you. Just briefly. Okay, so you've asked for an additional 10 million, and then you're asking for another 10 million that you don't know that we're going to get or not. But of that 38.4, I believe, of that money, you've distributed 25, I wrote it down, but I'll go back to 25 million of it. But I think if all of this money that's there and people are choosing not to apply for it because they may not have spent enough on COVID and everything else, what's going to happen to all of that money that they have not claimed?
We will turn it back over to the Spark Committee. So we let me just give you some idea of timeline. So we gave nursing facilities until September 30th to let us know if they're going to take us up on the 38.4. So we've got a few more days here. Based on the 66%, you know, if we were to predict, I would say, hey, we're not going to see 100% within the next few days. So we're going to turn some money back in the 38.4. Some of the facilities are going to walk away and say, we don't want to accept this, and we'll let Spark know immediately. The 12 million that I mentioned earlier for the community, we gave them until October 15th just because we were working with the MCOs to distribute this for us. And while they've been hustling, we just simply weren't going to put that kind of pressure on them to get the monies out as fast as we could with the nursing facility. So we gave the providers until the 15th to decide. I'll go ahead and share with you now. We got some input from some feedback from the MCOs last week, and we've only had, I think out of 400 and some providers, we've only had about 90 sign the attestation form. So we may not have a lot of providers who want the $12 million or portion of that. That's their decision. I do think we've still got enough days. We'll see an increase there. So we've got the 12 million, we've got the 38.4, we've got the 10 million for the PPE. Unequivocally, the 10 million will most likely be spent. I think assisted living providers will take us up on the 10 million to buy PPE. I do think that will happen. The 10 million on the testing, we're not going to get that money. That's going to be rolled up into the testing. I'll be honest with you, Representative Ballard, that's not even all of it. I mean, that's not even all of it as far as what we're tracking. There's even other CARES dollars. The point is, we will turn this money back to Spark just as fast as we can. And we are working with the Spark Recovery Office almost daily to give them updates.
That's for the clarification. So if that money goes back to Spark, can that money be used for PPE?
That money can be used for, well, I don't want to speak on behalf of the Spark Committee or the State Finance Council, but they've got their priorities. Yeah.
Yeah, but if they chose, okay, but that's,
Yeah.
okay.
Yeah.
Thank you, Madam Chair.
You know, Janice, it kind of sounds like to me that we need to have, you know, how many testing sites do we have available to us out there? What is the cost? You know, what are the different costs? What, you know, how much does that cost? And then what is the turnaround for those sites? I don't know how in the world that these nursing facilities are able to do all the testing that they need in a timely manner to, you know, allow people in their facilities and all of this good stuff. And it still goes back to, you know, somehow, and you know, maybe it's, you know, bringing our legislative members together and us firing a letter off to our congressional delegation that some pressure really needs to be put on to allow the state for CDC or CMS, I guess it would, or CDC, which whoever's controlling this, to allow us to address some of the needs in our own facilities to release some of this burden, because we know they're strapped in the first place. Then we come in and we cut their budget, and it's like, and put an additional expense on top of them. And if these facilities go under, it's not a good thing for the state to be taking them into receivership. We all know that. We've worked to really get out of that business. That means less care for our aging population. And Kansas is a graying state, period. We're not going to change that. It's been that way for, well, ever since I've been up here in the legislature. And, you know, baby boomers turned 65 in 2011. So it's.
Well, Representative Landwehr, if I may even add to that, and then we give them all these dollars and ask them to keep it all straight as far as what you're using to pay for what. I mean, I think it's tough. I mean, I think it's tough out there for all the providers. I think it's difficult to just track all this. I think it's just difficult. And I'm not trying it. So let me keep going if you don't mind. I mean, it's been tough, Representative Landwehr, as far as trying to make sure we can help as fast as we can, do everything we can, but understand that the providers are having a tough time. Holly mentioned today the fact that you know, her county had gone from the red zone to the green zone. Secretary Howard did make the decision that we will use KDH&E testing, we will use KDH&E positivity rates. So the CMS did give the states the authority to decide which positivity rate do you want to use. Do you want to use the CMS positivity rate or your state or your local positivity rate? And Laura, Secretary Howard did make the decision quickly. We will use the KDH&E positivity rate. And you heard Holly say that took their county out of the red zone to the green zone, which means they can test once a month instead. So we are doing everything I believe we can as fast as we can to make the burden not quite as onerous on these providers, but it's tough.
Well, and I'm not saying that the agency's doing that, and I'm just thinking that we need to pull together and get our congressional delegation to pay attention to stuff. But I think it's going to be help us in the future as we start making more decisions on, you know, how many test sites are out there. Because I know just listening in the Sedgwick County area, I know that Wichita State University is, I believe at the end of this month, they go online with their lab. And then they've been required to come in and provide more than just one type of testing. And the average cost there, that's $60 a test. And we still don't know what that turnaround time is going to be, because it's pretty tough. You test on a Saturday and you don't hear back until Wednesday or Thursday of the following week. You're almost halfway through your quarantine.
We are hearing from the trade associations that some staff are just saying, we quit. I mean, we quit. We're just not going to subject ourselves to all this testing. We quit. So, I mean, you know, yep, I agree with you, Representative. On page 24, number 45, and then you talk about PPE for our community providers. It's one thing to have PPE for our nursing facilities. We need PPE for assisted living, residential health care, and then we need PPE for our community providers, which House Bill 2016 didn't include community providers per se. So 45 from Luann Kibbe and Mitzi is that, you know, community providers have had difficult times getting PPE also. So Representative Carpenter, your point that we just got to get in a room and figure this out. We do thank the MCO, Sunflower in particular, has helped get PPE out to our community-based providers, and we appreciate that. On page 25, number 47. Oh, this is actually the infection control. And if you don't mind, Lacey Hunter will talk about this afternoon at 3:30 in our slide deck. But Lacey did note in this particular September response that KDAD's completed the infection control surveys of all adult care homes between March and August. And this last sentence is incomplete. So I called her and she filled in the blanks for me. The results of these surveys concluded that 21% of the certified nursing facilities and less than 1% of the state licensed only did we issue citations on infection control concerns. So just a heads up, we did conduct all those surveys and the results are there. And Lacey will can speak to that more this afternoon. On number 48, the targeted case management, again, we appreciate the comments from the conferees. We would like to have the opportunity to see how administrative case management works along with targeted case management and have some time to do that. You know, one suggestion might be at some point in time, you might want to ask Michelle Morgan during the legislative session, who's running the contract for ACM, to let you know how it's going. Leslie provided an update today. I think it's going pretty well. On number 49, this again was that there's no reporting, and this would be, we responded to this. However, it really is a KDH&E reporting issue as far as what they're reporting for COVID. And I'm sure Dr. Norman and his team will talk about reporting this afternoon. On page 26, number 50, this was from Mike, and Mike talked about this again this morning, that he urges us to reinstate the MFE program. We would love the opportunity to do that. We are currently in communication with the folks at CMS to see what that might look like. Some new opportunities presented themselves last week, but because Kansas doesn't have an MFP current program, again, we are not in the loop. We are asking what we can do to get back in the loop. We do have a meeting scheduled with Luann Kibbe and Mike on September 30th at 2 o'clock. So we are also interested in what can we do. Number 51, with what can we do to ensure the network adequacy of the SILs. Specifically speaking, the MCOs help us with supporting our provider networks. So we'll look to the MCOs. However, we would also agree that the SILs don't have direct funding per se. So that's something that we will encourage them to continue to bring to us and continue to bring to you. And then number 52 is essentially the same concern, that there just simply isn't enough support out there for the Centers for Independent Living. And we would not disagree with that. So with that, Madam Chair and members of the committee, I will stop unless there are more questions.
Committee questions? I guess, you know, with your response on the last one, with this response, and I'm not, you know, trying to beat up on you with this, Janice, at all, because I know that we're in some tough issues and everything in that, but, you know, it appears to me that we're never going to resolve that.
And that we could never ask for funding and get the funding?
Mm-hmm.
Really?
Well, let's just look at the $22 million cut that the IDD population took. I mean, they didn't expect that, or the cut to the nursing homes. And, you know, I don't know that we're necessarily making, you know, some of the right decisions on that, because I think the Interhab is correct when they talk about we're spending probably more than that, well, and the SGF part of that, I think, was 8.9. So we're probably spending more than 8.9 in SGF for hospital stays because there's not an option to cut those. And that math has got to, we've got to sit down and run that math to realize that, you know, we're cutting off a foot that could be used to help in other ways because we're having to pay for it in hospital stays that we don't get to come in and choose to cut in those types of things.
TA.
I mean, you know, the devastation that I've seen and I've heard from constituent stuff on that IDD side is just absolutely heartbreaking. And I don't know whether people just don't think that their votes count or that their voices don't count. But that just, and I know that wasn't your decision to make. So, you know, you're just the messenger sitting here before us today. But, you know, we haven't been funding this stuff right. I mean, if you look at the mental health stuff, that, you know, we finally just started getting some more funding back into that. And they took a hit, you know, all the social services folks took a hit. And these are some of our most vulnerable. And you know, from my perspective, I don't understand why some of the other budgets weren't hit. You know, concrete over children, concrete over, you know, our most vulnerable folks. So, but I think the testing issue, we've got to get some clarity on that there, like we mentioned earlier, and we have to get clarity on this PPE situation and understand what our folks are actually dealing with and why they still don't have it today. And I know some of that's not necessarily in your control, in your hands, but if there's pressure that we can help with or whatever, then we need to know that. Because I think that that's only going to grow. And I think it's, you know, we're probably headed into a different storm because of the similarities of COVID symptoms and flu. And there are going to be people wanting to get tested that normally wouldn't have, because it's like, oh yeah, I just got the flu. So I'm, you know, and most of that time you can do the over the counter, but you can't always take and do that on everything over the counter. So we don't get our arms around this testing, we're in trouble. Further questions, comments, committee in the room, committee members on Zoom? I can't see anybody, so I assume you can, Dave, or not? No, you can't. Okay, all right. Janice, thank you very much. We appreciate it. And don't ever worry about taking too much time because, you know, we like to see the details. So we appreciate it. Now that's Representative Concanon.
Thank you, Madam Chair. I just want to express that I am confused by all of these spreadsheets, that I'm sure they were put nicely in my folder in the order that I was supposed to be using them, but I've made a mess of them. Could we have them labeled next time?
Dave and I just had that discussion, There will be better labeling because, as you notice, I kind of had him come over here and talk to me, and then I watched Representative Ballard. I watched and Will and went over and explained because I was totally lost as well. And so they
Thank you.
had.
Thank you. I'm glad I wasn't the only one.
No, you weren't the only one there. So I'm hoping the folks at home were able to gather what was going on there. Any further questions or comments? Well, there's just, there's just a lot of things for us to track. And I think, I appreciate this spreadsheet and I appreciate the ability of staff being able to designate items that we want to continue to monitor so that we don't forget about those. And I know that they're always looking at ways to improve this spreadsheet, but I think it's really kept us on target. So I've appreciated it a lot. Okay, now that's all I had before lunch. Have I missed someone that should have been visiting with us? I can't believe I'm ahead of schedule. This doesn't happen to me. I always run late.
You better write it down.
Yeah, I want a star. I want a star for this. Actually,
I'll give you $1.
Actually, it's the second time it's happened this year. The mental health committee had happened on it. And it kind of scared us a little bit.
What's
So
going on?
2 thumbs up from Crawford County.
what?
2 thumbs up from Crawford County for being
Yes,
ahead of
appreciate that,
schedule.
Representative Mernan. I need all the help I can get. Oh, she is? Okay, never mind. Okay, so I guess committee being, we did get done early. We're going to have an early break for lunch because I don't know that we want to try to pull all of these people in here at the last minute. We're only 30 minutes ahead of time right now. So we will recess until 2 o'clock.
There's other people scheduled. I had a staff meeting to go and I thought, oh, damn, I don't ever leave, but I left this time and things, what the hell in the handbook? But then I realized it was all kind of messed up.
Yeah, after 2 or 3 touchdowns. Dave, how are you, buddy?
Canceled everything. We had a big offsite. Well, our offsite was going to be in Seattle this year. Off in October. And obviously that was canceled for multiple reasons. But between riots, air quality, and COVID.
There's man. Gentlemen, how do you do? Hey, Dave, how are you? Good. Yeah. 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 I mean, she's doing something.
My neighbors, I know I stood up at night. I think they all are.
We just need a little cowboy hat.
Well, I did ask one of my constituents.
I love it.
Yeah. I said, beside the other one, my goat t-shirt. Well, I made this one. Well, she said, have you been tested? I don't know what.
Yeah. Yeah, that's good.
I like it. So white, so it's the white hat.
Yeah.
Well, you see me now.
I do too.
Okay, so you have to find a prevention.
And this is supposed to be easier to come.
Every once in a while, I find the perfect spot where it doesn't fog up, and then it shifts slightly, and then the rest of the day. What do you think?
Well, I hope this afternoon goes quick.
There's this going on.
Where did everyone go?
Well, I can't listen to them. That would have been one part, but I got about an hour and 15 minutes. You got me. Put the gates at 7:12.
When we have the taco.
It was okay with me. I'm interim on emergency
And get there, yeah.
Great.
10 to 3. That's good.
Good.
We're doing what we can.
Why don't we go sit down? Bye. See you over there. Mr. Vice Chair, crank this thing up. Well, yeah.
The nightmare we're currently.
Wait. Yeah. There we go. Yeah.
United Health Group. So I'm kind of here to find her on the United Healthcare guys for a little bit.
I'm assuming Scott's busy.
I think that's big concern.
Hey, David.
I'm not very good at math.
No, I pulled my mask off. I've gone through 2 pairs of glasses because of that. They broke.
Good afternoon, Madam Chair and members of the committee. I'm here by myself. Lisa was unable to travel over here for this, so she just had me. I'm the CEO of Aetna Better Health Kansas, and I will walk through our updates. We just have a few on the spreadsheet. First one is item 4. They're on the spreadsheet where I have colored them Aetna purple.
Oh, it's about the third page. Like this, I have it. I wait here. There you go. Susan and I cheated and we had Dave sit down a couple small words before we left for lunch.
So the green, yeah, so there's green ones, we don't have any responses on those. Those were specific. There's nothing NCO specific on those. And then the next one, which is the stapled one, which has yellow on it.
The next page, sorry.
Chair, would you like me to clarify this?
Oh, yeah, I'm sorry. I apologize. I had told Dave he's gonna help explain for us. You're good. You're good. Just sit down. You're not violating your mask.
Madam Chair, I just wanted to clarify for the committee. So there's a number of different packets that do look similar. So this is a packet of information. It is a paper clipped packet. There is one page that has a green column, and on the front page, you will see at the bottom, there's a date reference. That date says July 24th, 2020. And this will be the first page from Edna and Faye just discussed. Behind that paper-clipped copy, there is a document that has the rest of the recommendations, and it has a yellow column. So that's the group that Edna will be using. And then the document packet that will follow is United's packet, and that packet is on standard paper rather than legal paper. And there is not a packet for Sunflower similar to this. So I just want to clarify that for the committee.
Thank you, and I apologize. It was a long time since I seen you last, so. You know my memory thing. Now, welcome back to us.
Yeah, I will make sure we have an Etna at the top of it. So on that first sheet, which has the green, none of those are Etna specific, so we don't have any responses to those, so you put that aside. So in the one that's has the yellow on it, the first one that requires a response is number 4. And I've highlighted it in kind of a purplish. On this one, this is related to service plans. Our response hasn't changed since what we provided last time, but we have adapted to the current environment, and we will meet with the members and designate our attorney virtually. So we are demonstrating flexibility on that. Next one is let's continue to monitor is number 11. On this, our response remains unchanged, and we continue to follow all KDHE and KDAS policies. Next one is number 16. Again, remains unchanged. We continue to use the state provider portal process and follow all contractual requirements. Then the final one, I believe, is number 34. Continue to support any fee schedules through passing those through to any contractual contract provider. So if fee schedules change, we will pass those through. I think that's all I had this meeting were pertained to.
Any questions, comments? Anyone on Zoom?
Madam Chair, this is Senator Petty. I have a question.
Senator Petty.
Thank you. If I am looking at the right sheets, back to number 16, you mentioned that nothing's changed. So are you not using the,
We need you to talk a little more towards the mic, Senator. I'm sorry.
okay, are you not using the same credentialing process then, or is there work towards that? It appears that that's not occurring. That's been an ongoing question. Is that, am I looking at the right sheet?
Following the state credential process.
I'm sorry, I didn't hear you.
On number 16, we continue to utilize the state provider portal process and follow all contractual requirements. So we are following the state process.
Okay, thank you.
Are there further questions? I'd just like to comment, I think that we know the rocky road that you started down and you've now made it a smooth road. So I give you kudos for that and thank you. And I hope you felt better presenting before us today, not going, oh my gosh, I got to go tell them something now. So
thank you.
We appreciate what you've done and how you've responded to our questions as well as the agency.
Thank you. Thank you for your support.
Next committee, we have Michael Steffen, President and CEO of Sunflower Health. I can't hardly recognize everybody with their mask on, I tell you. We'll start making you wear hats that identify. Welcome to committee.
We would be happy to do that. Thank you. My report will be brief. I'll refer to the same packet that you just had in front of you. There were no specific items on the spreadsheet for Sunflower. And so the same 4 topics that David referred to would also apply to us, and there have been no changes since the last meeting.
Okay, I guess we've got people that are listening in that are not able to hear the conferee, so you guys got to get closer to that mic.
Okay.
Start over, I'm sorry, Michael.
I'm Michael Stevens from Sunflower Health Plan, and I'll refer to the same spreadsheet that David just did. There were no items on the spreadsheet specific to Sunflower Health Plan, and there is no new item that references us, and so my answer would be the same as David. We continue to monitor, and we do follow those same processes as well on item number 16.
Okay. Questions for Michael? I'm going to ask you, and then I'm going to have David come back up, is what have been some of the have you had positives, and what have those positives been in stories that could have been maybe little disasters if you've dealt with COVID? And if you really haven't had any, that's fine. But we just know that everyone's been kind of struggling with this.
Yeah, I think the positive story has been the collaboration between the 2 state departments and the 3 MCOs with regular meetings, with a spirit of let's do what we can and what it takes to benefit those that are covered by KanCare, and let's all be flexible. And the 3 MCOs have met daily through much of COVID and continue to meet twice a week even now to make sure that our responses are the same so that it is easiest for members and providers to work with all of us together. And really, I credit my colleagues at the other 2 MCOs along with the state leadership of KDHE and KDADS for building the environment that allows us to collaborate. And really, I think it's been a success for the entire KanCare program.
Thank you. Comments, questions? All right, seeing none, thank you very much. David, I'll ask you that same question. I know you all have presentations later, but it's always good for us to hear good news.
Sure. I would definitely echo Michael's comments, the collaboration with the other MCOs and the departments, but also with provider associations and all the providers in the state. There's always natural friction, but I think we've all worked very well together. One member story that I have in the deck, but I'll share it now because I know, even though we're on, I know I'll be on at 5:40 when the meeting ends at 5:30, so there won't be time to share it. But we had a situation where one of our members became homeless due to domestic violence issues. And she was unable to get into a domestic violence shelter because they denied her admittance because she hadn't had a COVID test. So our care coordinators worked with her and her child. We got her a hotel and put her up in a hotel until she was able to get the test, and was able to place her in a shelter and is now
back out on her own and doing well. But and one of the things that we did as a managed organization is we weren't going to let somebody, if you need a place to stay, and that's our job, that's our mission, that's why we're here.
That is awesome. Thank you very much. Next, we have Carrie Kine, is it Kines or Kims? Director of KanCare Provider Relations and Strategy with United Health. How bad did I butcher that?
You were right the first time. Carrie Hines.
Okay.
I'm the Director of Provider Relations and Network Strategy for United. And my update will be very similar to the other two gentlemen who spoke before me. We had the same 4 items that we carried forth our updates from the last meeting. So no new information or United specific items to report. And to your follow-up question about stories from COVID, Kevin actually has a slide specific to that he's going to speak about this afternoon. So if you would let us defer to his testimony, that would be awesome.
All right. Questions, comments?
Representative Landwehr?
Yes.
I just wanted to say thank you to United for the extraordinary things they're doing for our federally qualified healthcare center down here in Southeast Kansas, recently funding a project that supports seeing people in their homes, taking food, whatever it is, just making connections at the front door with our patients. And so thanks for that. We really appreciate it.
Oh, thank you so much. We really enjoy working with our FQHCs.
Further questions, comments? All right, seeing none, thank you very much. I do have to give kudos, I think, to all 3 of our MCOs. It's kind of nice to see the list dwindle, and I know it still looks big, but that's just because there's items that we want to make sure that we keep track of, so we're just kind of monitoring those. So if something comes up, we don't totally forget it, and then we remember what we've kind of done in the past. But I think that they're all doing an excellent job and have stepped up to the plate during COVID. We also have committee. Okay, next we're going to have KDHE updates, and the first one we have is KanCare program, and who's doing that one? All right, come on up. Oh, he does exist. I thought maybe he left.
No such luck. Good afternoon, Madam
Well,
Chair.
I'm going to say that, but go ahead.
Good afternoon, Madam Chair and committee. Thank you for the opportunity to provide testimony. Some of these, I think you know a little bit about already. Personnel changes. You obviously know from before Sarah Furtick, who is our new Medicaid director, and welcome her aboard. Dr. John Esslinger, the Medicaid medical director, retired. He actually came to us a little over a year ago out of retirement. I twisted his arm, and so we're in the process of recruiting a new Medicaid medical director and serving that role on an interim basis. KanCare, continuity of operations. I have to give a great shout out to the healthcare finance team of Sarah and Chris and Mark and the rest of them. It's been anything but easy, as you can imagine, with a lot of moving parts during these last 200 days. We've been at this, and we've been in incident command now for 38 weeks, and lots going on. The MCO, innovations and cooperations, as was provided testimony just a few minutes ago, I must say, have come together, the 3 of them come together in a very cooperative manner and solved problems and innovated. And I think the tip of the hat to those folks as well. And in addition, working with our own team internally. The COVID-19, of course, and I'm not going to get too deeply into it, except to say that it stretched our personnel a lot, and across all 3 divisions, really. But there's been a lot of things that have come out of it, I think, that have been helpful. One of the things that I think about your community is mobile testing. We were just there last weekend in Abilene.
Excuse me, Ms. Milk Secretary, do we have written comments from you?
No, I'm just providing oral testimony.
Oh, okay.
Okay.
No, it's not. He doesn't have written testimony for you.
No, it's just the people that follow me will have the packet. And but the mobile sampling and testing has been something that has been great to get into communities that have not had strong medical presence and or have had outbreaks, and that's been something that's been really quite good. I think that Chris is going to talk in just a minute about the Families First Coronavirus Response Act and its impact on Medicaid, which has been helpful to us. And again, with the you heard about it earlier this morning about the expansion of codes, including telehealth and virtual visits, which has been a godsend to people who are at risk from leaving the house and coming out. So unless there's any questions for me, Madam Chair, I'm going to turn it over and to Sarah Fertig and then to Chris, and then I will close it out.
All right, that's fine. Welcome to the committee, Sarah.
Thank you, Madam Chair. Sarah Fertig, State Medicaid Director. I have been in this role since July 13th, so I'm coming up on about 2.5 months in this role. As Dr. Norman alluded to, prior to serving as the State Medicaid Director, I was the Medicaid Inspector General for about 2 years. So I spent 2 years looking at the Medicaid program from the outside, and now about 2.5 months looking at it from the inside. And if you'll indulge me, just before I get into the slide deck, I wanted to share a couple observations I've had in the 2.5 months I've been with KDHE in this role. And one of them is, and this should come as no surprise to any of you, but Medicaid is an extraordinarily complex program. I knew it was complex from my prior work at the AG's office, but however complex I thought it was, it's 10 times more complex than I thought it was. So it is exceedingly complex. And that kind of flows into my second high-level observation, which is that there are a lot of very, very skilled staff at KDHE. It takes a lot of expertise to know and understand all of the federal requirements that govern Medicaid, all of the clinical decisions that have to be made on a day-to-day basis, the financial decisions. It is very, very complex. We are lucky to have a very, very highly skilled staff to help us get through this and an efficient and compliant manner every single day. And so for my tenure, as long as I'm in this position, one of my priorities is going to be to try and make sure that we value those employees as much as we should, because it's truly remarkable, the work that they do. And we'll go into that a little bit later, but I mean, just the response to COVID alone has required such a tremendous amount of manpower to make sure Medicaid keeps going. So I'd be remiss if I didn't mention that. In my testimony today, Madam Chair, if you're okay with it, there are the last 3 bullets under the KDHE portion on the second page of the agenda dealing with eligibility. If it's okay with you, I'd like to bump those to the end of our presentation so that Chris Sports can handle those, and I'll just take the other bullets. Okay. So starting on page 5 of our slide deck titled KanCare Update, Robert G. Bob Bethel KanCare Oversight. That's what we're working off of. So we'll start with the HCAP update. And just a quick refresher on what HCAP is. HCAP is a healthcare access improvement program. And state statute provides for a provider assessment to be levied against hospitals across the state. Currently 1.83% of inpatient costs. There were some legislative amendments that were made to it within the last session that would allow KDHE to pursue CMS approval to get up to increase the assessment up to 3% of inpatient and outpatient. So what we do with the revenues generated from that assessment is we use that to draw down federal matching funds. And then those funds are distributed in a couple different pools of money that are governed by statute. But a large beneficiary of that are hospitals. So it's a very important program. And as I believe Chris Sports mentioned to the committee back in June, in May of this year, we found out that CMS was not going to approve our proposal to amend our 1115 waiver to allow for the full scope of HCAP that was contemplated by statute, to allow for the full 3% provider assessment on inpatient and outpatient. And so that kind of threw us for a loop. My understanding is that my predecessor, Adam Profit, worked really, really hard to get that through. And we were receiving some communications from CMS that we thought it was going to happen. And so everybody was really caught off guard back in May when we found out that CMS was going to approve it. So we had to kind of reconvene and decide what's going to be Plan B. And the Kansas Hospital Association has been really, really helpful in helping us figure out what Plan B is. We've had a number of meetings with them since I stepped into this role. They've also made available some outside expertise, which has been really, really helpful to help figure out what the next possible step is. And so throughout this work with KJ and the outside experts, we've figured out that we think CMS made a technical error when they were conducting our budget neutrality calculations back in 2018. And we think that that error is to the tune of about $395 million. And so our Plan B is going to be to approach CMS, ask them to correct that technical error. If they're able to do that, that will add about $400 million to the Kansas budget neutrality cap, which is the total amount of money, state and federal, that we can spend under our 1115 waiver over the 5-year period of the waiver. So our Plan B is to submit that. We're finalizing that proposal now. We've got some more information from our actuaries on Friday. We're hoping to get that submitted by the end of the month. And then once we hear back from CMS, then we'll figure out what amount from that additional about $400 million up to our budget neutrality cap we can comfortably afford to put towards the provider assessment. And then we'll come back to CMS and ask them to increase the provider assessment by that percent. It's kind of complex. Madam Chair, I don't know if you want to entertain questions now or wait towards the end of my presentation, but this one's pretty sticky, so I imagine there might be some questions.
Committee, are there questions? Senator Solomon.
Thank you, Madam Chair. What would be the reason they wouldn't recognize and correct the error? Is there any?
You know, honestly, Senator, from what I've seen, I don't know why they wouldn't. It seems pretty cut and dry to our actuaries as well. This was something that was left out. So we're pretty confident that they are going to approve it. However, it's kind of within their discretion if they want to do it or if they don't. So what I've been hearing from a lot of our partners is that CMS's decisions have been a little bit unpredictable in the last couple of years. They've had a couple serious personnel shakeups. And so I don't want to bet money on it, but we're pretty confident that they would approve this. But it's really within their discretion if they want to approve or disapprove.
Well, I'd sure like to, excuse me, Madam Chair, but I'd sure like to make sure that we are clearly aware of that on a regular basis. I don't care if it's week to week or what. We need to visit with some others to discuss this little issue. Okay,
Sure.
Thank you.
And so you know, Senator, we're maintaining contact with the Kansas Hospital Association on this all the time. So we want to have kind of a coordinated communication plan at the DC level. So we want to make sure that the communications are consistent on that once we send the proposal.
Representative Carpenter.
Thank you, Madam Chair. Yeah, that's kind of disturbing. The 3% is really kind of in the middle. Aren't there states that have as high as 6% in HCAP?
Honestly, Representative,
I believe there are. Down here at the bottom of in this last bullet here, it says, KDHE will work with KHA about the increased HCAP the state can afford. There's no state money in this. So are you talking about what the hospital assessment would be for the hospitals?
I appreciate that question. Thank you for giving me the chance to clarify. We understand that that's not state money that's being used to draw down federal funds. What we're referring to there is what we can afford to stay within our budget neutrality cap under our 1115 waiver. And that's where the affordability comes in. You can only spend so much money combined, state and federal, and HCAP's part of that. And if we spend above that, then the state has to pay it back in SGF money. So it's really important that we stay within our budget neutrality budget. And that's what we're referring to here. Because every policy decision that we make that increases a fee or anything like that, that all kind of cuts into our budget neutrality. And so we have to make sure we stay within our budget neutrality cap. So that's what we were referring to there.
Committee, are there further questions? So, and maybe I missed this one in there, was on the technical error, was it something that we left out, or they just looked at it wrong, or?
We think that CMS made an error by omitting certain expenditures when they were figuring out how much money our without waiver amount would have cost. So we think they left out some expenditures that the state had incurred between 2012 and 2017, that should have calculated, what they do is they figure out how much, they guess how much the state would spend with an 1115 waiver and without waiver. And we think that they left out some expenses in the without waiver. And that's keeping our budget neutrality artificially low to the tune of about $400 million, we think. But to more specifically answer your question, we think this is an error on CMS's side.
Okay, so I just want to clarify, we think or we know?
Well, our actuaries say they absolutely did.
Okay.
However, it's a matter of CMS kind of applying their own policies. So we definitely think it was a mistake. However,
Okay.
CMS has the final
Right,
say.
no, that's kind of, no, I understand they do their own
Yeah.
little thing, but I just wanted to find, how we were approaching it from our direction, so, okay, thank you. Are there any further questions, committee? See none? Good, I asked Barbara's question, she didn't have to ask me.
Are we ready to move on? Okay. On slide 6, we're talking about update on the regulations for the protected income limit. And we provide some background here. So about a year ago, the protected income limit for HCBS increased from $747 a month to $1,177 a month. There were some legislative provisos that were included that made that change effective. However, we needed to catch up on our end with the regulations. And so since June, we just found out about a week and a half ago that our regulations had gone through the approval process with the Division of Budget, with the Department of Administration, with the AG's office. And so we're planning to publish notice of the public hearing in early October, which would mean that the public hearing itself would take place in early December. It has to be at least 60 days following the notice of public hearing. And then after the public hearing is held, assuming we don't make any further changes to the regulation, they'll take effect 15 days upon publication in the Kansas Register. So all of that means I'm hoping around Christmas, the regulation will be effective. And if anybody has any questions about that, I'd be happy to answer. Otherwise, I'm happy to move on to slide 7, One-Care Kansas.
Madam Chair,
Yes, Senator Petty.
could I ask if the speakers could take off their mask? It's a little harder to hear when we're online. And the sound has changed since the morning. It's a little more kind of tunneled. I mean, it's okay, but I really would appreciate it.
Madam Chair, if you would like me to take off my mask.
If you would, please,
Okay.
if you feel comfortable doing so.
All right, hopefully I can hear it a little bit better now. So moving on to slide number 7, One-Care Kansas. This program launched on April 1st of 2020, which you're probably thinking is a splendid time to launch a program right after the pandemic began. But so far it's going pretty well. So far we have 37 providers who've applied to be One-Care Kansas providers, and 33 have already been fully contracted. This information is current as of about a week ago. We currently have about 700 members enrolled in the One-Care Kansas program, with 412 being enrolled in the asthma population and with about 300 being enrolled in the SMI population. So we're planning to look at some audit tools, and we expect that 6-month audits will begin next month. And so far, it seems to be going very well. We are hoping to expand the number of individuals enrolled in KanCare Kansas, so we're exploring internally if there's anything that we can do to further, I guess, market the program and demonstrate some of the benefits that it could have for the target population.
Senator Saltontrop.
Just a quick one. So what you're doing is just trying to develop a scope of work and determine if they're meeting that, the providers.
Are you talking about the audit tool?
Where you're trying to develop an audit process.
Mm-hmm.
So is that just defining the scope of work and making a determination whether your providers are adhering to those guidelines?
To be honest with you, Senator, I'm not sure specifically what our KanCare Kansas team has in mind for those audits, but if you'd like, I can get that information and get it back to you.
Further questions? Carpenter.
Thank you, Madam Chair. Just a very quick one. I know way more acronyms than I ever wanted to, but what is SMI?
Serious mental illness.
Representative Landwehr?
Is that Representative Murnau?
That's me. Sarah, thanks for the update. I just wanted to let you know, I recently have spoken to a provider here in Southeast Kansas about this program, and they have about, I think, 59 or so folks enrolled, and it's working really great. And I was one of the people who was a little hesitant on when we started this because I didn't think we funded it enough. And I didn't think that we gave enough thought to operationalizing it. And when I say we, I mean legislature, not the department. But I want to say that I think it's working well here in Southeast Kansas. I think there were some bumps with enrollment with the different MCOs, but upon asking for help with that, we got that right away. And it's really making a big difference here, and very cost effective is, just keeping some folks out of those higher cost services. And so I just want to say I was kind of a critic, not because of the concept, but because we just kind of put a small amount of money towards it. So looks like you guys are doing a great job on it. Thanks.
Thank you. Any further questions? Seeing none, proceed.
Thank you. Moving on to slides 8 and 9, the Disability and Behavioral Health Employment Support Pilot Program. This is one of the items that was included in our issues log. So slide 8 contains a little bit of background for those of you who might not recall what we're talking about. Our 1115 waiver for 2019 through 2023 includes the authority to operate this pilot program, and it will include up to 500 eligible KanCare members. And we've been working with an advisory board to help design, see what the program is going to look like. And as appropriations allow, we're hoping to hire 2 additional benefits specialists that can work with this program, as well as the Working Healthy and Work programs. On page 9, we talk about what's been happening since the last Bethel committee. And originally, this pilot program was supposed to be up and running in July of 2019. There are a variety of reasons why that has not occurred. Our target go live date is July 2021. And to help expedite the process, we're looking to bring in an outside contractor to help us put together a program manual and an implementation plan. We think that will help speed up the process quite a bit. The staff we have internally who are working on this now are very, very busy working on temporary unemployment plans for the Working Healthy and Work population. And it's taking a lot of time to make sure that those members receive the support that they need. So we frankly, we don't have the bandwidth to put together a manual and a comprehensive implementation plan internally. So we're looking to bring in an outside contractor. We hope to have somebody on board, I don't know, in the next couple of months, depending on how long the contracting process goes. We had also reached out to our KEYS contractor for an estimate to see how much it would cost to build in pilot program specific codes into our eligibility system that would allow us to track this pilot program discreetly from other eligibility groups and also allow us to do specific reporting. And we got some sticker shock on that. Their estimate was $1.6 million. That is only on the keys side. That has nothing to do with our claims side on the MMIS side. So we thought that is a cost that is not really sustainable. That's not really something we can pay for. So we kind of regrouped from that and we're looking at internal ways that we can track these folks. And we think that with a pilot population of up to 500, we can do a lot of this internally. It might require some manual work, but we think that we could do that for a heck of a lot cheaper than $1.6 million. So that's the route we're going to go. And I'd be happy to answer any questions that anyone has on our progress so far on that.
Any questions? Representative KanCare.
Thank you, Madam Chair. Thanks for the presentation today, Sarah. What, on this pilot program, what's your goal? What are we working towards here?
Well, our goal is to have a program kind of like what Working Healthy and Work already does, but for the behavioral health side. So we're looking at individuals with serious mental illness diagnoses, such as schizophrenia, so that they can enjoy some employment supports and allow them to be successful in competitive employment. That's the goal.
And in that process, are you assisting them to find work?
There is some pre-employment supports. So there are some services that would be provided to help folks gain employment, seek and gain competitive employment. So yeah, that's part of it.
And then you're tracking I'm just trying to get my arms around the whole concept. Are you tracking then their healthcare costs once they're employed, with the assumption being that an employed person will be healthier?
Well, I mean, CMS always wants lots of reporting. So there are some specific reports that our waivers, special terms and conditions are going to mandate that we do. But really what we're looking to do is see how successful these folks are. You know, once they're admitted into the pilot program and they start receiving those supports, are they successful in obtaining and maintaining employment? How are they doing income-wise? Are they doing financially better than they were before? And, you know, since we will be able to track them, you know, we do have access to health data that could kind of suggest health outcomes. So, you know, are they able to, you know, maintain their appointments with behavioral health specialists? You know, how is their, you know, if they're on medication, what's their compliance like? So, you know, we would have access to some of that information, but primarily what we want to see is increased employment rates for this population and successful employment. So you can find and keep a job for longer. That's the main goal.
Okay, thank you. Helps a lot. Thanks, Madam Chair.
Any further questions? Sir, I've got a couple of them. Who is the advisory board?
Oh, boy.
And if you want to get that back to us later,
Okay.
that's fine.
Thank you.
And then was there any SGF that was put in that in the 1920 or the 2021 budget?
Yes, I believe so.
Do you know what those amounts are?
I might phone a friend. Mark, do you know off the top of your head? Okay. We can get that to you if you like.
Okay, appreciate it. Thank you. Any other questions, committee?
Okay, moving on. Slide 10, the next several slides are going to be talking about a COVID-19 update. And some of this information is going to be duplicative of what we had in June, but we thought it was important to show you kind of cumulatively what's been going on since COVID began, because a lot of these things kind of intertwine together. One important fact at the bottom of slide 10 is that on July 23rd, Secretary Azar renewed the public health emergency through October 22nd, 2020. This is important in a couple of respects. One of them is that the increased 6.2% federal financial participation that the state has been benefiting from since this began, by law, it terminates at the end of the quarter during which the public health emergency terminates. So this means that if Secretary Azar does not extend the public health emergency, our 6.2% increased federal financial participation will go away at the end of the year because the public health emergency is in the fourth quarter ends December 31st. If he extends it to January 2nd, then that means the FFP, the 6.2% FFP will continue through March 31st, 2021. So we're keeping a very close eye on this because it has a big effect on how much STF we're burning through on a monthly basis. Turning to page 11, a lot of this information is what we provided in June. It's here for background and context for some additional work that we've been doing. We included in there policy flexibility for telehealth. I know you've been hearing about that. That's been a subject of a lot of discussions internally. Turning to the next page, we wanted to share some additional special authorities that have been exercised across the program since June 2020. We've submitted 3 additional additive Appendix Ks. These are kind of special emergency authorities that CMS can approve. Additive Appendix K number 3 was important. That allows for up to 3 30-day periods of provider retainer payments for those 5 waivers. That was a big one. Before that was approved August 6th, we only had approval for 1 30-day period, so that was pretty significant. And then additive Appendix K number 4 at the bottom of that slide. This would provide, we haven't gotten approval from it yet, but it would provide for medically necessary support and personal care services for school-aged kiddos with an IEP during periods of remote instruction in order to ensure their health, safety, and welfare. We were hearing that there were some kiddos who their school districts, for whatever reason, were unable to provide these supports, and so they were reaching out for help. So I don't think we've received approval on that yet, but that's one thing that we're trying to do to make, the pandemic maybe a little bit easier on some vulnerable kiddos. Turning to the next slide. These are
Sarah, just a moment here.
Sure.
Let's go back to on page 11 on the telehealth piece. Would you, and maybe it's a small list of what the codes were that you opened and what those codes do?
I think we have them outlined in some of our bulletins. Later on in our slides, we have links to some of those. I don't think I could recite them all off the top of my head.
That's fine.
A lot of them are behavioral health related. So,
I'm just wanting to look at, because telehealth is going to become a big issue for this next legislative session on what we do and what we don't do. And it would be good for us to know in advance what codes you have opened up and what do each one of those codes do.
Sure. Would you like us to send that to you?
Yes.
Okay.
Well, I'll send it to David and then he makes sure that we get all of it. Representative Carpenter.
Thank you, Madam Chair. Just a quick question. So back to the bottom of page 10, July 23rd, 20. Our original estimates at the 6% was going to save us around $100 million. So was that through July 23rd or was that through the entire year?
I'm not sure what the time frame that was based on, but we're seeing it's about $40 million in SGF savings a quarter. So that number may have been March through July.
I was just curious if we were estimating that 100 million to be till July 23rd, and then with this increase here, it would be another 40 million more.
Yeah, it's about 40 million a quarter that we're not spending in SGF.
Could you find out what the total would be at the 6% federal match for the, I suppose, to the end of the year, if it was to the end of the year, I suppose, for this.
Okay.
So, and then just, we talked a little bit about eligibility here. Are you still, what is your guideline now for allowing continuing eligibility?
Well, Chris Wards is
She's going to talk about that. Okay. Okay, very good.
I might defer to her, if that's okay.
All right, thank you.
Sarah. On the appendix K4, I'm trying to understand, so what services are we looking to provide for IEP students and why? And who will provide those services?
Well, personal care services, that's one example for that. So if you have a student who's in a remote education setting and they need assistance toileting, stuff like that, that would be some of them. Those are some of the ones that we were talking about. KDADs might actually be in a better position to describe those in greater detail, as this was an item that was brought to us, to KDHE from KDADs, based on communications.
Representative KanCare.
Thank you, Madam Chair. So to follow up, the reason for this would be that they're no longer, they would be receiving these services if they were in school, if they were in the school building.
Yeah.
And by remote, they don't have access to these services. So
We were hearing that there were, and again, KDADs, they were on the front end of these conversations. We just heard it kind of secondhand from them. But our understanding is that there have been situations across the state where a kiddo is in a remote learning environment and they really, really need these services in order to be successful in a remote learning environment. And the local school district was unable to provide those in-home services for them. So we were trying to fill that need if the local school district was unable to.
thank you, Madam Chair.
Okay, when you say we provide, so who would be providing them if it's not the school district?
Representative, I can't answer the details on that. I would defer to Kate. That's all.
I'm getting a head nod there from the secretary, so she'll be able to elaborate on that.
Yeah.
She probably understands where I'm going. Yep.
Yeah, we'll talk about that in our presentation.
All right, I appreciate that. On K3, I know that we had some discussion on retainer payments at our last meeting, but this looks like perhaps it involves more than the retainer payments that were discussed last meeting. This is correct?
I don't recall what was discussed at the last meeting, but this was the scope of the Appendix K that we submitted. It would across those various waivers. I think a lot of the focus has been on the IDD side, but there's some providers that provide services to more than one waiver group.
Okay, could you at some point, we don't have to have it today, but if we could look that up, because I think you're right. I think it was on the IDD. I don't recall discussion about any of these other waivers. So I'm just kind of surprised we're hearing about them today. Okay.
Okay, back on slide number 13. These were just some of the changes that were made. A lot of this was duplicative from information we had in June, but again, this is important for context. One significant change on the first bullet point. Back in June, we reported that we were delaying annual eligibility reviews by 120 days. We have now kind of indefinitely delayed those based on public health emergency extensions. I think back in June, we were cautiously optimistic that the PHE would be ending sooner than it actually has. And so as long as we are accepting the additional 6.2% additional federal funding, we cannot discontinue somebody from eligibility for Medicaid unless they voluntarily leave the state or unless they ask for their eligibility to be terminated. Those are the only reasons why. So that is kind of delayed indefinitely, and that's really the only change on the slide since June. Moving on to slides 14 and 15, this is just kind of a visual depiction of all the policy tweaks that we've had to do on the KMAP side in response to COVID. And this is a public website. Anybody can go there and look this stuff up. It's very important. One that I wanted to
Sarah, I'm sorry, maybe I'm just missing some things. So we touched on the first bullet point, but did you go over the other bullet points and I just missed it?
Oh, no, Madam Chair, I did not. This was information that was presented in June. If you like, I can go through them point by point.
All of those points were?
Mm-hmm.
All right, thank you.
So then on slides 14 and 15, these are some of the policies that we have adjusted in response to the pandemic. One that I wanted to bring to your attention is on slide 15, that first column at the very bottom, 20088 reimbursement to providers and facilities serving the uninsured. There was some testimony this morning about uninsured individuals and COVID testing. Just so you know, there's a bulletin there that informs providers how they can seek reimbursement from HRSA for COVID testing and treatment for individuals with a COVID-19 diagnosis if they're uninsured. So we've got that information on there for providers.
Okay, so they may have private insurance, but it doesn't cover it, so then they would be considered uninsured?
I'm not sure if that would fall under HRSA or not.
See, I think that was some of the issues that some of the folks were facing this morning. It's not just being uninsured, it's their insurance companies that they do have don't cover it.
That may qualify as uninsured. I would argue, as an attorney, I would argue that they're uninsured at that point, Madam Chair, but I'm not sure what HRSA would say for that. So we wanted to highlight that just because that's, and we've received questions about that as well. What are we supposed to do if someone's uninsured? And so I wanted to highlight that.
Well, it might be something that we want to check into, whether it's you guys or it's KDADS, because I think it's a big issue for our nursing home folks. If there's some way that we can help them out, that would be great. Representative Ballard.
Thank you. Just a clarification. I'm looking at slide 15, and I'm looking at the telemedicine, the different codes and everything else. And I went down, I'm looking at 286 mental health crisis intervention codes. Are there additional codes? Because we've always had some telemedicine codes, am I correct?
To my knowledge, yes. My understanding is that in some instances, what we've done is open telemedicine to different technologies. So, and it's possible that televideo was not previously approved, now it is, or previously telephone was not approved, now it is. So sometimes that's what it is. It's expanding the types of technology you can use to deliver.
So they're not necessarily new, but more modernization and updating and everything else.
Yes, Representative, that definitely happened with some of the codes.
Okay, thank you. Thank you, Madam Chair.
So then telehealth could be telephone or video.
It depends on the code.
Okay, go ahead.
Okay, slide number 16 also includes some additional COVID-related bulletins that are on the KMAC website. And again, you know, these are public information, anyone can look on them. And then moving on to slide 17, this is kind of the transition into analytics and performance metrics. So I'll go through some of this information for you. On slide 18, this shows the distribution of KanCare members across the 3 MCOs, and you'll see that the percentage distribution is remained very steady between 2019 and 2020. United tends to have the most members at about 37%, followed closely by Sunflower. Aetna's holding steady at 27%. So those numbers haven't changed very much. On slide 19, we show how many claims have been processed year to date in 2020. And in the bottom, the lower right corner of slide 19, you can see the total percentage of claims that have been denied. It's fairly low, 15 to 16% overall, so most of them go through. Switching over to slide 20, and this provides kind of a different graphic of year-to-date claims compared to year-to-date denied claims. And you'll see that again, the denial percentage is pretty low over the course of 2020. And as usual, pharmacy has the highest percentage of denied claims, but that's because it's a point of sale service. So sometimes, you know, if you need the medication today and you just got approved today, eligibility information might not be through that service yet. So moving on to slide number 21, percentage of clean claims processed within 30 days. The contract standard is 100% of clean claims within 30 days. You'll see where we are at the top in calendar year 2020. And one thing that's of note on this slide is Aetna's claim turnaround time has improved quite a bit from calendar year 19 to 20, if you look at those charts. So those numbers have come up quite a bit, and we're very happy to see that. Moving on to slide number 22, we can see claims processed within 60 or 90 days, non-claim claims, and all claims processed within 90 days. And overall, those numbers are looking pretty good as well. On slide 23, we talk about member grievances, showing 2020 versus 2019. And at the bottom, you can see the top member grievance trends for the second quarter of 2020. And as per usual, transportation is pretty high up there. And then moving over to slide 24, we see resolved member appeals versus, or 2020 versus 2019. You'll see that the numbers are down a little bit for second quarter of 2020. That's not super surprising since, you know, a lot of things kind of slowed down during COVID, so that's not terribly surprising. And then moving on to slide 25, these are provider appeals. And how many of them were resolved within 30 calendar days? And the contract standard for that is 98%. And then how many were resolved within 60 calendar days? And for Q2, all 3 MCOs hit that 60 calendar day mark, so that was good to see. And moving on to slide 26, these are some of our metrics for the customer service center.
I'll have you back up just a minute to slide 24. I guess I want to know what Sunflower's doing versus Aetna and United on the pharmacy piece. That's quite the difference.
I would prefer Sunflower not.
Okay, that's fine. And Sunflower knows much about it.
Okay, so back to slide number 26. These are just some of the metrics for the call center to see basically how quickly, you know, the calls are being answered, how many times a member just abandons the call. So that shows you where we are with members, and overall the pickup time is pretty quick, low call abandonment rates, so that's all good. On slide 27, we see the similar numbers with regard to providers who call the customer service center. And again, pretty fast pickup rates, pretty low call abandonment rates as well, which shows that they're doing what they're supposed to be doing. On slide 28, we include the MCO profit and loss per NAICS filings. This is for the second quarter of calendar year 2020. And overall, the MCOs are doing okay. I expect that those numbers will shift as the rest of 2020 moves forward. And I'd be happy to answer any other questions. Otherwise, I'm happy to turn over for an eligibility update with sports.
One thing I think I'd like to see in the future is on the codes, because I think some of these are probably KDHE and some of them are probably KDADs. Would that be correct?
The telehealth codes? Yes.
So it could be one or the other, correct? It's for us to identify which ones are which.
Okay.
So that we know who to ask the questions of. I think we've got one we're going to ask a question on, but it's probably KDAD. Representative Solomon, do you have a question?
Thank you, Madam Chair.
Oh, he's my senator.
Sarah, I am. Have you had any conversations with the AG's office about the criteria for the next Inspector General?
No, Senator.
They asked, have they reached out to you or said anything?
I did speak with them before I departed from that job and kind of gave some thoughts. It's such an odd job. It's kind of unique. So I did share some kind of parting thoughts on what I thought would be appropriate kind of criteria. Some of it's statutory, but no, I've stayed out of that. I've not had any conversations with them on finding that.
Well, I hope there would be at least some input so that you would feel comfortable with the type of recruit you might be looking for and the responsibilities here for oversight of the program, unless you don't want that critical look.
No, in fact, Senator, I tried to convince Jay Andler to take the job permanently.
No, I'm serious
He
about,
turned me down.
I'm serious about providing some input, so thank you.
Sure. And Senator, if I may add, I can tell you just from having worked with Derek Schmidt for 2 years in that role, he's very, very aware of what that job requires and knows a lot about the skills that are required. He was involved when that position was created. So, I mean, in terms of having confidence that the AG's office knows what's required and if they're going to recruit appropriately, I have full confidence that they will. They know what they're doing. And now, Madam Chair, if you like, I'll go ahead and turn this over to Chris Swartz for an eligibility update.
Further questions or comments? All right, go ahead. Thank you very much for being here this morning today. Welcome to committee. Yeah, I was gonna say, do you feel comfortable taking it off? That would be good. Thank you.
I can do that. Good afternoon. I'm Chris Swartz. I'm the Director of Medicaid Operations for KDHE. Thank you for the opportunity to give you an update on what is happening in the eligibility world. I'm going to start with my presentation starts on slide 9. I'm going to provide an update on the status of the Medicaid applications in 29.
29. Thank you.
I'm going to start with an update on the status of the Medicaid applications. Then I will follow with a little bit of an update on the transition of the processing of elderly disabled from a contractor to the state. Provide the last update on that. And then finally, status on the request for proposal that we issued in September of 2019. And then I will start maybe by answering Representative Carpenter's question about the what we're doing for the eligibility, non-discontinuance of eligibility. So the guidelines that we're using for continuing eligibility is we are not terminating people at review time because it does not meet the criteria that that are imposed on us in order to qualify for the 6.2% additional federal participation. So if we continue doing the reviews, but if the reviews generate a potential discontinuance because we're sending a pre-populated review, our reviews are done, are processed, and if they're meeting all certain criteria, they're automatically reviewed without any intervention from the beneficiary. You have to verify that none of the information, the economic information, financial information has changed, like their salaries, number of children, and that kind of stuff. So those will go automatically for the system, and you continue to go automatically for the system. Those review, but we can't do a match, or we don't have all of the information to do a match, that will generally generate an action from the beneficiary. We send them a pre-populated form for them to fill out and return to the states. Those have been stopped because we can't discontinue anybody unless we choose to lose the 6.2%, which I don't think that's something that we want to do. So those continue until we will resume doing reviews, and at that point in time, we will have a plan to review all of these people that have been put aside during the emergency, and then at that point in time, they will just go for their regular review and either continue. Not all of them were generated in discontinuance. Some of them are generated in an actual approval and continuance. It just didn't automatically move forward.
Representative Carpenter.
Thank you, Chris. I appreciate that. So CMS has, let's just say they have medical expenses, then that cost continues on. At some point in time, will we be responsible for that, or will CMS pay those bills until
further notice?
No, CMS covers these people, and they do understand that these people are continuing on the program and they no longer have financial eligibility. In compensation for that, that's why they provided to the state the 6.2 additional % of federal participation across the program, so that we don't incur all of the cost of continuing these people, because part of it is SGF, that we're continuing when the person eligibility continues, their cost, there's a share of the cost between the federal government and the state. So we're continuing these people, and we're continuing to bear the SGF cost of these people, even though they may not have eligibility anymore financially. Compensation for that, the federal government is giving us a 6.2%. They are covering the federal piece of it regardless, and it will never come after that.
I understand that, but I think my biggest concern is, depending on how much money we incur, we've talked about an additional $100 million this year. If we continue on at this rate, our SDF portion will also eat into that $100 million figure of savings. Is that not correct?
It will, but you will continue to get the 6.2% additional SGF, additional federal participation across all of your other beneficiaries. I think in the end, you're not going to be out of money, because the feds are covering the regular cost of these people at the regular federal participation, plus the 6.2%, not on just those people that we're continuing, even though they may not qualify anymore, but across all of the program. I think in the end, we're going to be okay.
Okay. I mean, our FMAP is now what, 43, 57.
Is it 57 now? We did increase it 65, so 6.2 of that.
So we're 65, 35.
Mm-hmm.
That could eat into our $100 million that we're getting. I mean, I'm just saying, I just need to be honest about the $100 million versus, there is some cost involved in that.
And the $100 million that you were talking about, is it just the dollar value of the 6.2%?
Right.
Okay.
That was projected at the beginning of the year is what we
Yeah.
would increase.
I think it's a little more than 100 million, isn't it?
If I'm following the question, correct,
No,
I'm
you
sorry.
just go ahead and step up and tell us who you are, because of our folks out there.
Sure. Mark, I'm with KDHE. If I'm following your question correctly, Representative Parker, are you talking about what the increased FMAP is worth? Is that what you're doing your 100 million? Yeah, so like the January through March quarter was about 55 million additional with feds provided, and April, May, June quarter was roughly the same. I think it was a little bit more, maybe closer to 60. I didn't get you the exact number, but if I'm following you correctly, that's the 100 million you're speaking to.
Okay. Thank you.
Thank you.
However, at the end of the year, we're going to get another 100 million. So that would be a total 200 million. Because a 6.2% increase doesn't disappear until the end of December of this year. As Sarah mentioned, it's if the emergency is still in effect at the beginning of the quarter, which will be the 1st of October for the federal quarters. And in this case, it is because it expires on the 22nd of October. Then because on the 1st of October, we're still under the emergency situation, then we get the 6.2% till the end of December of 2020. Should it be extended past that quarter, then we would get another quarter. But so for this year, we're expecting to get about $200 million extra federal funds to cover those people that are continuing the eligibility for a period of time.
I don't disagree with you there. I think that we are paying 35 cents on every one of those dollars, though, is what I'm trying to get to, is it's not just the feds picking up the bill. We are paying our FMAP share.
Yes. You are correct.
All right, thank you.
All right, so the rest of the eligibility, the application processes are going very well. I mean, the report is about the same as what has been submitted to you for the past couple of meetings. The total number of application in-house is always under 3,000, which as of 2 or 3 days from today, it was at 2,796 application in-house. Only 184 of those applications were over the 45-day statutory requirement to be processed. However, only 30 of those had all of the necessary information for us to actually process. They were in an active status. The other 154 applications were either pending some information from the beneficiary, a provider, or some institution, financial institution. The two graphs at the bottom is basically representing what I just talked to you about and showing the split of where the applications that are over 45 days fall under and how many there are. Are there any questions about the application process? Thank you.
Committee, any questions on Zoom? Representative Carpenter.
So we brought all these folks in-house to process these elderly and disabled claims. And we were down to just a few. So could you tell me the reason why we're now up there again in the thousands?
We're not up there in the thousands. The thousands is the number of applications we have in-house, but the ones that are over 45 are only 184. Yeah, this is just our regular workload. Yeah.
I was looking at a little over here.
Right.
Disabled.
Yeah.
So we are doing well with
Oh, yes.
in-house folks.
Yes, and this is a combination of all applications. That's the elderly, disabled, and the family medical. So the family medical is only the over 45s, we only have 6 of them, in over 45 status. The elderly and disabled, the long-term care are about 24 of those. So this is the split. And the elderly and disabled and long-term care will always be a little higher because of the type of information that we're requiring. It's an asset test type of financial evaluation, and it's always a little longer to do that. Thank goodness we're not in the thousands.
Scared me too.
Well. Yeah. All right, so transition of the workload for Maximus, I think we are at the end of that, but we committed to report on it, for a full year. And since it started in January of 2020, I continue to report. So we did complete the transition that started at the end of middle of 2019 on January 1st of 2020, and all processing, answering the calls when it's related to specific call to eligibility. All of this is done by in-house state staff for the elderly, disabled, and long-term care population. They answer, any of those calls. We also established right after the implementation of right after we insourced all of these processes, we established some rapid response calls because we wanted to know immediately after the implementation of the program whether it was working or not, what challenges were experienced by the stakeholders, whether it was an MCO, a provider, or a beneficiary. And those rapid response calls, kind of ended from a natural death. Basically, nobody participated in it within about 6 months of the program being implemented. So we discontinued those, but we will continue to have this kind of a process in place. Should we make some drastic changes anywhere during the program, because these work very well when we do something new. We have bi-monthly meeting with the nursing facility associations, and we continue to have those. There's some agenda, items, and it's basically evolved, from reporting on capital problem to discussing, more program issues or what we want to do better kind of things. And then, so there's a little chart that shows kind of the transition date for each of the pieces and when it happened, with the final date being January of 2020 for the full transition of all processes. So I'm going to give you also an update on staffing. Because we were concerned about being able to find sufficient candidates to bring in 313 people, which was the number of people that we had estimated would take to actually operate the program efficiently. So we filled the majority of our positions, and we continue to recruit and hire staff. As you can see in the table below, we still have about 41 vacancies, which is 13%. 13% is the positions are vacant. And that will be a continued process, to hire and recruit and find the right candidates. So I don't think that I have anything other to share here with the group. It's been pretty consistent that we were at 13%. And at this point in time with COVID, we have a lot of staff that are either not working because they are being put on quarantine, or their children have been exposed to something. So we're operating, I would say, at about 60% of the staff that is there. So a lot of the things have been repurposed so that we can maintain the processing of the application current.
Senator Solontrop /
Thank you. It was for 7 years.
I know.
Can you tell us a little bit about Conduit? Other states have worked that in, and how it came about that you selected them?
So that's my next slide, where I'm updating on the clearinghouse contract. And I want to thank Secretary Norman for letting me do this. I told him, please let me do this. For the last 3 times we had to say, we can't talk to you about it. We can't talk to you about it. So he humored me and let me do it. So we started our RFP process in September of 2019. And in January of 2020, we first amended the Maximus contract to change the scope of, work and have them continue processing just the medical eligibility application, family medical eligibility application, and the state insourced the elderly and disabled. We went on procurement for a new contract because their contract was expiring at the end of this year in December of 2020. The procurement was complete in August of 2020, and we awarded the contract to Conduit. We followed the procurement process of going out for bids, received bids, evaluated the bids, and Conduit was, thank you so much. And Congregate was the selected bidder. So Congregate is also operating in Indiana in a clearinghouse that is very similar to ours, where they're doing a comprehensive work. They don't do just either telephone or putting together information. They do the comprehensive work that our clearinghouse is doing, where they actually do a pre-screening of the cases and do a recommendation for eligibility that then the state finalizes. And so that's one of the states that they are operating in. So they started, the contract was awarded on the 5th of August, and we have started implementation and transition of the work and everything to this contractor. Now the COVID-19 delayed the award of that contract, and we are now on a super aggressive timeline to implement transition of the work and have that new contractor come in, find the facilities, do the recruitment of staff, get trained on our processes and policies, put all of this in place, and take over January 1st of 2020, which is the day after the previous contract is ending.
Do you know anything about the cost of that contract?
Yes, it's a 6-year total contract if you have the 3 optional years executed also. And that is $136 million contract over the 6 years. If all 6 years, there's a base of 3 years and then 3 12-month term, optional additional terms that we can exercise. The total value is $136 million.
Over 6 years.
Over 6 years. Over 6 years, yes.
Representative Carpenter.
Thank you, Madam Chair. The other thing is, will they be using our mainframe keys then? Are they bringing their own equipment or how's it going?
No, they have to use the state eligibility system.
Okay.
All eligibility workers, whether they are KDHE, DCF, or contractors, have to use the KEYS eligibility system as a system of source.
Thank you.
You're welcome. And I think that concludes my presentation. There are no questions.
Now, I'm going to assume that on this contract that you guys have put in some good clawback provisions for poor performance, et cetera.
Yes, ma'am.
Well, I assumed,
Yes.
and I assumed correctly, but I wanted to have your verification on that. Are there further questions, comments? All right, thank you very much.
Madam Chair, any further questions for me or the rest of the team?
Well, I did, and then I forgot them. There was some comment that got brought up. Let's see if I can go back and jog my memory. Oh, I know what it was. Because we've had some discussion about this morning, and then there's just been discussion within, as far as us and legislators and our constituents or stuff, is how you, let's use your office as an example, is if one of your employees tests positive, what happens?
Well, they would have an interview with a case investigator who would find out who their close contacts were. The person with the positive test would obviously put in contact or be put in isolation and quarantine themselves. And the close contacts would also be quarantined until which time they were invited back to work after a 14-day period.
So if I'm sitting next to the person that tested positive, I'd be put under quarantine as well?
If you were within a close enough distance and for a long enough period of time, yes.
This is what I'm struggling with, is our hospitals don't even do that. Our hospitals, a person tests positive, they don't even test their employee, even in close contact. They don't test their employee unless the other employee that didn't test, unless they show some symptoms, and they don't quarantine that individual. So we're trying to understand, we're just trying to get a better handle on
Sure. Well, that's
what
a common
everybody's
question.
doing, why they're doing it, et cetera.
Common question. In hospitals, we typically wear medical grade PPE, a properly fitting and fit tested N95 mask, or a surgical mask and face shield with eye covers, gloves, gowns. Although the gloves and gowns are not necessarily needed to prevent that which you just described. The kind of PPE that people wear in the community is not medical grade PPE and would not be of the same quality, if you will, for preventing that exposure.
So what grade did you say the mask was? Not the N95, I understand.
Yeah, but then it can be either one of two things. It can be an N95 mask by itself, or it can be a surgical mask, just like the one I have here, with a face shield. And both of those instances require eye protection to be considered medical grade PPE. The bottom line on that, is a great question, is that if a person is in medical grade PPE as just described, they won't, nobody around them will be a close contact if they also have medical grade PPE coverage. They will not have a close contact.
Representative Ballard.
follow up with that, because you said eyes, and no, you know, they've talked a lot about nose, mouth, and eyes. But then I read an article in the medical journal that people that wear glasses are better protected. So have we added eyes, or have eyes always been there and I was not aware of it?
Eye protection's always been there.
Okay.
Further questions? Senator Solomon.
Thanks for being here, Mr. Secretary. You got a new Medicaid director now. You've taken the long-term care eligibility and operational portion in-house. You've replaced Maximum and with Conduit. So what else is left to do before we could say, Mr. Secretary, get something cleaned up or get it right? Are we at the end, or do you see any major changes?
I think really, great question, Senator. I think the only major change at this point is to bring on a Medicaid medical director. We've always had a Medicaid medical director that, and see, they're key for particularly around pharmaceutical use and selection of what's on formularies, and to help guide the care teams and work closely with the MCOs. That would be the last team member that we would need to put in, and I think we're in stability operations. After the Maximus contract rolls over to Conduit, I would consider that point going forward to be stability operation.
Okay, I'm looking for your recommendation on that additional position.
Yeah, it's a hard one to fill. It almost has to be somebody that wants to get paid about a third of what they would if they were in a normal clinical practice, to be honest with you.
That's hard to fill.
Are there any further questions? All right, seeing none, thank you very much, Mr. Secretary. All right, now KDADS is up, and I'm assuming it's going to be Secretary Howard to start us off. Welcome to committee, Secretary.
Thank you, Madam Chair and members of the committee. I appreciate the chance to be here, and as you said, kick this presentation off. I thought I might take just a few minutes and maybe revisit or highlight some areas I know that you might have already touched on today, but I think, and that will be touched on in more detail by my team. But I wanted to reference just a few items. And we'll be working from the document KDAD's updates on requested topics in terms of the document in front of you. My own comments are just oral, as were Secretary Norman's. One of the areas where we're spending a lot of effort right now within KDADS with regard to our nursing facilities has to do with the whole issue of visitation at long-term care facilities. And as you all know, such a tremendous toll over the last 6 months as those doors closed and as the ability for folks to visit with their loved ones, particularly in person, really was closed off through guidance from CMS that was issued about 6 months ago that made only very, very limited exceptions for end-of-life situations and define that in really, really narrow ways. So it's been about 10 days now since CMS took action to provide more flexibility. And so part of what we've been about in these last 10 days is working closely with our associations, nurse facility partners, really to make sure folks understand what that guidance is. And then we're also working on some things we should have in final form in the next day or so, some things that might be more accessible for family members and for residents to understand what they should expect. Because I think one of the most critical pieces for folks to understand is it's not going from 0 to 60 miles an hour overnight. And there are still circumstances based on the positivity rate in certain communities, or if the facility has had a recent outbreak where indoor visitation would still not be allowed. So we're working hard on that issue. And I might just mention for this committee, the CMS guidance, it obviously puts emphasis on outdoor visitation, which already some of that had been going on, but then it really encourages and really requires facilities to develop visitation plans if they're in counties that are in the low or moderate rates of visitation that include indoor visitation. And as I said earlier, I think broadening that compassionate care reason for visits, even where there's a high level of COVID transmission, to include those things, for example, where an individual might be struggling emotionally. They might have other things going on that aren't necessarily about their physical health per se. Again, I think really, really time for that. We do also have a new opportunity as well through the new federal guidance to use some of the federal civil and monetary penalty funds that states receive in terms of fines that happen from the surveys and inspections that we do of nursing facilities. And we can now use that to purchase things like outdoor tents or plexiglass providers, the kinds of things that we see everywhere in retail to support our facilities. That's a brand new allowance within the last 10 days when that new guidance came out. So we'll be standing that up just to allow folks to make requests. Again, small dollar amounts, but it certainly may help some facilities as they're trying to transition on this. We also are using that federal guidance to develop our own state guidance to apply similar kinds of criteria to our state licensed facilities when we think about assisted living and the like, and are working to get that out this week as well. So again, I wanted to mention that because I've really appreciated the attention of the legislature and others just in terms of the concern for really the well-being of our elders in those facilities. And again, it needs to be done in the right way, but it's time that we recognize the impact and are able to respond to the impact of that social isolation on the health and well-being of our elders. So that's been an important part of our work over the last 10 days. You'll also hear more from Deputy Secretary Bruner later today on the PPE side. And I know that came up as well in your conversations this morning. But we expect to receive as an agency the $10 million that we requested through the last round of Spark funding to actually have those dollars in hand midweek this week, and then to be in a position to sign a contract for a vendor that nursing facilities will be able to access. And the federally licensed facilities who are receiving parts of the $38 million that was previously approved that Deputy Secretary DeBoer talked about this morning, they can use those resources or resources provided through other direct funding federally to purchase. The state licensed facilities will get an allocation from us that goes against that $10 million in order to provide them PPE. And I'd be remiss if I didn't give some credit to Kansas Division of Emergency Management. While we were waiting for kind of the whole process to work through with the Spark process to get those resources, KDM did go ahead in the last week or so and send out an additional 21 days of PPE supply to facilities across the state. So that's a bit of a PPE update. This is going to be something where we have to keep close watch. I think facilities, and we are already worried about, what happens after the end of this calendar year. Should we still be in this, since so many resources are tied to spending in the next 3 months, right? Ultimately, I think from my perspective, testing is everything. And with the new mandates on the nursing facilities, the ability of the state positivity rate to begin to go down. Right now we have about 1/3 of our facilities that are required under the new federal mandate that was issued about a month ago. About 1/3 of our facilities are in counties where they would currently have to test twice a week. Significant impact. As you know, the federal government has provided some machines, some supplies, some new, and then when some of those supplies couldn't be refilled, they've now supplied some of the Abbott testing things to some facilities that are in moderate or high risk, kind of the yellow and red counties. I'm probably most concerned about those facilities right now where there's a gap, where they've not received those supplies. So again, we requested about $10 million through the last SPARK process. That was pulled into the larger conversation about testing, and I think we're eager, working with our colleagues across other agencies to sort out those pieces as we move forward. I share concerns about the sustainability. Should this go on for a long time, and should facilities have to test on a very frequent basis in some counties, what those impacts will be. Scott will have more details about some of that within his testimony in terms of resources out to facilities and the like, but I did want to acknowledge, how active and focused we are on that issue, and how we're working as well, across state agencies as we think about a unified testing strategy that includes a focus on the aging population. So again, more details in the document in front of you that gives you more information on the actual supplies that have already been provided to facilities, and that the federal government will be continuing to provide over the next few weeks. I did want to make a couple comments about our own state hospitals. I think we've not talked about them perhaps as much, but 4 state hospitals, KNI, Parsons, Osawatomie, and Larned, as it relates to COVID. Since the beginning of COVID, at our 4 facilities, we've had a total of 88 staff test positive and 27 residents. As we sit here today, all of those residents have recovered, and all but about 13 of the staff have recovered. Most of those resident cases were a couple of clusters at KNI and Parsons that were able to be contained within specific cottages. And those of you who are familiar with those hospitals understand just the physical makeup of those facilities really makes that more feasible than in some institutional settings. And then there's been 1 positive resident test at Osawatomie, no positive residents test to date at Larned State Hospital. I should knock on wood, because that could change today, right? But I'm really proud of the work that the state hospitals have done. And of course, we continue to reinforce the importance of, the protective gear, the masking and the like, because, people are getting tired. We're about 6 months in. I was reading a lot over the course of the last few days just about the 6-month wall that you kind of run into. And so we've continued to reinforce that. I think even when we had a few upticks at KNI or Parsons, much like my colleague Secretary Zamuda would say, oftentimes we could trace some of that back to people getting more lax on following some of those procedures. So again, we've not talked as much about the state hospitals, but I felt like it might be important just to give you an update on what the COVID experience has been there. So in our presentation as a whole today, you'll hear some COVID things, but you'll also hear just our progress on moving forward initiatives. And I'm really proud of the ability of my team to really do some multitasking. Some really important things, were passed and supported through the legislature last year. And so you'll hear updates on those initiatives, how we're implementing those and how we're moving forward. But again, I just wanted to make those opening comments. I'm happy to stand for any questions you have, and I'll be here throughout the presentation as well, if there's any questions at the end.
Any questions for the Secretary? Representative Carpenter.
I'll start, especially Ben Secretary Norman's here. We have continually heard this PPE stuff, and I'm sure if you listen to earlier testimony in this committee about the organizations that represent nursing homes having shortages of PPE, not being able to get it, just all those things. And I think it's very difficult for us as legislators to try to sort through the chaff and figure out, what is the problem and where is it at? Does KDHE have a warehouse full of PPE? I'm just saying, is it availability? What is the problem to get it to the sources? I realize that some people may be getting it, but we heard
constant testimony. I've heard it many, many times about the shortage of PPE. You just said they shipped out 21 days supply. I didn't hear that this morning in any testimony that we received here, and any of you other guys jump in here. But to me, it's just, what is the real story?
You know, and I'll start, and if Secretary Norman has anything to add to that, you know, certainly he may do that as well. I think partly depends on when you're talking about this too. This has been a long process, right? And as all of this started, you know, lots of very, very immediate, just shortages in the supply chain. And frankly, to this day, there are still shortages in the supply chain. You know, and the Kansas Division of Emergency Management, there are times where, you know, they have more or less challenge securing some supplies. You know, 1 month it might be, gosh, we're really struggling with the right grade of gowns. There was a period a few weeks ago where it was really difficult. And again, this isn't just in Kansas. It was really difficult to get gloves. I think also with our nursing facilities, a few other things that I think that they've experienced over this time. There was a period of time, for example, when our federal partners, and I think you probably saw this at one of your last meetings, right? When our federal partners said, we're sending out all these supplies. And then I think you saw in one of your prior meetings, you know, the masks they sent out, those weren't medical grade. They were masks that were probably less useful than the one that I have. So there's been, I think, a lot of fits and starts, and maybe at some points in time, a lot of promises that really couldn't be kept. So how the process initially has functioned within Kansas was that we initially asked our facilities if they were having trouble securing supplies, you know, and a mixed bag for all of them too, in the sense that some of them might be part of a larger organization that happened to have a contract with a supplier that had a better supply chain. But if they had issues with supplies, they talked with their local emergency management providers, and then they made requests up through the Kansas Division of Emergency Management. You know, and that process worked really well so long as supplies were there. And we've begun to move that process a bit now as we at KDADS are stepping up to try to fulfill the mandate put on us through House Bill 2016 to provide that PPE. So we took a couple steps with that. One was requesting funding to provide to our federally licensed facilities, which through the SPARK process authorized the $38 million for our facilities, which is in the process of being sent out. I think, as you heard this morning, about 2/3 of that has been attested to at this point. And then we also requested an additional $10 million. And Deputy Secretary Bruner has been working on a contract with a vendor to allow nursing facilities to order through that vendor and really to attempt to provide a reliable supply chain. In the meantime, nursing facilities, like any other businesses in the state, through a process that KDM has stood up, if they can demonstrate that they have tried to place an order with a vendor, there's a delay in receiving that, they can't receive that, they can provide that documentation, and KDM will send out, they will send out a short-term order until those private contracts can be fulfilled. So we're shifting to that process. We weren't quite ready yet with our contract. So again, KDM stayed in with our facilities to provide that 21 days. So what we would anticipate going forward is nursing facilities could use the contract that we're standing up. If there are issues with that supply chain or other supply chains that they're trying to use, they still have an emergency backup for a short period of time. You know, and from the KDM perspective, you know, certainly, you know, they're continuing to try to manage that larger supply. of PPE across the enterprise. But that, I mean, just maybe gives you a little bit of the history. And again, the supply chain, it's been different at different points in time. There's been points in times where, and when we experienced that as an agency too, right, in trying to fulfill state hospitals, our surveyors who need to be in full PPE going into COVID positive facilities. So again, just a little bit from my perspective.
Thank you for that very much. So a nursing home out there, their supply that they got from a supplier comes in and it's worthless masks or not up to standards or something like that. How long does it take to get it from the Department of Emergency Management then?
That's very quick. I mean, that's very quick. And then there's also, can be like the real emergency, like you've got an outbreak going on, you set up a facility doesn't have something and supplies are there within a matter of hours in that circumstance. But again, at this point, there's not an assumption that our emergency management should continue, should fulfill all needs of these private facilities. I mean, as we're shifting to new dollars from the federal government, new dollars from us, and the contract that we're standing up at KDADS, KDAD really stands there in order to fulfill the emergency needs that might arise.
And do you have some kind of a hotline, so to speak, with the nursing homes? I know, some of this is kind of a surprise to me when we heard this testimony this morning, but you have hotlines for and avenues for them to call in and make their needs known. Is that not true?
So as I think the Executive Board said this morning, we meet weekly with the 3 associations. We meet every Tuesday morning with the 3 associations. We have a complaint hotline at KDADS that's been used for some of that. And then we're also hearing some of that as we are also out at the State Emergency Operations Center in terms of issues or things that might come through local emergency management or the local health department.
Thank you, Madam Chair. Thank you, Ms. Secretary.
Welcome. Representative KanCare.
Thank you, Madam Chair. It just made me think of something else I wanted to ask. A couple of weeks ago, there was a webinar for nursing homes are you familiar with what I'm talking about?
There were some webinars that we participated in with the associations to talk about the new testing guidance.
Okay, that must be. Yeah, somebody was telling me about it. I think it was a facility owner that called me. Do we have access to watch that? Is there a link on your website or anything?
It would be on, we can get that link for you. Commissioner Hunter just told me that it's on the association's website, so we can provide you that link. We'll get it today and make sure the committee has that.
Well, I thought it was really good information. He had information that I didn't have, so I would really appreciate that.
Further questions, committee? Seeing none, thank you very much, Secretary.
Representative Landwehr.
Oh, who do we have?
It's Monica. Sorry, I wasn't fast enough on the mic. Secretary Howard, you may have mentioned this and I missed it. There was someone earlier who spoke about how surveyors are not tested prior to coming in. Could you confirm that or help us understand? And I've also heard from a constituent the same is true of the fire marshal.
I can't speak to the fire marshal, but that is true that we have not tested our surveyors. I mean, we've continued to use the practice that has been the practice all along of screening, temperature checks, those kinds of things, and basing anything on symptoms. That is an ongoing conversation we're having, though, particularly with the new testing requirements. So, no, we have not to date tested our surveyors upon entry. But again, remember as well, the use of protective use of PPE and things like that as they're entering into facilities.
Thank you.
Yeah, I might tag along on that just a little bit, Secretary, because I know that individuals going in and out of hospitals, not only do they have the testing, but they also, they're double checking immunizations, boosters and all that is up and current. So are we looking for that side of it as well on the immunizations and boosters of our inspectors?
I don't know the answer to that question. Let me follow up and get back with the committee.
All right, thank you. Committee, further questions? Dina, thank you, Secretary. Now, who are you
I'm
taking?
going to pass this, I believe, to Deputy Secretary DeBoer to talk about receiverships.
All right.
Thank you.
Welcome back, Janice.
Madam Chair, members of the committee, Janice Board, Deputy Secretary, I will actually be forward along. I've got one slide on page 5. We have continued to make progress on the receiverships. So again, we can't thank you enough for your support during the 2019 legislative session to strengthen our receivership statutory language. We have, I think since we were here last, we sold the facility at our Village Villa. So on August 10th, that facility closed. We had sold a facility on June 1. We have 2 facilities still on the market, and they are Providence here in Topeka, which is an FMH, and we're seeing still for mental health, and we have a facility in Great Bend. There may be a potential buyer for the Great Bend facility. We are hopeful. So at this point in time, I just want to let you know we are continuing to make progress. This is one component of our business that has not stopped during COVID. We are continuing to talk and meet every Monday at noon. That is my report, unless there are any questions.
Any questions? All right, seeing none, thank you. Who's up next?
Good afternoon, everyone. My name is Amy Penrod. I'm the Commissioner for the Aging and Disability Community Services and Programs Commission with KDAS. And my slides start on slide 6, and actually we'll just go straight to slide 7. This is information I typically share with you each meeting about the Home and Community-Based Service waiver enrollment. You will see that for the IDD waiver, we are currently serving 9,128 individuals with a waiting list currently of 4,314. For the physical disability waiver, we are serving 6,140 individuals with a waiting list of 1,609. I will say that with this year in calendar year 2020, for the PD waiver, we have made over 234 offers for services on that waiver. We have had enough movement that we were able to make those 234 offers.
On the IDD, what kind of progress are we making, not only on the waiting list? And then I think the other question we've asked for, and I was thinking someone was supposed to be kind of getting us a number, if we could calculate what we would save in the hospital money, SGF, that we could actually put back in after they received a $22 million cut.
As far as progress on the IDD waiver wait list.
One is on the IDD waiver wait list, and then the other one is, our concern is that we are paying more than the 8.9 SGF that drew us to the $22 million that drew down 11 for the IDD population that got cut under the governor's allotments. That we're spending more in SGF now because we're having expanded hospital days for these individuals.
I can adjust the wait list question right now on the hospital list. That will take a little bit of coordination then with my colleagues at KDHE to talk about that hospital side versus the labor expenditure side and pulling that data together. So on the IDD waiver wait list, we have not had a lot of movement on that list. Of course, individuals that come onto that waiver, it's typically a lifetime waiver, so we don't have as many people coming off and then coming on. However, I would say the individuals that we have had leave the waiver for whatever reason, those spaces are being filled, kind of backfilled pretty quickly by individuals requesting crisis services. We have had this calendar year over about 124 crisis requests, of which 106 were approved so far year to date. So any movement we have had on that waiver has been kind of rapidly filled, backfilled through crisis requests. I understand. Okay, so moving on to slide 8, I wanted to just give you a little bit of an update on where we are at with our home and community-based service waiver renewals and the proposed amendments that we've talked about previously. So currently the physical disability and the frail elderly waivers are with CMS in the waiver approval process. Each are in the final stages of approval, and we really are expecting that thumbs up from CMS here just about any time. I was hoping to have information for you today, but I will keep waiting and hopefully I'll have something good for you this next time to talk to you about. Once those PD and FE waivers are approved, we are shifting our focus. We've kind of already shifted our focus a little bit to what we need to do to address some of the issues that have been brought forward by stakeholders and some of the issues that CMS has asked us to look into in more depth. And a few of these are listed here. These are amendments that we will be pursuing for the home and community-based service waivers. And some of these touch just one home and community-based service waiver, and others will touch multiple waivers. So we are really looking at a fairly large project here of submitting amendments for potentially 5 to 7 waivers all at the same time. So first we will be unbundling assistive services. Currently assistive services is billed as one service, and CMS has asked that we break that into 3 separate services. So durable medical equipment, home modifications, and vehicle modifications. So we will be pursuing that. We are also doing updated waiver performance measures, and this is also something that we have been working on for quite some time, and CMS is expecting that we make these updates. And then we will be revising our waiver language to include provisional plan of care creation processes. Again, this is more of an administrative type of amendment for the waivers. It is basically codifying what we are practicing currently for each of the waivers. And then we will also be lifting the cap on specialized medical care that is currently in the waivers. So rather than having the language be read as a hard cap, it will be a soft cap on specialized medical care for individuals on the IDD waiver and the TA waiver. So if an individual needs those services and those services are on their person-centered service plan, they will be able to get more than the current limit, which is 12 hours currently. And then we are also working both internally and with some of our stakeholders on some plans. These are not going to be immediate waiver amendments, but they will be they are being heavily considered, and plans are being worked on to unbundle our IDD day services and IDD pre-vocational employment services. Currently, pre-voc and day services are kind of together as far as billing and such, and CMS has asked that we separate those. And so we are working on a plan with our stakeholders on how we do that, as well as meet some of our goals with the home and community-based service final settings rule, and working with our stakeholders on what will best serve our participants. And then, of course, as we've talked a lot about during COVID, the use of telehealth and what services under home and community-based services might be beneficial to retain in the telehealth mode or that availability.
Representative Carpenter.
Thank you, Madam Chair. And before you get a little off of the waiver renewals, would that include the SED waiver that you would be reviewing?
We would be, the SED waiver would include, we would be updating the performance measures for that, and we would be revising it to include the provisional plan of care process.
One thing that I was after Adam for a long time, and I've been after Sarah already, it would be presumed eligible in the SED. And what we see is with, for instance, PRTF use 14, 16 years old in a crisis, go to the facility and need services and not qualify. And so they would give them a Medicaid application. You know, how long do you think that will be? I mean, I'm just saying we do that for pregnant women. And I just think that it makes a lot of sense. And it scares me to death that one of these folks that we turned down at that time goes and commits suicide because they're in crisis. They can't access service. They don't have any money. And I know that there's an expense involved with that. But while you're opening up that waiver, can we take a look at that and see, at least knock down some dominoes and see what the obstacles are for that?
Sure, I'd be happy to have that conversation with the folks on the Medicaid team at KDHE, as well as our internal team.
Well, it makes a lot of sense, and therefore it probably doesn't have any place in government, but thank you.
Yeah, aren't we allowed to do presumptive eligibility without adjusting the waiver?
I would have to double check before I say yes or no. I think that there's a good chance that you're correct there, but I would want to double check this one.
Yeah, and as Representative Carpenter, talked about it, there can be an expense to it, so it's something that we rarely do, but we do have other areas correct where we do the presumptive eligibility, but I don't think we have to wait for a waiver.
Okay, moving on to slide 9. This, I wanted to give you a little update on where we're at with our home and community-based settings final rule work. I have updated this slide. I presented some information to you when we were here in June. We have had over 2,800 home and community-based services sites that have submitted self-assessments along with evidence to support the fact that they their ability to meet the final settings rule. Of those 2,800, all but 2, and I know that this number is a little bit different than that. I have 99.4% of assessments have been reviewed as of 9/22. I can tell you that as of 5 minutes ago, I was notified that all but 1 have been reviewed, and those notifications have gone out to those facilities and sites to let them know of their status. And so officially we would kind of move into what we would call the remediation phase, in which we will work with those providers that have those sites and help them work towards compliance with all of those final settings issues. So we are committed to working with our providers to ensure that they can all get to that compliance level. The feds did extend the deadline for compliance. The deadline had been March of 2022. It has been extended to March 2023. And my staff are committed to pressing forward with our work so that we can help our providers and allow the providers a little bit extra time then with that extra year to help them come into compliance with those federal rules. Okay, so slide number 10, I wanted to give you an update on our targeted case management work group. And in June, I talked about, this was an item that we wanted to follow up on. And we had planned on meeting in April, but due to COVID, we had had to suspend our meeting and plan for it another time. I'm happy to report that we were able to accomplish our initial meetings. Those initial meetings were held on September 15th and 16th. We pulled together a very diverse group of targeted case managers and kind of from all different areas of the state. We're talking rural, urban, independent case managers that are associated with the agency, really from every group that we could think of. And in fact, those groups of targeted case managers nominated individuals from within their cohort to participate in the group. And we focused our first 2 meetings on talking about the core values and really the importance of targeted case management, what that service means to people, and what we feel is the most important aspects of that service to carry forward as we look towards the future and we look towards system change. The slide indicates here that additional meetings are being scheduled. We have actually, since we printed, we have sent out save the dates for October 13th and 14th. So we are anticipating 2 more meetings, half day each, on October 13th and 14th. And as I think Janice mentioned earlier, the meeting, I think, meetings so far have been well received. We've had a lot of great participation, and I think it will help bring us all to kind of a common understanding and level set about what we think is really important about these services for the individuals we serve. And future meetings will kind of delve more into the nitty-gritty, more of the technical aspects and how some of that would look in an ideal world going forward.
Amy, if you could, because one of the things that we've learned, depending upon what area of profession, when you use the words targeted case management, is if you could elaborate what that means when we talk about it here.
Targeted case management, it's a very prescriptive set of 4 services that individuals are allowed to receive assistance with. This can be help with an advocacy for their care planning process, really a very familiar individual with our participants, someone that can help coordinate some of their services. And in the past, we have had some issues, or maybe issues isn't the right word, but there's been some conflict, I think, about what types of services targeted case managers are actually providing to our participants and what they're able to bill for and things like that. They are this group of people. They really have a heart for their business and really have a heart for their participants, and a lot of times go way above and beyond what they are able to bill for, which makes it really difficult sometimes to be in that business. So we really kind of want to take a look at the sustainability of targeted case management. It's a very valuable service. I don't think you would find a waiver participant that would say otherwise. And we want to be sure that we can, as we look forward into the future here, we want to make sure that we can save and preserve what is best about the system and make it sustainable.
Any further questions? Yeah, I think Representative Ballard has. And it may not be for you. We were trying to decide who it belonged to, but we figured if we asked it, then someone will know.
I don't know if it's appropriate for you, but this morning I was thinking about a testimony we had in terms of a shortage of nurses, as well as we weren't able to go to $37 an hour, yet they were asking for 47. So we look at that. Do we have
specific group of substitute nurses. That's not really the right word, but just like in our schools, we have substitute teachers for those who cannot be there, that are sick, that needs to be replaced. Now, what about the nurses, LPNs registered, that cannot report to work because they're maybe quarantined or they think they have symptoms? What happens to the patients on the floor? I mean, so I know the nurses work, double shift, sometimes triple shift, but do we have anything that says we can continue to do our job and we have a replacement for those people to be out until they really can come back?
So I think in a situation like that, I would probably need to defer to some of the individuals that either work with the nursing facilities or facilities in general. Most of my providers are providing services in the home. I do think that different provider agencies have different plans. Some of that may entail a backup plan, or it should entail kind of a backup plan for an individual to receive their services if their regular provider that comes to their home is unavailable. I would suspect that different agencies or provider agencies may end up using or utilizing nursing agencies at times when they are unable to provide those needs from within the house.
I was asked a question last week. 2 different people, one on Monday and the other one on Friday. Whenever I get 2 or more questions in the same week, and I haven't seen anything in the paper about it, that means there's a problem someplace. And so I realized I did not know the answer. I would love to have said to them, well, of course they do. They have some means in order to do it. But then the question would have been, do you know that for sure? And I'd have to smile and say, no, I don't. So that's why I'm asking the question. If we don't have it in place, you're thinking that we use an agency or someplace, of which you're going to have to pay higher a rate in order to do that, because that's the only reason why that's their business. So I guess I just need to know, do we have something in place? Because otherwise, we are almost saying, somebody on that shift will say, I may have a symptom, but I'm not going to do anything. I'll just keep my mask on and I'll put my face thing on and continue to work, because they're so desperate for people on this floor. I can't do it to my colleagues. So I guess I would like to know, do we have something in place we can count on, or we're just hoping they don't get sick?
Yeah, if I could please defer that to some of my colleagues that work more with the facilities. They may be able to answer your question. Again, I suspect that you would get a different answer depending on the particular provider, that all providers may have a slightly different kind of a backup plan for filling the needs of their patients and their residents. And I know
so who's gonna step up, or are they gonna leave you up there by yourself?
If it would be okay, they could probably address that when they come up next, if that's okay, unless you'd like to have them talk about it right now.
That's okay, whenever they come up, as long as I get an answer for today, because if not, I will ask the chair if I can ask this question again. Sure.
Well, and you can also ask the question and staff can find out who the right people are and have them respond back to the committee if it's not today. So you're fine, go ahead.
Sure. And then on slide 11, I wanted to talk a little bit about administrative case management. Now, Leslie Anderson earlier today with P4AD talked to you about the AAAs and their work with administrative case management. Administrative case management does provide eligibility and enrollment assistance to individuals on the brain injury, physical disability, frail elderly, and the PACE program. You can see, and Leslie provided some numbers as well, and you can see that there has been a significant uptick in the number of individuals that have been served by this program. I think we are finding anecdotally, and we will be tracking some data to watch this, but we are finding that a lot more of our applications and things that are coming into our team for approval are complete, which is one of the goals of administrative case management. So far, so good with that program. It's been very successful, and I think we have a lot of good comments on it. And then bringing up PACE, I think my last couple of slides here. I've provided you PACE enrollment numbers for the month of, as of September 22nd. You can see we have a total of 689 individuals enrolled in these over the 3 program providers. And then the following slide indicates which counties are served by each of the 3 providers. And then finally, this was addressed in the Medicaid director's testimony earlier about Appendix A for the home and community-based service waivers. One of the ways that we have been able to respond to COVID has been to request waivers from CMS for certain flexibilities within our waiver program. I have listed several of those here. We have allowed additional flexibility for services to be provided in homes or temporary settings when perhaps they normally would have been provided in an alternate setting, a provider setting. We have permitted payment to family caregivers to provide personal care services in the event that a worker is unavailable or in the event that a family would like to limit the number of individuals coming into their home and limit the exposure. They are allowed to provide those personal care services to their family member. We have increased availability and eligibility for home delivered meals. We have allowed some provisional employment pending background checks to allow for individuals to begin work very quickly without delay so that folks are not without their services. And this particularly comes in handy when one normal or regular worker is ill and you need to bring someone else in quickly, or a family member wants to step in and offer the services. And then we have also talked about the retainer payments. That is a Appendix K flexibility, which Deputy Secretary Thor covered earlier. And then finally, we have submitted draft Appendix A flexibilities for one would be to be able to offer home and community-based services to children while they are receiving remote education. We have not yet finalized that flexibility with CMS yet. CMS is working on guidance that they are expected to submit out to all the states. And so we have made our request and noted the reasons why we feel like this is necessary. And we are awaiting a final kind of response from them that's more general to all the states before we proceed any further with that.
Any questions? Seeing none, Amy, you're off the hook. Now I believe that we have Andrew Brown. Our next victim is. Welcome to the meeting, Andrew.
So my name is Andy Brown. I'm the Commissioner of Behavioral Health Services. I'm going to try to do a real quick overview of this. So my first slide talks about just some kind of overview of our behavioral health response to COVID-19 and how we established some health policies. We expanded those services so that we provide those services around the state. My next slide on 19 is just a quick update on the Children's Psychiatric Hospital in Western Kansas. As you know, there was legislation that was passed in the past session that requires a Children's Psychiatric Hospital to be opened in Kansas. So we currently have staff that are working on the RFP process for that. We've met with a couple of vendors that are potential vendors, and we've toured a couple of physical sites in Hayes to kind of get an idea of what sort of real estate's out there. And then on my next slide, there's an update on the plan to lift the
WASH moratorium. This talks about our regional psychiatric hospital beds and our state institute alternative policies. We got those policies passed over the summer, and so those are now published, and we're now taking applications from hospitals to become state institute alternatives. So when we open the hospital in Hayes, it'll be a state institute alternative hospital, and allow for hospitals, other hospitals around the state to open psychiatric beds and receive both voluntary and involuntary patients. And then on the next slide, number 20, our psychiatric residential treatment facilities update. This is standard language for you, but I did want to point out that our current NCO wait list is down to 90, which is about 22 lower than we were in June. And out of those are for our foster care children. We're down to 19 from 24 in June. So that's, I think, pretty remarkable progress for us over the last 3 months. And we're currently working to try and establish some specialty PRTF licenses in the Kansas City area for children that are difficult to place in a regular PRTF. Stanford.
Any questions? I think you explained it well.
And I can take a second to try to answer Representative Carter's question. Yes.
It'll be fine.
Okay, so when it comes to PRTFs, PRTFs are not emergent care. So the level of treatment that we're looking for somebody that's in that acute psychiatric need as a kid is in hospitals. So there's enough planned admission time and wait time on the NCO PRTF admissions, but there's plenty of time for us to get an SCD waiver in place using the normal process for PRTFs. For acute care, we have the HAFI program, which is our hospital alternatives for psychiatric hospitalization of youth, where we contract with KBC hospitals. And those hospital beds in that program are accessible for children that may not have Medicaid coverage or other types of coverage, but have that acute psychiatric need. So those two hospitals are able to take those patients based on a screen that happens at the CBC. And then the state pays for that out of the state funds. Right now there's, I think, close to 18 open beds that are not currently open and can take patients. And in general, I think we've got something like about 60 beds between the two facilities in Wichita and Kansas City. And hopefully we'll be adding some in Hayes.
And I think you've been working on that for a while, so I mean, hopefully you're getting real close.
Yeah, I think we're making good progress on it. I'm afraid we're going to enter that point soon where there's an RFP out, and I won't be able to talk about it much, but I think we are making good progress.
Before you get up, and I don't know if it's you or if it's the secretary, but I had a question earlier on the appendix K3 on the, or no, 4 on the IEP, and it was said that KDADS would explain. Who is that? Okay. And if you explained it and I missed it, I apologize.
That is the item where we had requested we have submitted a draft appendix K flexibility to CMS regarding the need for medically necessary support and personal care services for students during remote learning. So many of the schools are, if they're not in full-time, a lot of them are in 100% remote or even some hybrid version. And quite frankly, all the services that the school districts are accustomed to providing within their school building, they are not able to provide in each individual student's home. This leading up to the school year commencing, we received a lot of feedback and concern from parents and providers, folks wondering how they would possibly make the transition from summer plans of care to school plans of care when this school year looks nothing like any other school year has looked, and really pleading for some flexibility there. This is an instance where, again, like I said, we're waiting on CMS to provide some guidance to the states. We are not the only state faced with this kind of predicament. And we have expressed our concern to them and asked for some flexibility. And we are awaiting their response before proceeding further. In the meantime, we have allowed for, in these circumstances, in certain circumstances where an individual student has an IEP and has medically necessary services or personal care service needs on days or hours that they are in remote learning, that they can continue to receive that support if it is a waiver service via the waiver. And we want to be sure that our participants are not kind of in this crossfire of and falling through the cracks, essentially.
Okay, so who currently pays for these services in normal school? And then who will be paying for them under this amendment?
In a normal school year, it is my understanding that these services would be the responsibility of the school district.
So with this amendment, it becomes the responsibility of.
If they are providing home and community-based services, that those expenses would be part of the home and community-based service budget or the Medicaid budget.
Wow. This is a big deal. And I think we need to understand a little more detail of this big deal, especially when we're sitting with a waiting list on the IPD population.
Representative Landwehr?
Representative Mernan?
Yes, I think my understanding is targeted case management, or what we would call in schools attendant care for, personal care services and such. Those used to be, school districts could bill those to Kansas Medicaid and seek reimbursement. They are no longer allowed to do that. And so, it's not a real simple deal here, but it is a real thing in that it's going to take probably 2 state agencies to work together to try to pull off these adaptations for virtual school for these really high needs kids. We're talking about super high needs kids. And in order for them to get their education, it probably is going to take both agencies doing it. And my understanding is in the past, schools could get paid for that, but they can't now. So that's probably more complicated than any of us can wrap our hands around. But the bottom line is there are kids who are receiving virtual education, but they can't truly access it because some of the most basic things aren't in play. Is that, Amy, am I explaining that correctly?
Yes, you are correct. It is very complex, and I cannot stand here and say that I have all the answers. We have been looking and watching, trying to figure out how are other states handling this? What are the options? CMS is well aware that we're struggling here. The participants in our programs need just these very basic services, and in a lot of cases, we were being brought a lot of stories and things from parents that are saying this is going to make you have to choose between having a roof over my head and food on the table, because I will or I may not be able to go to a job if I have to provide these services myself, or have a little bit of help here and allow my child to get their education in this manner. So I agree, this is a multi-agency issue. This is one method that we felt like was worth pursuing, and I would say it's by far not a done deal and not a set issue, because CMS could very well come and tell us that we need to do something a little bit different or have a different solution for us. I think we've had a lot of conversation with our colleagues at KDHE, and we are very much open to solutioning this in the best way possible. I think our primary concern, though, at the moment was making sure that kids could access their education and be provided that and not fall through the cracks and not have families in that very difficult position trying to make those decisions.
Well, and I understand that. That's why I said it's a big deal, because it is a complicated deal. It also gets even more complicated when you start dealing with Medicaid, and then you also deal with the school finance formula that's very complicated. So I guess the question comes then, why is Medicaid not paying for this? Is it because it's not in the school building? So that would be a question. Then what are these parents doing today for these children? Are they not getting the services that they are due under their IEPs at home?
As we started school, and I keep looking back to me, feel free to correct me if you feel I'm going astray, but as school was approaching, and some schools were starting earlier than others, and we started to hear this fervor, because usually when you transition from summer schedules to a school schedule, those services that are needed by a student provided during, say, the hours of 8 to 3 or whenever they are in the school building, all of that responsibility is typically on the school and not school district. Well, kids aren't going to the buildings from 8 to 3 every single day. Some are not going into the school at all. Some are 3 days, some are 2, some are, a limited number of hours. So there are several factors, one of which is kind of network and the ability to provide services in the home. I would say that it'd be very difficult for the school district at this particular moment in time to have a network capable of providing those services. That said, our home and community-based service network is already strained as far as workforce and things of that nature. So it's not a panacea, it's not a perfect solution by any stretch. However, we felt like it would buy us a little bit of time to come up with something that's a little bit more, I want to say permanent, because I certainly hope this isn't all permanent, but a little bit more sustainable. So in the short term, we are, if a student is not in the school building and they have needs for these services, we are allowing those to be provided via HCS, if that's the appropriate venue.
So we are currently providing HCBS services for these kids today.
Some, yes.
For some. Why not all?
If they need it and they're unable to get it from the school district, then we are allowing that to be provided via our providers, our Medicaid providers.
So then is the school district reimbursing for these students that they are required to provide this service to?
We have not gotten that far.
This is where it all starts getting really complicated, and the issues, we're sitting here with the Supreme Court over there holding on to a case. And some of the IEP stuff falls right into all of this. So I think that we probably need to be provided, we need more information on this. And I think that the fact that we're sitting, you know, with IDD sitting with this huge waiting list out there, now we're stressing the system out more because we're trying to meet some obligations that some school districts are supposed to be meeting. Then the school districts need to be paying for this, not for the state. Because if you guys have got extra dollars in your budgets, then I want to see that IDD with waiting list gone. I'm sorry. I don't know where Representative Carpenter is with this right now, but I am just very, very disturbed to learn this today. So I want detailed information, who, what, when, where, and how, what the numbers are, who's paying for this, because it's not as if because we have school districts sitting out there with some really damn nice reserves.
Representative Landwehr?
Representative Renan, and I don't want to get into a battle here with you, so go ahead.
I have no need to battle. I'm just going to point out that I think that it is a strange situation in that federal law meets federal law. And I think that's what Amy is saying, is that, you know, when you get IDEA and up against some of the CMS regulations, it gets super complicated. But Amy, what I'd like to know is, have you heard this coming from settings where kids are being served in alternative school settings, such as a behavioral health focused school, and the difficulty in the mental health provider being able to build targeted case management during that time because it's technically school time, but it's all hands on deck in schools like that? Is that where you're hearing it from? You mentioned some of the stories.
No, what I'm hearing more from is the folks, the parents that are, you know, in home and have their students in home and are needing to provide, needing support to be provided during those remote education hours when possibly the parent would be working or out of the home, you know. I think in normal years, parents have an expectation, especially when their kids reach the age of kindergarten or first grade, that, you know, their child will be at school for a certain number of hours a day and plan around that. And of course, COVID has completely upended and changed just about every facet of our lives and our kids' lives. And so this is really, it's really putting a strain on not only our waiver participants, their families, our providers, all of our systems.
Thanks, Amy. I had heard it from a collaborative behavioral health school district relationship. And so I'm interested in, you know, just where the pressure is being felt. And like you said, multiple strategies to try to address it. Thanks.
Well, and I want to make it clear is I'm not saying that we do not use kids these services, because I've said this for the last several months, that IEP law doesn't stop just because we're in a pandemic. It continues, period. Those are mandated services. I do, you know, and this is why, you know, and agencies wonder why some of us legislators get frustrated with all you guys is all of a sudden a bomb is dropped on us like, oh, this is just no big deal. We'll just kind of put it in here. And maybe somebody won't pay attention to it. And I'm not saying that was an intentional deal, but this is huge and this should have been brought to our attention. And what's the cost of this is currently, because it sounds like we already have a cost affiliated with it. We just don't know if we're going to get reimbursed from the feds. Is that correct?
At this point, it would be, from what I am understanding, we're waiting for CMS to give us the guidance, and at which point we will make whatever adjustments we need to in our path. I think that given the complexities, I feel like, and this is just my personal opinion, when working with CMS, they have been as flexible as they can with us, knowing that there are a lot of things that are unforeseen and that we couldn't have predicted. And I know, you know, as a parent myself, I was really kind of crossing those fingers on both hands, hoping that the school year would start up like normal. And you edge closer and closer and closer to that magic date, and it just didn't, we're not normal yet. We're not at normal yet. So we do have a long way to go. I will commit to working with my colleagues at KBHE as well as the Department of Education, and we will work with CMS to come up with our path forward and get you some additional information about how this might work.
It goes back to we should, as legislators, especially whether it was this committee, whether it was the emergency committee, whether it was the budget committee, should have been made aware of this huge change. And nowhere in the documentation that we've received today, and I don't think it was on brought up in the budget committee, was it, Representative Carpenter? What dollar are we dealing with so far, and what dollar are we projecting that we're going to look at? And if I understood correctly, there's no guarantee at this point that the feds will reimburse for these HCBS services. Is that correct?
That would be correct.
Okay. Because a child qualifying for the reimbursement under Medicaid is different within an IEP than it is qualifying for Medicaid services somewhere else, to a certain degree.
That I'm not certain of, but I know that in order to have home and community-based services provided, there are certain parameters that have to be met. So,
well, and I think and I know on the mental health side of things, just because that's one I'm a little bit more familiar with, the reimbursement rate for Medicaid under schools is a whole lot different than when you step outside of that school arena with the way they're able to bill. So what are the difference in the Medicaid reimbursement rates under the school when they provide these services versus what we're going to do underneath the HCBS? I don't want these kids to be denied their services. So, anybody wants to jump on that one there, I will come back at them very hard, because I think most people know, even though, people want to talk about me being a little rough on the edges when it comes to kids, I am all in, and Representative Ballard will back that one up, because we battled that together as a team. And we will continue doing it. But we need to be kept in the loop. We ultimately make some of the final decisions. And when we're kept out of the loop on something this big, it's pretty upsetting to us. This is that communication thing, why it is that everyone wants to ignore the legislature just because we're out. And then people wonder why it is that we're going around and wondering, well, what else are we not learning about? What else have we not heard about? What else are we not being told about? What else is coming to us in Akron? So I'm not attacking you, you're the messenger. There's a lot of people sitting behind you. There's a lot of people listening, so they'll understand where it's coming from. Representative Ballard, I believe you had a comment or a question?
Just a question. Is this not a COVID expense?
Nobody knows.
I mean, it's like, it only occurred because of the pandemic. So in listening to you, to me, it's a COVID expense. And we talked this morning about the $34 million and who was going to claim it and who was not, because they didn't want to be audited with an expense that's not there. It seems to me that this is definitely a COVID expense. Otherwise, you wouldn't have made that adjustment. The adjustment was made because of that particular pandemic and how you have to deal with it. So when you said whether they're going to reimburse it or not, I don't think Kansas would be the only state that would have that particular thing. So when we talk about who's going to pay for it, I'm just asking, is it not a COVID expense, or have they simply said you can't do this, which is the first time we've heard?
They haven't said anything yet, so there's not a response. And so they're providing the services, they're paying for the services, but we don't have an answer on who's going to pay for that, whether we can use COVID money, whether feds are going to come in and pay our HCBS rate, whether schools should be, I mean, it's a huge question mark right now, but it's a major
But I'm just kind of my own justification in my mind.
Nobody knows.
They don't mean anything, right? Because CMS, but I just wondered.
But the kids are being taken care of, so that's the point. and fine, but now we need to know where we're headed.
And I know you're a little rough on the edges, but when it comes to kids, I have to say, she'll be in the corner.
I will fight for the kids because they don't get to vote, so I'm comfortable. Okay, committee, now that I've gone off the rails on this, are there further questions on anything?
No, ma'am, I just want to come.
All right. I'm not even gonna go there. Amy, thank you very much. We appreciate it. So any information of what's been done, what's going on, what the discussions are, definitely looking at what the Medicaid reimbursement rate differences are between HCBS and what school. There's a whole lot, kind of involved in all of that. We would definitely want to kind of get the ins and outs on that so you can be a part of the solution at some point. Thank you. Now, Scott, do you feel better? Anyway.
I'm not sure about it, Jay.
I don't know. Do I have any faults in my judgment?
I'll withhold judgment if that's okay.
Thank you very much for being here.
Glad to do it. Before I jump into my part of the presentation, maybe we come back to Representative Ballard's question and try to answer from 30 minutes ago or whenever you asked your question of Amy about staffing plans when they don't work the way they're supposed to. On the nursing facility side, where my responsibilities are, when we do a survey of a nursing facility, we do look at their emergency response plan or their disaster recovery plan. And part of that is how the facility will meet the needs of the care needs of residents when things don't work the way they're supposed to work in the case of a natural disaster or in this case, it's because of COVID-19 and potentially staff getting sick or residents being sick and not being able to work. So we do look at those type of plans there. In all honesty, we've gone in and looked at some are better than others and have a deeper bench, if you will, or a deeper plan. I think probably facilities would say that those plans are designed for a natural disaster or something short term, not something that lasts 200 days or 6 months. So those plans are getting stretched, and we're hearing that from facilities as well about not having enough staff, not having the right mix of staff. One of the things CMS has done is allow facilities to use staffing differently, so they can bring in licensed staff from other states or states that have other states using people can operate on the edges of their license and some other flexibilities like that. But that is an issue, and it's a very good one to point out. Heard some of those concerns earlier in the pandemic, and some of the that you've already been made aware of. So my part of the presentation starts on slide 20, and it's labeled long-term care. I didn't say my name. My name's Scott Ritter. I'm the Deputy Secretary for Hospitals and Facilities. On slide 21, one of the topics that we give you a regular update on is the use of antipsychotics in nursing facilities. And the slide that you'll see on page 21 is the same slide you saw in June. The data set for this measure is nationally collected, and it doesn't get updated very frequently, so that's the same. But I did want to give you some new information, particularly since it's been a couple of months and I wasn't happy with the answer that I gave you the last time. So I asked our MCO partners, because one of the behavior performance measures in their contract is reporting on antipsychotic use and the appropriate use of antipsychotics in nursing facilities. So we have some data from for that measure, and I asked the MCOs to, if it was okay if I shared that, and then have them provide some examples of what they're doing to try to address antipsychotic use. So on slide 22, you'll see the results from the first and second quarter of the data that we report back to the MCOs. We collect it, and then we report it back to the MCOs on that performance measure, and you can see that for all 3 MCOs again for 2020. And then if you turn the page on to 23, there's a column for each MCO that they gave me a few bullet points about what they're doing within their health plans to address antipsychotic use in nursing facilities. I didn't edit them very much. I tried to get them to fit on the slide, so it's pretty much their words, but that's there for your information, and we can talk more about it and provide more of that information going forward as well. And I want to express my thanks to the MCOs for providing that information. Slide 24,
We wanted to give you a few updates about kind of our what we've been doing with COVID-19 around adult care homes. One of the things that House Bill 2016 required us to do was to enter and conduct infection control surveys in every facility that we license. And we did accomplish that. So on slide 24 is the results from the state licensing facilities, so assisted living and Home Plus adult daycare facilities. For the Home Plus category, we conducted 179 infection control surveys. We've completed 4 immediate jeopardy investigations. So that's an investigation where there was some concern inside the facility that rose to the level of an immediate jeopardy of safety or health. We cited 1 of those in the Home Plus category, and then there were 2 infection control citations while we did the 179 inspections. For the assisted livings, we did 293 infection control surveys with 14 IJ complaint investigations and 3 citations from that, and just a few more infection control citations that came out of those surveys. On the next page, so that's the state license side of our role. On page 25 are the nursing facilities, the skilled side. We conducted infection control surveys in all 329 facilities. We completed 513. We did have to repeat some, given what the CMS guidelines were, but we did all 329 completely, and then did a couple of extra times, at least 1 extra time, with 215 IJ complaint investigations and 25 citations. So it was a lot of work from the survey team. Commissioner Lacey Hunter is here with us today, and it's her team that went out and did that work in the course of about 6 weeks to visit all those facilities and get those infection control surveys done. That was a template that CMS provided, but it did require, in most cases, some on-site time in addition to reviewing documents that we could do before and after. A lot of effort to get that kind of baseline level of where facilities are. The guidance has changed from CMS now. We're back kind of into our routine survey schedule. We are able to do some of those. We also have to do some repeat visits when there's been an outbreak. So we get a list from CMS every week of facilities we need to go back and revisit. We're keeping up with those as well. But just a remarkable amount of effort and work to get that baseline completed by the end of July. On slide 26, I want to start talking about testing. We already talked a lot about testing in nursing facilities today, so I don't want to repeat too much, but on slide 26, I wanted to set a little bit of context for kind of where we were with testing before the CMS mandate came down. Feels like a couple of weeks ago, but honestly, my time scale is a little off. So, but anyway, so what happened before the CMS mandate? So there was a testing strategy. KDHE released their statewide testing strategy in June. And we tried to follow that as close as we could because that pointed in the direction of not doing mass testing or surveillance testing in facilities. You look for people that had symptoms or that would be under investigation. And you do broader testing when there was an outbreak or in a congregate facility. So we followed that guidance. That's what we used when CMS released their documents, giving states some idea of how to start reopening nursing facilities to visitors and outside services. So we use that testing guidance that KDHE has laid out as sort of the framework for that as case rates in counties were slowing down, as the testing was done. If there was an outbreak or a suspected outbreak, then health departments could work with facilities to come up with plans to reopen. That world changed on August the 26th, or around there when CMS issued their final rule that mandated more broad-based surveillance testing in skilled nursing facilities, as you've already heard about. So on slide 27, I tried to lay out some of the key points of that. Again, this is stuff you've already heard. I don't want to repeat too much, but the key point to emphasize is that for nursing facilities, they're required to test all of their staff that work in the building, in their buildings, and it's regardless of their job title, whether they're a contractor, consultant, or volunteer. So pretty much anybody who's on the payroll or not on the payroll but providing care inside their building. Facilities can meet that testing requirement using a rapid point of care test that uses an antigen or tries to detect the antigen of the coronavirus. They can do that in-house. They can do it with an outside lab, but CMS asks, they require that you document that the test was done. The frequency of how of that routine testing depends on the prevalence of COVID in the county, measured by the rate of positivity of testing. And I put the 3 categories there. So once a month, if it's below 5, if the testing positivity rate in the county is below 5%, you have to test everybody in the building, all the staff in the building once a month. Medium, it's once a week. I apologize, that's wrong on the slide. And then if it's high, at 10% or higher, it's twice a week. CMS did say you can choose to use either the rate that they provide, that CMS provides using the national data that's collected, or you can use a state measure. We've adopted as the state policy that you to for facilities use the KDHE reported testing positivity rate for a couple of reasons. One is that we think that the data is updated more frequently. It uses more of the information that we have, so it matches up test results and tries to find so the same person, if they were tested twice, they don't get counted twice in the measuring. And it's measuring the same thing. So we think that's a better result, easier for facilities to use. On the next slide, 20, so that's the testing requirement. So, and again, you've heard about this today. So facilities have to meet this requirement. It requires, in some cases, a lot of testing to happen in buildings, and then with a lot of frequency. And so partially to meet that requirement, CMS and Health and Human Services sent testing machines to skilled nursing facilities around the state, all over the country, but we got many of them in Kansas as well. There were 281 facilities that got those testing machines. I'm on slide 28, sorry. They were provided for free. The first round of testing, or enough kits to do one round of testing, were provided for free. And then facilities were directed, as they needed more supplies, to order them from the machine manufacturer. So whether they got the BD machine or a Corel machine, they could contact those manufacturers. And when they did that, I haven't heard any case where they were able to get more supplies. So I think in most cases, facilities were told they're back ordered, we'll send you more testing kits, or the materials you need to actually run the test. So that's what we mean by a kit, when they're available 30 days, 60 days down the road. So facilities were able to use those machines for maybe their first round of testing, maybe a little bit further than that, but then they haven't been able to use them for those additional rounds that have still been required in buildings that was necessary. If you get a positive result on that rapid point of care test that looks for the antigen, CMS says that you need to verify that with the more definitive test that looks for the genetic material of the virus, the PCR test. So that means you have to do a second step. That it is a second step. It does prevent from facilities relying on that first positive test from their testing machine or antigen machine that could be a false positive. So then rather than triggering all the steps that come after you identify a positive case, which could involve bringing in the Department of Health and Environment to investigate an outbreak and do a much more testing of more than just the staff, residents in the facility and others, they want that confirmational test completed to make that happen. On slide 29, the Secretary mentioned this as well. So as HHS, they realized, but as HHS reported that there was problems getting supplies for the machines that were sent out, and they didn't go to all facilities, not all nursing facilities, and very few, if any, of the state licensed facilities got those machines. HHS announced that they had secured a supply of tests from Abbott called the Binax Now test. There's a little picture of it on slide 29, or at least part of it. And they began shipping those out to facilities, nursing facilities, but also assisted living facilities to help kind of fill the gap of the need for antigen-based, that preliminary test. From what we were told by HHS, those are going to be supplied for the next several months until the supply chain for other kinds of testing and even the testing kits that facilities need for their machines opens up a little bit more. The list that we received, I think this was maybe September 8th, I think was what the day of the list that we saw. 106 assisted living facilities in Kansas and 264 nursing facilities were in that initial distribution round of these added cards. And they were sent primarily to counties that were either red or yellow, higher positivity rate. counties could, because they were testing more, so they had more demand. On slide 30, some considerations as we, again, things you've already talked about some today. What about the role of KDHE? So when there's a positive test, or you get a positive result from that antigen test in the machine that the facility has, or some other way they have to get an antigen test, facilities need to call KDHE, report through the epidemiology hotline that they've got a positive case, and then KDHE works with the local health department or on their own through the epidemiology team to talk about how to get that confirmational PCR test that facilities need. So there's a great connection there, and it reinforces a lot of the guidance that we've been giving facilities all along, that as you identify potentially positive people that work in your building or live in your building, or you get this positive result from your antigen test, you need to communicate those results to health and environment so they can track it within their epidemiology tracking system. That links to other resources, links to, because KDHE will also step in and do the mass testing within a building if there's an actual outbreak, where there's more than 3 confirmed tests in the facility. So that's been an important connection that we emphasize, KDHE emphasizes to facilities, that they need to be reporting those results as they get them. And then on testing frequency, I put a couple of comments in here about the difference in results. Since I wrote this, we did issue guidance that said we prefer and we direct facilities to use the KDHE results for testing positivity rates for some of the reasons we talked about before. So that's kind of ongoing as we, and you may have some more questions about that as we move forward. But on slide 31, I want to talk about the visitation guidance, because this is important, and the Secretary mentioned it in her initial comments. So CMS closed the doors at nursing facilities to visitors, which was important for safety and health and protection, and it had not great impacts on people who live in facilities and their loved ones. So CMS, just when you say reverse, but it probably replaced that guidance on September 17th, acknowledged a lot of the concerns that folks have expressed about the harm that lack of visitation has had in nursing facilities, and really said that facilities should allow visitors as long as community spread is low and there are infection control practices in place that will keep people safe, and you can enforce social distancing, and you're conducting testing as required by CMS. So all these rules eventually all fit together. That's a very high bar for a facility to meet, to go from being closed to all visitors to then being open to anybody who wants to walk in the door when they want to visit their loved one. So there's still some work to do to get from point A to point B. CMS does, in that guidance document, strongly encourage outside visitation. We're directed to provide $3,000 grants from the civil monetary penalty funds to facilities to buy tents and plexiglass dividers, things like that. We're pretty close to having the application ready to stand up for that process. It's very similar to the program I think we talked about the last time that you all met, to share or to provide funding for tablets or iPads in facilities to allow for electronic visitation options. That was a little bit easier because the kinds of things that facilities could buy was pretty limited to tablets or iPads or things that promote visitation electronically. This could be then, I don't know how many different kind of tents there are, but for $3,000 is probably a lot. And the plexiglass dividers need to be customized for facilities. So there may be more options that facilities will need to exercise to make that work. But it is an option, and it is something to help promote visitation. On slide 32, the guidance does talk about indoor visitation if there's been no new onset COVID cases in the past 14 days, and the facility is not currently conducting outbreak testing, which includes the initial outbreak, testing for the initial outbreak, and then any follow-up testing. And so some facilities, if they've been clear of COVID for 14 days, could open and do that visitation inside. Again, the preference would be, or the express preference in the document is in a larger room, not individual patient rooms, in some way that's monitored and still with social distancing, things like that. So trying to be clear that it's not, and especially as you talk to family members who call, it's not going back to the way things were. It'll still be different, but it's certainly a step in the right direction from being closed entirely to visitors. Some expansion of the definition of compassionate care visits, which are allowed, and a lot of emphasis on if a resident in the nursing facility is really declining in health, not just near the end or in hospice, but they're not eating, they're not as social as they were. All of those kind of reasons of compassionate care visits, and the facility needs to work with the family to figure out how to get somebody in there to visit. So that's an important part. Again, a pretty fine line to walk between all of the other things that I've already talked about, the limitations on visitation, but then making this happen. That's going to be a struggle. There are some things that we're working on clarifying in terms of just the operational elements and how you do this. A lot of them I've already raised, but you require visitors to be tested before they come into a building. That's not 100% clear. When can a visit happen in the residence room? There's some language in the guidance document that talks about conditions and if the resident's not able to leave the building, leave their room. But there's some operational questions there that we need to figure out. And then is what the reasonable limits. So now we're talking about not unlimited, but fewer limits or fewer restrictions, but probably still some. So what's reasonable? Once a week visit, 2 family members, and there probably will be some difference in facility. But overall, it's a step in the right direction. It's certainly a helpful progression in where we are. Again, doesn't get us back to how things were before 200 days ago, but it does move things along. On slide 33, I made the last comment I think about adult care homes and visitation is just on that slide. Tried to list out all the resources that have been flowing to adult care homes. Again, many of these things you've already heard about. The $38.4 million that nursing facilities are in the process of receiving. My numbers are a little dated compared to what Janice talked about, but from that money from Spark, the $10 million for state licensed facilities for PPE that you've already heard some about. Happy to talk more about it. There is $102.4 million that the federal government released directly to nursing facilities over in 2 batches. That was tied to testing to some degree, but other additional operating costs. And then we put the $10 million on there that we asked for from the Spark Committee and Office of Recovery for testing that's now been bundled in with some other testing resources that we'll need to think about. Trying to put all that onto one slide so you can have it in kind of an easy way, again, just for nursing facilities and long-term care settings.
Any questions?
Just one quick one. Scott, didn't you tell us last week that if a nursing home could not access testing material and could not test it, there was an affidavit or something that they could fill out?
Thank you. I should put that on the slide after we had that conversation about the committee. That yes, the CMS guidance does say, and they've been clear with us as the regulator, that a facility that can't meet the testing requirements, if they document their best effort, which means that they ran out of their test kits. They can't buy any more. They've exhausted all their available resources to buy testing. They can't find a private lab that would do the testing and get the results back in 48 hours. Any of those conditions that CMS laid out in the testing guidance, if facility can document that they can't meet it, then they're not going to be held. They will be penalized for not meeting the testing frequency. Thank you for putting that out.
Madam Chair, this is Senator Petty. I have a question.
Senator Petty, go ahead.
It's come up several times about earlier about how much money, is available or going towards, and it seems like a lot of money. I was just, maybe I've missed it in the presentations today, but do you have kind of like a high to low average of what it is costing per week for testing within the facilities across the state?
Not per week, Senator. I would say we've heard a range of what it costs if you from using the testing machine that CMS provided and resupplied to in a private lab. I think the range, I don't know if it's in these slides, but somewhere between $50 and $120 per test. I think Rachel Munger, when I looked at her testimony this morning, she had a slightly wider range. So you can think about what the reasonable number is to pick in there, but $100 a test. Then the difficulty of figuring out the week would be how many staff there are and how frequently you have to test them, and that could vary county by county. It's a significant amount of money, but probably the best, and some of the, like the Abbott card, I think is $5 a card, an individual test, and that would be on the very low end. But so it's a pretty wide range, and then the multiplication would be how many staff there are in counties times how many times a week you have to test them. And the secretary mentioned about a third of the facilities are testing at least every week or twice a week. So but that's at least the elements that you need to calculate it. Well, we do get that question quite a bit.
Yeah, this is just as a follow-up. I know it would not be an easy figure, but that seems to come up often. So if there would be some way of, you know, a low of, a high to, of what it could be per week, it just really gives more reality to how this is really in some ways not a lot of money, although it sounds like a lot of money when it comes to all of the testing that is required. And then my follow-up question was, if on the rapid tests, if an employee or of a facility tests positive, does the facility itself give the other test, or do they have to go to the health department or some other facility within that community?
So if there's an outbreak in a facility, so there's multiple positive confirmed results, then KDHE does step in and do the outbreak testing that's required. That may be everybody in the facility. They do contact tracing to see if there's anybody who could be excluded from that. But KDHE does provide that first round of testing and one additional round of follow-up testing, usually within 14 days of after that initial testing round is done. So it wouldn't be everybody in the facility necessarily, although it may be depending on who the person was that tested positive, what they were doing, where they were working, if they were wearing a mask or not, things like that.
Thank you.
Further questions representing KanCare? Oh, you thought I forgot you, didn't you?
Nope. Thought I was gonna have to throw a fit.
Let's go.
You know, I was gonna ask a lot of questions, but it's 5 o'clock somewhere. And
so it's okay.
I have places to be. But I did promise, I get a lot of phone calls from facilities, and I've been yelled at and cussed at, but by, not by the facilities, but family members that can't go see. I mean, it's been so emotional, and I know that you know what I'm talking about. And so I'm not going to ask these specifically, but I've written down some of the concerns that have been thrown at me, and I know that they've been thrown at you too, but I just want to bring them up. Of course, we talked about the cost of testing, and the fact that they're paying for one round of it is somewhat helpful, but and we've got money that we're putting towards it, but we have small nursing homes out in rural Kansas that just aren't even going to make it. They're not going to survive this. They don't have access to the PPE. They haven't had the you know, we're out there rural. We don't have access to the testing if they haven't gotten a machine yet. And another part of this is that they have to hire somebody just to do all this testing and the paperwork. We have workforce problems that we can't get anybody hired. Not only can we not get anybody hired, but people are quitting because they don't want to do the testing. And then the ultimate insult is when a surveyor walks in and doesn't have to be tested. I understand that they wear protective, all the protection. My husband does it every day, and I get that. But I think it's a bad message that we're sending. And and then my last point is the countywide designations on the level. You know, I don't know whether it's the same way in the urban area, but for us, some of where the outbreak is might be an hour and a half from where this nursing home is with 14 residents, and they still have to test everybody twice a week. It's just all very frustrating, and I know it's a transition, and it's something that we all have to work with, but if you want to visit with me sometime away from here, I'm just really frustrated. Thank you, Madam Chair.
Appreciate that. Those comments.
Further questions? All right, seeing none.
So talk a little bit about state hospitals if you still want me to proceed through that. Just a couple of issues with state hospitals that you asked us to update on. So recruiting and
I think
retaining.
if you just kind of hit the highlights of those, unless
Sure.
unless a committee member has a specific that they need, and then we welcome elaboration.
Glad to. On slide 35, you've asked us a couple of times to update about recruiting and retaining staff at Larned. We updated the vacancy rates for the last pay period in September. That was complete. So you can see the trend is going in the right direction. We've had some good success in hiring direct care staff. Some nursing recruiting has gone well. The numbers don't tend to show that out. There's a lot of work being done at Larned. In the following slides, 36 and 37, there's a number of items there that I call your attention to. Maybe one in particular, we renewed our contract with KSN to help us with some advertising, not just in the Larned Pawnee County area, but pretty much all of Western Kansas, or the service area for Larned, to recruit and retain and attract folks to work at Larned State Hospital. We also included the holdover chart, or the mandate chart, on slide 38, which tries to show how many times in a day a nurse or somebody's required to hold over to the next shift. The trend is going in the right direction, although I'd say we took a little bit of a step backwards over the summer as we had COVID cases and just other issues, but I think the overall trend's in the right direction. Then the last item is about the lifting moratorium at Osawatomie State Hospital. I repeated a couple slides from last time, just again for the context of the money that you have all appropriated for us to be able to lift the moratorium in the coming year, with building regional beds that we've talked about. And that's all proceeding. Slide 41 is where it kind of comes dollars to donuts. So we've started the construction, not the construction project, a lot of the planning that's required to update the Biddle building for an additional certified unit. We've interviewed contractors and we'll proceed with that as we're moving forward. The other part is because we're moving people into a new unit that we were using as a COVID isolation unit. We've got to address the staffing there, hiring people and then getting them moved around. And we're beginning to work on that. We listed the vacancy rates for the types of positions that we need to recruit. It's a challenge. I don't tell you about workforce. You've heard that before. And we've got issues at Osawatomie as well that we need to address. And we're working on that, knowing that we need to hit the deadline of May to raise lift the moratorium. Again, there's a lot of efforts going on in the regional beds and the SIA policy that Commissioner Brown talked to you about already. But for our part of Osawatomie, we're well on the way of using the money appropriated for the building work that we need to do, that work, renovation, remodeling, and the staffing that we need to be working on. And I feel really good about where we are, even in the midst of the pandemic and having issues around that, keeping the team focused on where we need to be so that we can raise the moratorium, lift the moratorium.
Scott, on the certified beds, are we paid from the beds on the certified or just the licensed?
We're paid from the beds on their Medicaid beds. So
okay.
Draw Medicaid, yes.
I couldn't remember. Any other questions, Scott? Did anyone have anything specific that they had issues on with the hospitals that means we had him kind of rush over the top of that? All right, you did a great job. Thank you so very much.
We only say that if it's after 5.
Oh. Well, we weren't scheduled to adjourn until after 5:30, so we're still okay.
Secretary, I don't Secretary had some closing comments for our part.
Back cleanup. All right.
I don't have anything specific additional to add, but if the committee has any further questions, I think the only thing I just would say is I hope you can see just the breadth of continued effort, not just on COVID, but on trying to advance other initiatives forward. And we will certainly get back with you on the information that you requested. And Madam Chair, I'll own the piece about not having communicated on the HCBS education issue. I think from my perspective, it seemed like the right thing to do for kids in the interim. And frankly, we thought that given the level of national attention on this across the states, that there would have been some guidance from the federal government a long time ago that I probably should have learned many years ago that doesn't happen quickly sometimes, even in a crisis. But I'm happy to answer any more questions, and we appreciate the chance to be in front of the community.
Questions for the Secretary, Representative Ballard?
Just briefly, I think Senator Meyer had asked had asked a question. I think of the Secretary. Was there anything else that you needed? And I think he indicated it was another position that he was going to fill and everything else. So I guess my overall question would be, how are you feeling about this process and all the pieces that we have had to put together, having never gone through this type of problem before?
In terms of COVID response, no, it's obviously been a huge learning experience. And, one of the pieces that I think that it's probably maybe been one of the biggest learning experiences for us. I mean, it reflects right in all of these conversations around long-term care. We sort of sit here as the survey agency, right? And yet, long-term care is different. It's different than hospitals. It's different than other pieces. And I think the learnings that I've had over time is just the need for us at the KDAD side to have more program capacity related to the nursing facility side of the equation. Scott sits there, with survey and certification, right? It's a specific regulatory function, but maybe unlike our community-based programs or our behavioral health programs, over the years, that capacity within the agency on the program side, who's that program lead on nursing facilities? Who's that program lead? We don't really have that in our agency. So we've been having a lot of conversations about, just how this has kind of pulled back that curtain. I think we recognized it early on, but it wasn't necessarily our highest priority. And so I think we've really had to scramble because of that gap. So in the same way that your Secretary Norman talked about a couple of needs, I think for us, it's really filling in that gap and really having that program expertise on the nursing facility side outside of just the survey and regulation work we do.
Very nice. Thank you very much.
Any further comments, committee? All right, seeing that, I appreciate what you brought before us, and I'm not saying that you made the wrong decision. It was just a shock decision for us to hear about it today when we're trying to figure things out. So we're not saying you made the wrong decision.
Thank you.
Thank you very much. All right, committee, now we've got 3 people that are holding us up. Love y'all, really. No, I apologize. We did so good earlier, and then we got off track. All right, now we're going to have our MCO presentations. And first up is David Livingston with Aetna. Welcome to committee, David.
Thank you.
You're done? All right, thank you.
CEO of Aetna Better Health. There will only be 2 holding us up. So I'll be really brief. In this presentation, really it's focused on things we're doing during COVID. And I think slide number 5, if you want to jump to that, this just kind of puts some numbers behind it. So since this has started, we have done over 5,300 COVID tests for our members. And over 6,500 instances of care related to COVID provided excluding testing. So that could be, if someone has COVID, that could be multiple lab tests, so it's like encounters, but we've done a lot of services. Our care coordination team has done over 4,600 calls specifically to support these members who have COVID. And then, we talked about telehealth quite a bit today. Since March, we've had over 130,000 telemedicine visits. Some of these are video, some of them are via telephone, primarily focused in the areas of behavioral health, primary care, and specialty. And these were not just all COVID, obviously, but certainly it's changing the landscape in Kansas, and we're excited to work with KDHE, KDADS, and as this evolves. And just as there's a couple more member success stories that you can read, certainly follow up with questions, but I really do want to pause for a moment. And we've talked a lot about collaboration in this room, but we really do need to recognize the providers of care out in the market, the ones who are on the front line. They're the real heroes in this, out every day, face to face with our members, patients, the citizens of the state. Just really wanted to thank them. With that, I'll wrap up.
All right, committee questions for David? Representative McCann. No, you're fine.
Thank you, Madam Chair.
I'm just kidding about us having to rush it.
Okay, well, thank you, Madam Chair. First of all, I just want to commend you for continuing improvement. Yeah, I beat up on you pretty bad at the beginning, so I have to give compliments when I can. I've got a question I'm going to ask all three. In our special committee on foster care, the thought has been brought up a couple of times about having all of the foster care Medicaid under one MCO. And I'm just wondering from each of you what you think of that idea, how it might impact you, and whether you're supportive of it or not. Thank you.
That's a tough question to ask up here. To answer, I've seen states, there are states that have done both ways. Some have it with one, others have it with multiple, and we have been in a few states, the sole source fosters in some of our states. I think it's definitely, there's pros, cons. There's member choice issues, but I think there's also advantages to having expertise. So I'm giving a very non-answer right now.
Yeah, I could have put you on the spot. If you want to think about it.
Happy to think about that and be involved in those discussions.
Thank you.
Any further questions? I might just make note, he told one of the success stories earlier today, but there's also some other success stories that they've had trying to get through this COVID. So I just want to make the committee members aware of that if you want to look through the testimony. Thank you very much, David. We appreciate it.
Thanks.
Next, we have Michael Stevens with Sunflower Health.
Thank you, Madam Chairman. My packet looks like this. I have 16 very pretty slides I was really looking forward to talking about, so I'll do that to my windshield on the way home.
No, you can go ahead and do it.
No. I would like to draw your attention to just two things. One, we have shared a mission moment or a member success story. I think it was particularly gratifying to get this thank you letter from a member when so many people have been adversely affected by COVID and have lost jobs. We had a disabled member who, in working with our case manager, was able to buy herself over the last 18 months a new handicap accessible van and her first home, and was able to do this through a supportive work environment that we've been able to help her with. And this is her letter of thanks that she sent us, her excitement of doing it. She says it's the biggest accomplishment of her life to be able to do this for one of our disabled members, and we were extremely happy to be able to play a small part in that. The last thing I would bring to your attention is, as we've had a lot of conversations today about PPE and the difficulty of getting them, we saw that as an opportunity for us to step in early on, and we're able to donate 435,000 masks, boxes and boxes of gloves to HCBS providers, to Centers for Independent Living, and to area agencies on aging who also shared with local nursing homes. These were folks that really needed to be able to have access to these, and were finding it very difficult. and still do in many instances. And so this was one of the things that we did to help. We are grateful for this opportunity to serve and for the collaboration we've had, again, with the other MCOs along with the state during this time.
Committee questions?
Regarding foster care, we're in multiple markets across the country, some in which we are the exclusive provider, some in which we are a preferred provider, where members have a choice but are encouraged to select a preferred provider. And I will waffle just as David did, that there are definitely pros and cons. It seems that while there may be the advantage of having expertise by concentrating it all in one, it often causes people to feel frustrated that they don't have a choice and that there is less accountability when there's only one rather than three competing.
Right, anyone else with questions? Thank you very much, and we appreciate you, sharing the stories. I've told some of my colleagues over the last few years as they talk about whether it's, negative on the MCOs or whatever, is that the enhanced benefits and services that are provided by our MCOs is not something that ever happened under the old Medicaid system, and it probably could not and would not happen under. So we appreciate hearing these types of stories. So thanks for sharing. Okay, last but not least, we have Kevin Sparks with United Healthcare. Welcome to committee.
Madam Chair, members of the committee, is it okay to take your jackets off? I know you're going to be here for a while, so. Okay.
You can take your mask, if you'll take your mask off, if you feel comfortable, so.
Oh, yeah, no, that's fine. Slide deck looks like this. The slide after the nice picture of Terry Kynes. We have a COVID update. And on the COVID update, we have a dashboard. And I just want to update you on the dashboard, first of all. On the bottom left, it says 241 members were positive COVID tests, which is up from 108 reported last quarter. Next to that, we have 135 inpatient admission with positive COVID tests. That's up from 39 reported at the last Bethel. 169 long-term nursing facility members with positive COVID tests. Last time we reported 10, but that was skilled nursing facilities, and so we broadened that a little bit. And so if you were tracking against the last report, you couldn't get there. We've had 12,814 long-term care member safety checks since last Bethel. Currently, we are not safety checking any longer except for our quarterly outreach to long-term care members. But I did want you to know that we did another 12,000. With respect to member stories, I put one on the second to last slide. We have a member success story on there for you to read at your leisure. And then to address foster care. I think last time I checked, there were 7,200 kids in foster care. I think that is too small of a population to carve out. Because I know that there was a bill, I think last year, the year before, where there was a carve out for one MCO to bid on that. And I think what was mentioned earlier, it is a complex question, but I guess the simple answer comes down to choice and choice for families, and that's probably where I would err.
Thank you.
Many members, other questions? Representative Ballard.
Actually, Madam Chair, I really don't have a question, but and looking at all three of these and the stories, I just want to comment too, that it's very interesting and something that I will keep. It's something that I think if I'm doing a forum or if I'm just talking to a group, it's always nice to tell them the positive stuff because they know all the negative that's out there. And I see this in the donations as well as the stories. And these are things that people live with every day. People talk about kitchen table items. These are just things that people live with. And of all the reports I've seen for many, many years, this has the compassion knowledge, it has the numbers, and it has what all three MCOs are doing to benefit people. And I thank you very much for this.
Thank you, Representative Ballard, and on behalf of my two colleagues, we used the opportunity for COVID to come together and work better with the state. And you know, I know it's a positive thing that comes out of the pandemic. Not many of those things probably do, but that is one that has.
Well, and one of the things as I was talking to some other folks earlier today is, you know, everyone that's in this room and some that are listening and our MCOs is when the time comes next session and we've got to really look at, okay, what do we need to tweak and change and improve on our telemedicine, et cetera, is be prepared to bring us those plans because we're not the experts, but we're definitely the ones that will.
Absolutely appreciate that. And every meeting we have with providers at this point in time, we've been asking them.
All right, thank you. Appreciate very much you being here today. All right, committee, that will conclude our hearing and conferees that we have today. You do have before you the minutes from the June meeting. If we can get a motion to approve those. Motion by Representative Buchanan, seconded by Representative Ballard. Who do we have on that? Well, then I guess we're not going to approve anything because we don't have a quorum. We stuck through it, but the little Zoom people left us. All right. So I want to appreciate everybody, and I apologize for us getting off track. It always seems like there's something that kind of pops up for us that needs a little bit further discussion. And appreciate our MCOs and their willingness to sit and wait through all of this for us. So we are adjourned until next time.